Good morning to everybody. Thank you so much for coming. I'll go ahead and get started so I can hand it over to Miss Judy. I'm just going to introduce myself. My name is Natalie Arrington. I'm an employee at Center for Prevention Services out in Charlotte. And I am also a member of Rowan County's post-overdose response team and a member and the harm reduction advocate on that team. I'm sorry, I got cotton in my mouth this morning. So I'm going to actually pass the forum over to Judy so she can do our official opening. And thank you so much to everybody that's coming. I just wanted to say that. And if for folks, there'll be folks floating in and out. And if you do happen to need the lead, that's okay. This event will be recorded, so you'll be able to see it later on if you'd like. All right, so Judy, you go ahead and take it away. I'm going on mute. You're on mute, ma'am.
Here we go. That is one of the dangers of this event. So thank you, Natalie. Good morning. I'm Judy Klusman, Rowan County Commissioner. I'm part of Healthy Rowan and the post-overdose recovery team. And we are just so thrilled that you are here today for our annual. We hope it will continue to be annual and not pandemic interrupted forum on substance use disorder. This really is a disease, and we've got a long way to educate our community on the fact that addiction is not a choice, that it shouldn't be a stigma. You know, cancer, just talking about the big C word, used to be one of those things you did not want to do in public. And now it's very common that we do talk about cancer and we talk about disease with it. And I'm hoping that we can get there when it comes to substance abuse and neglect and addiction. Addiction is a disease, and we all know that, and probably many of us have people in our families or people that we know that really struggle with this disease. But through hopefully this education forum, you can get ideas to do referrals and to help those you love. So with that, I will turn it back to Natalie and we can start our forum. Thank you.
Thank you, Judy. Thank you. There's more folks floating in. To everybody that is attending right now. And again, if you are not able to stay, I recognize some names here, and I know you guys have pretty large roles. It's completely okay. This event will be recorded. It will be available on YouTube, and it also will be available on our Port webpage. I will drop the link for the Port webpage in the chat at some point during this meeting, so you'll be able to access that and see the information that we have available on there. I have if you have your agendas, I emailed that to everybody because I wasn't exactly sure how to operate the Eventbrite settings to attach it into that. So I emailed it to you, and you should have that. Our first speaker will be Scott Lucano. I apologize to him in advance if I have not pronounced his last name correctly. But he'll be talking in detail about some of the preliminary information about substance use, and then we'll go into detail about some information about CRM. If you haven't heard of CRM before, CRM stands for the Community Resiliency Model. It is a holistic approach to dealing with trauma and traumatic events, and assisting people with recovering from those, whether it be for substance use, a variety of experiences. And actually there'll be Judy and Kelsey Silva Disla will be doing that presentation. So I'm not going to talk about it too hard, but our presentation for from Scott is on the agenda, won't start until 9:30. So this is a great time If you have any questions, also please feel free to use the chat. So if you have questions for our, we'll have a lunch and learn later on. So that's an opportunity for you to interact. Please drop questions in the chat now, and I can get those over to the folks that'll be speaking. If you have questions throughout any of these presentations, please use the chat. Do not hesitate. I'm trying to make sure I'm not missing anything. If you want to take this time to kind of use the restroom, gather your thoughts, answer some emails, I spoke to Scott this morning, and I don't think he'll be starting until 9:30 on the dot. So I did leave some wiggle room into the forum, so that if you do have any things that you need to take care of during the event, you can float in and out and do those things. I didn't want this to be a virtual event where we're all glued to our screens the entire day. I think that is very boring from my personal experience. So please, let's have conversation, let's talk, ask questions, chime in, any thoughts or ideas that you have, or anything that you feel like you're doing in your community that will be a benefit to folks in other communities. We love to hear it. This is not in webinar format, so you are welcome to unmute yourself. Just raise your hand first. Raise your hand so that the speakers during that time can call attention to you, and you can speak and share your thoughts. If you're not comfortable with that, the chat is always open. I'm going to give everyone just a few seconds, because again, Scott is not going to be starting with us until 9:30, because I had the agenda set up to where the intro will be to 9:15. So yes, there is a little break period in between the presentations.
Natalie, I forgot to tell you, I give very short introduction.
I'm trying to build the time. I'm so sorry. It's okay though. I'm trying to work.
Or Commissioner Klusman, would you mind reflecting? So is this our fourth substance use forum? And so we started this in 2017. I feel like you've been a part of this the entire time.
Did we lose you, Alyssa? Oh. Thank you, Alyssa. I appreciate that very much. We have come a long way, and I'm particularly pleased where we are this year, because I think for the first couple of forums, well, the first one we just had a really incredible speaker, and I remember he's an author also, and wrote about how and who really started the opium epidemic. And that was just fabulous. And we had a really good attendance. And each of those forums really focused more on numbers and data. And what I'm excited about this year is that we are all about more of an interactive program. And it's like Natalie said, you know, we want you to go away with things that you can act on. I think that's a good way to describe it. But it's always good to get together with colleagues, people that are doing the same thing across our county that we don't know about. And because of that, that's one of the values of this particular forum. Alyssa, can you think of anything else? I feel like I'm missing things.
No, that's perfect. So my name is Alyssa Harris. I'm the health director here in Rowan County. And I was just sitting here thinking I'll be closing us out today. But as Commissioner Klusman was talking, I was thinking through, you know, the transition of this event has gone from, like she said, the more data heavy, hey, this is what's happening in our community, to this understanding of it's not just focused on opioids. It's focused on all substances. And then it's not just focused on the data piece. It's focused on how can we take this information and do something with it. And that is what I am so thrilled about. And I think that's why, your opening was so wonderful, is it's that focus on resiliency. It's on addressing the trauma. It's healing the soil. It's figuring out how do we build a better community through the opportunities that we have, like the Substance Use Forum, where we are fighting the stigma and getting that information out to the public. And so we appreciate your time and joining us and being a part of this conversation, because it can't just be us, it can't just be one or two people. It has to be every single person in our community taking the opportunity to talk about it, because it affects all of us. Every family or subsequent family has some sort of connection to substance use or addiction and recovery. So that's all I wanted to add.
Yeah, I think the other thing too is that we're trying to get a handle on who and what kind of service that we do have in our county and surrounding counties, because we don't want to duplicate. But one of the things that we've come to realize is that we do need a short-term detox center. So people, instead of detoxing in jail, can go to a facility that's dedicated 100% to detoxing and have specialists there that are trained to deal with people that are detoxing. And then they can go on and do what they need to do as a citizen and according to the crime that they have committed. But they don't need to do that detox in the jail. The other thing that I'm really hopeful for when we talk about our police and sheriff's office is that sometime soon we can implement the program, and I forget what it's called, but I want to call it ride along, but that's not what it is. But to have a social worker that is trained, that they can go out when the police call and say, we have someone that is mentally ill that needs to be incarcerated, but instead of bringing them to jail, we want you to come and help us get them into treatment first. Natalie or Alyssa?
I actually see a message from Jason Jackson about the co-responder program. Jason, would you mind elaborating on that? I'm sorry if I called you out.
You're fine. I was just wanted to say that because she said she couldn't remember the name of the program. In Pitt County, we do have a co-responder program. By the way, my name is Jason Jackson. I work with the Pitt County Sheriff's Office. I'm in charge of programs in the detention center. We have the Sharp and Aware program. They focus on substance use for individuals who come into the jail with drug-related charges, or if they come in intoxicated or things like that. We address those issues while they're here and try and give them what they need so when they get out in hopes to reduce recidivism. A program we did just add on to our belts is the co-responder program, which offers 2 clinicians for the sheriff's office, and it offers 2 clinicians for the municipal police department. And anytime they encounter an individual in the community who seems to be either under the influence, or if they have mental health issues or something of that nature, where they, as she was speaking on, something where they may need treatment versus arrest, the co-responder program tries to address that on the scene. So when they arrive on scene, the co-responder will be contacted. They'll come out and they'll try and deal with that individual right there versus just arresting them and bringing them to jail. So that's kind of what we've been working on, and that's why I just wanted to add that in there, because that's the program I believe that she was talking about right there.
Yes, let's see if I can see. Yes. Oh, I'm so glad you added that, Jason. What county are you from again?
I'm sorry, Pitt County. Pitt. Yes.
Okay. Well, that's terrific, because I know that I'm involved with our North Carolina Association of County Commissioners, and I know there's quite a few counties that are working on a program like that. So you can expect a phone call and perhaps a visit, because we do need to learn what other counties are already doing.
And actually, I see a lot of people, I see some familiar faces, but a lot of unfamiliar faces and names. So would everybody in the chat be willing to drop in the chat what counties they're representing, what agencies they're representing, so we can get an idea of who's here. And then if you all want to connect with each other, please just reach out, exchange emails, so that we can continue to build a partnership with one another and exchange ideas, so that each of our communities can grow and just learn from one another. So what counties is everyone from? Cabarrus, Sherry Neely. Hey, Sherry, how are you?
I'm good. Sorry, I was on mute.
Oh, no, you're fine. Hi, Erica. Hi, thank you from Union County. Hello. Hello, Karen. South Jones from Wise Up.
Natalie, at the end of the event, is it possible, if folks would like, that we can send out who attended?
Yes, I can do that.
That contact, because oftentimes I feel like with any forum, you have this really great momentum and energy that happens at the forum, and then it kind of drops off. So it's such a wonderful opportunity if we can continue the conversation and really figure out how do we have this more regional network and approach, and know those folks who are across county lines, because we know our people don't stay within the county lines. They come and go everywhere. So we do want to make sure we build that.
Absolutely, I can do that. See, Iredell County, Pitt County, Cabarrus. Okay, Rowan, of course. Okay. Thank you all for coming.
This is really great, because I don't think we've had visitors from other counties attend the forum before, because we only did it in person, and it's a long way to drive. So maybe what we can do is a blended program from now on, so people from other parts of the state can join in.
I really like that idea. That's fantastic, because like you said, it's getting everybody together.
And I'm just reading. Thank you all so much for coming. And let me see. I was actually trying to see if our next presenter would be in. He hasn't came in quite yet. But York County, okay. Thank you so much for coming. You didn't come anywhere, but thank you for tuning in. I gotta get used to this virtual stuff, man. Scott is awesome. He's so cool. He's very helpful. He helped me with get this forum together, and so we could talk. And actually, so Scott did just come in. Thank you, Scott, for coming in. We're gonna take a few minutes. So if everybody wants to grab coffee, run to the bathroom, we're going to be in presentation mode for the next hour or so. So go ahead and get your bearings so that we can sit down and kind of listen and chat with one another for the next about an hour and a half for the next break.
Hey, Natalie, Karen South Jones has her hand raised.
I'm sorry. Go ahead, Karen. I can't see it. Go ahead.
No, well, thank you. Thanks, Courtney. I was just gonna, since we had a few minutes here, was just gonna add a couple of things. At our first forum, we had Sam Quinones, who wrote the book Dreamland, to come in and speak. And Sam has written another book, which will be released in, I think, early November, maybe late October. And it is The Least of Us, True Tales of America and Hope in the Time of Fentanyl and Meth. I was able to get my hands on an advanced reader copy of that, and it is very good, and it also provides a perspective on fentanyl, meth, as well as additional information about just the general opioid crisis. We're working with he and his publicist to see if we can arrange a lunch and learn or something, or a book signing, either virtual or in person if his schedule allows. So I will keep this group informed about that if they are interested in participating in that. The other thing, and this is for Rowan County people, just to kind of put this on your radar, since we're all focused on substance use prevention, Salisbury, the city of Salisbury is considering adopting a social district for the downtown area, which would allow for outside consumption of alcoholic beverages. And it would be within certain parameters. And the state legislature gave municipalities the authority to do this. Kannapolis has already done it, and several other jurisdictions. But I just wanted to put that out there. Wise Up hopes to be at the table as those discussions and decisions are being made on recommendations to City Council for what Salisbury Social District would look like. But we feel very passionately that we need to balance the needs to enhance our business district and business owners with sending messages of prevention, and that we are not inadvertently sending the message that which all too often is the case, that the way to have a good time is to consume alcohol. And young people are absorbing that message, and they are drinking early and they're binge drinking. And so just, if you guys, just can keep that on your radar, and if you have any feelings or opinions about that, to share them with council members and folks on Downtown Salisbury Inc. as they go through this process. We're hopeful that Wise Up as a substance use prevention coalition will be able to be around the table. Getting a little bit of pushback on that from the group right now, but anyway, I just wanted to let you guys know. Thank you.
Thank you for sharing that. And again, I will provide everyone, just give the list of all the attendees so that you can be able to stay in contact with one another and continue that conversation.
I just wanted to say thank you, Karen, for mentioning that. It is a topic of discussion with Downtown Salisbury Inc., DSI, which I serve on. Of course, they are a big proponent of that and propose that particular ordinance. I think they're looking at, when we have, especially when we have events at Bell Tower Green. If you haven't been to Bell Tower Green, I'll give them a plug. I was there on Sunday, and there had to be over 100 people there, and they were all ages, from really elderly to our little ones who were playing in the water. And the playground was full, and there was a soccer game going on, and so it's a wonderful, wonderful place for the community and visitors to come and experience Salisbury, the downtown part. And I say it's now the heart of downtown Salisbury.
I actually took my office out to the Bell Tower Park on Tuesday and was there for an hour, and it was fantastic. I was supervising the ladies as they enjoyed walking around because it is gorgeous. The weather was fantastic. So definitely come out and enjoy.
Another alternative.
Well, Natalie, I'm going to take you up on jumping off to get coffee, and I'll be back right at 9:30 for our speaker.
Thank you. Anybody else that needs to go ahead and do a bathroom break, I might need to do the same. I'm going to go ahead and go to the bathroom. So anybody else? We'll see you back at 9:30. Okay, so it looks like everybody's coming in. I'm going to go ahead and give Scott his formal introduction so he can get started. Scott, please let me pronounce your last name for me so I'm not butchering it during your intro.
It's like Lutgenow, like root canal.
Lutgenow. Okay. Scott Lutgenow is a social worker and licensed clinical addiction specialist who created GateSpring Consulting to positively impact the field and the individuals, families, and communities they serve. Through compassion, clarity, and energized instruction, he uses his clinical experience in opioid addiction treatment, recovery advocacy, and community coalition building to assist individuals and organizations nationwide through SAMHSA's Opioid Response Network. Lutgenow formerly served as Deputy Director for Addiction Professionals of North Carolina and as the Vice Chair of the North Carolina Association for the Treatment of Opioid Dependence. He previously served as Director for a large nonprofit opioid treatment program in Raleigh, North Carolina, serving over 600 individuals with severe opioid use disorders and complicated challenges around comorbidities and social determinants of health. So everyone, Scott Lutgenow.
Excellent. All right. Well, thank you so much, Natalie. It's wonderful to be here this morning. Can everyone see my title slide?
Thank you for calling SNH Youth and Adult Services. This is Ms. Hart.
All right, somebody's on the job. That's how it goes, right? So good morning. I just want to start out by thanking Natalie for arranging this. This is really a fantastic event, sophisticated sort of subject on that's on a lot of our minds right now, right? And of course, the Opioid Response Network through SAMHSA is what made it possible for me to speak this morning. So I'm just going to talk very quickly about that because it's a resource that I think is underutilized. And it's a free resource available to all of us. And what I'll say is the Opioid Response Network, which is right here, was funded through SAMHSA. It started with the STR funds, the state targeted response funds, the SOR funds as well. And the website is opioidresponsenetwork.org. And you see at the top right-hand corner, there's submit a request. Just very quickly, I'll talk about what that looks like. So some obligatory slides from SAMHSA here, right? So we're addressing with communities to address the opioid crisis, stimulants as well. I think I heard somebody talking about Sam Quinones' new publication that touches on methamphetamines as well. And very excited to read that. That's news to me, very cool. This is how you get in contact with us, right? You could email us at ORN, or you could even call this number. I highly request just submitting a request through the actual website. It takes about 10 minutes and somebody will contact you within 48 business hours to talk about your request and then match you with consultation, either locally, if they have sort of local capacity that's a specialty and what you're looking for, or we'll look nationwide if we need to. And of course, it's made possible through SAMHSA, again. And we're trying to spread the knowledge about innovations and different evidence-based practices across the continuum of care, right? So prevention, recovery, harm reduction services, things like that. So what are we talking about today? Like, what's the reason that we're here today? And I stole this slide from a gentleman named Dr. Kevin McCauley. Some of you might be familiar with Memo to Self. He's come out with a couple of documentaries on addiction. He was a flight surgeon who experienced some addiction issues, and he has sort of devoted his life to advocacy and making sure that people sort of understand the complete nature of addiction, right? Because if we don't understand it, we can't treat it or prevent it or help people recover from it. Natalie, can you tell me how long do I have this? Do I have an hour till 9:30 or till 10:30?
Yes.
Excellent. Okay, good. All right, so why is this the most evil disease imaginable? So Dr. Kevin McCauley said if Dr. Evil from Austin Powers were to come up with a disease, it would be addiction. And why? Why is that, right? There's a big argument whether it's a disease or at all, right? We can't even really decide on that among many of us. It's genetic. but with variable penetrance. So for instance, I struggled with addiction issues. So October 19th, in a few days, will be 10 years of long-term recovery for me. My father did not struggle with addiction issues. His father did, right? And so there seems to be no rhyme or reason sometimes. And then sometimes it really follows family lines, this intergenerational cycle of addiction trauma. Repulsive symptoms that are easily confused with willful badness, right? It looks like folks are willfully doing these things that are seemingly baffling to many of us who don't really know any better. And then self-deception is a clinical feature. That's what makes this different as well, right? So when myself, if I had a compound fracture, if I was skiing or something, there's no question about whether I need medical care or not, right? That's different with addiction, because we have a hard time sometimes talking the individual who's struggling with the actual addiction into the fact that they're having an issue. Poor prognosis in many if untreated, like we're seeing swaths of individuals live and die based on funding and treatment availability. I've seen it with my own eyes. I know probably many of us have, right? And so poor prognosis in many if untreated, others just get better spontaneously, right? So we saw the largest study on recovery to date that was done a few years ago by Dr. John Kelly from Harvard. And it told us some interesting things. And that was that most of the people that identify as being in long-term recovery did it spontaneously on their own. So we still have a lot to learn, clearly, about recovery, prevention, treatment, the whole gambit. Chronic and relapsing, right? And so we've taken this approach, and I don't think I have to tell anyone here, we've taken this acute care model approach to a problem that is very not acute. This is something that sort of sticks with us. And so my past addiction is just an indicator that I could struggle with addiction in the future, right? And so what we see is a total dearth of recovery support services. So whereas my father, who was diagnosed with pancreatic cancer, got wonderful innovative care at Duke, went for checkups every 3 months, every 6 months. This has been 10 years ago now, and he's still going for checkups at Duke. What happens when an individual enters into recovery, and what are the same things that we're doing to make sure that we're keeping that individual in recovery? We got a lot of problems in our field. So culturally and politically divisive, right? We have so many sort of values that are wrapped up in this idea of free will, or this idea if we don't like the sort of situation that we're in, we just simply need to try a little bit harder. This is the land of the free, the home of the brave, and all we need to do is try, and there's opportunity for everyone. Well, you know, we've been learning a lot the past few years about how that's not so, about how we have different rows at life. There's marginalized populations that we couldn't possibly imagine what they're going through, right? But we're starting to learn more now. We're starting to learn more about how to help people as opposed to alienate them by not understanding what they're going through, or the medical nature of their diagnosis, right? And then it only submits sometimes to weird solutions like peer support, spiritual growth, things like that. And so it can be a bit of a confounding thing, right? It's a bit confusing. So you have to give a little bit of understanding to folks that don't know any better. There was a point in time where I didn't know any better. Okay. So addiction, how big is the problem? It's huge, right? So 16% have of the population have this disease of addiction, more than heart conditions, diabetes, cancer. Think about how we treat and think about those illnesses and those diseases as compared to addiction, right? And 31%, while not addicted, engage in addictive substances in ways that threaten health and public safety. And believe it or not, that 31% is not made up fully of college population, although we see a lot of that normalization. I know we talked, I've heard a couple of people talking about sort of the drinking aspect and how that's normalized. Well, that's not the only thing that's being normalized, right? And one thing that I started to understand is that when I was at NC State University, going back to school to get my MSW, get my DSW, they did not have a collegiate recovery program. And so we went to get that started up over there. And what occurred to me is that folks were getting into recovery in a very early age, at a much earlier age than we had sort of seen previously. Well, what do I mean to say by that? Seeing individuals that became addicted to opioids through access through their grandmother's cabinet or whatever that is, right? And then quickly going down that road and then getting into recovery, like going into treatment, getting into recovery 17, 18 years old. Pretty remarkable stuff. Contributes to a range of other social consequences requiring medical care. We have gone to pay for the consequences of addiction as opposed to paying for the prevention and the treatment of addiction, right? We've done that for a little while now. We've seen the results. The results are clear. We don't spend nearly enough on treating addiction. And we sort of fight amongst ourselves in the continuum of care about who gets money and what resources. Well, really, we all need money and resources because each part of our continuum of care is absolutely critical. You know what I mean? So this is just a little bit of a look at what we pay versus what we get, right? And so 96 cents of every dollar spent by federal and state governments on substance use and addiction go to pay for the consequences, and only 2 cents go to pay for prevention and treatment, to put things into perspective. So we shouldn't fight amongst ourselves, right? We should fight for ourselves. And this is what's happening now. You know, heroin, opioids killing an American every 16 minutes. These sorts of headlines and statistics have become normal to us, have they not? Right? We've become numb to these things, whereas first they were absolutely shocking. Numbers like this, figures like this, this will be the 4th or 5th year in a row where we've had more Americans die by overdose than died accumulatively throughout the entire Vietnam War, the casualties. So think about the abject disaster that the Vietnam War was, and this is what we're dealing with every year. And then I'd be remiss to say how many people are dying from cigarettes and alcohol. Still many, many, many more people, right? And so this is a big issue. This is a big ball of yarn. And we know that overprescribing was one piece of this problem, right? At one point, 25% of counties in the United States had more opioid prescriptions than people. It's 25 out of 100 counties in the United States had more opioid prescriptions than population, right? And we know it's not just opioids. Again, it's benzos. Benzodiazepines are highly dangerous, right? The doctors for many years prescribed Xanax and still do for anxiety. It's not the first line defense for anxiety. This is very sort of staid and old stuff. And we've seen, good research come out that shows us that benzodiazepine use is linked to early onset dementia. Cocaine. Right, we've seen upticks in cocaine use in recent years. Not to mention we're seeing fentanyl and cocaine and cannabis. Cannabis is something that we need to be aware of. I don't think I have to tell our prevention folks that. Something to be aware of. I think if we want to tackle this issue of cannabis and legalization and getting less folks to jump into that mess, is to say, how do we keep them from needing to jump into that mess? What are they medicating with these substances? And we'll talk about that, right? And that sort of gives us entree into this idea of community wellness, trauma, recovery, all of the good stuff. And then designer drugs. We know that stuff's coming out that our legislative bodies can't even keep up with, right? We have very savvy suppliers who are changing a molecule and the chemical makeup of a substance, and we can't make it illegal quick enough to catch up with it. So kids are walking across the street from their university into bong and head shops and then buying these substances that are absolutely serious, So a lot of stuff has changed. And one thing that's changed is this whole thing around opioids. And we've seen 3 sort of major opioid epidemics in our country. And the first was the Civil War. And so we saw a lot of folks coming back, dismembered, horrible chronic injuries. They wanted to keep them comfortable. And so a lot of these folks became addicted to morphine, other short-acting opioids. And their wives did too. So this was like a really big sort of thing that happened early on in history. There was a lot of understanding around it, right? And then we saw this second wave that happened in the 60s and 70s in the greater New York City area, specifically Harlem, right? And then we saw how folks from marginalized populations, the Black population, the Latinx population, how they were treated when they then became addicted to these substances. And we tried to arrest our way out of that issue. And it's not a criminal justice problem, it's a public health catastrophe, right? And so we saw we saw the impact of that, right? Now we have this latest introduction, which has given us a lot of interesting, perplexing differences, right? And so what does this all come down to? And I know some of you are looking at the brain, you're like, oh my God, is he going to talk about the brain? And I'll talk about the brain for about 30 seconds to a minute, because I want to impress this point. This is what we've learned in the past 10 years about the brain science of addiction. And this is really important for all of us to understand, right? So practitioners, providers, street level bureaucrats, which, you know, goes back to that book in the 1980s that talks about folks that work with the public on a sort of intimate level, that have a lot of control and the sorts of services that they have access to versus those that they don't. So police officers understanding this information could do a world of difference, right? Practitioners, preventionists, all of us need to understand this information as folks that are working in some way with this population to try to help. Right. And so the midbrain, this is what we've learned in the past 15 years, this part of our brain that's responsible for our survival as a species. It's the part of our brain that it doesn't handle higher level reasoning or thought processes. It handles the intuitive, what happens before we have a chance to think about it. So if something comes into my periphery of vision, am I going to defend myself? The fight or flight sort of response. It's the part of our brain that if we're not watching TV, we don't see a pizza commercial, but we haven't eaten in a while, right? It's the part of our brain that says, eat, you're hungry. It's important to your survival to eat, right? It's the part of our brain that's responsible for sexual attraction, or this idea that we procreate as a species. Like, it's intimately linked to who we are and what we do. And it's all before we have a chance to process things. And what we have found is that individuals with addiction issues, many of them have experienced trauma at such high levels that their brain has repositioned the procurement and the use of these substances as the most important thing to their survival. So meanwhile, everyone in their sort of scope is looking at this person as, what in the world are they doing? Why would they spend their grocery money for their children on crack cocaine or heroin or whatever it is? And what we have learned is it makes absolute complete sense that they would do this. It's a stress-induced response before they have a chance to even process it. Now, I don't have time to really go down the rabbit hole in the brain stuff, but there's some other insidious things that happen inside of the brain that continue to solidify the addiction, that makes it critical that we take care of these folks with understanding and compassion, right? They're only doing what their brain has told them to do. And so, you know, it's also important to understand the power of dopamine, right? And so a lot of times I ask folks, what is dopamine? Everyone says it's the happy chemical. And it's not that. It's sort of tangentially that. It really has much more to do with feeling comfortable in your own skin. And it assigns, dopamine spikes in our brains assign importance to life events. Not just importance, but it assigns life enhancement and survival to certain things. And so a lot of us, we know now, don't have normally functioning dopamine receptors in our brains. And so for those of us who sort of struggle with that have abnormal brain structures, it's hard to feel comfortable in your own skin. And you can't really put a premium on feeling comfortable in your own skin, right? And so if you are perpetually sort of uncomfortable in your own skin, you have a hard time assigning things as being important to survival and things that are really adaptive and really supportive of your recovery and your sort of global health. But what happens is an individual tries a piece of chocolate cake. Look on the left-hand side of this graph. You have the 100% basal release. That's a normal basal release in a quote unquote normal brain. But that person eats a piece of chocolate cake and it spikes up a bit. And they're like, wow, this is pretty life important. I like grandma's chocolate cake. It's important to me, right? And then you see the person on the right, they try an amphetamine, a substance that's very similar to methamphetamine in the chemical makeup, okay? And then you see the spike there. It's like 1,000% increase. And so for the individual that has never felt comfortable in their own skin, and then they try a substance, this is why you can't understand why that individual is doing the things that they're doing. And then meanwhile, the brain is reworking this idea around what's important in life and what is not, right? And then this slide, and then we'll stop talking about brain stuff, I promise. But this slide explains to you why some folks try substances and they're like, what's the big deal? And some try substances and they're like, this is what I've been looking for my entire life, right? And so these two individuals tried a stimulant. The individual on top, you see that those sort of glowing reddish areas on the peripheries of the brain. That's dopamine response. That's a normal dopamine response in a person. And then you see the person at the bottom that has a very vague dopamine response. They have a hard time getting that in their brain just naturally. And this is just one issue our brains sort of predispose us toward addiction. Both of these individuals tried a stimulant. The individual that had naturally occurring dopamine production said, I don't like that, because their brain already has a state of homeostasis that's nice. But the individual on the bottom that tried that substance said that they loved it. It was a very pleasant response. And so that sort of explains the difference. I like Dr. Glenn Hansen's quote here: a person with this illness can no more stop their behavior than a Parkinson's patient can stop their shaking, right? And so the symptoms of substance use disorders look like bad behavior. And that sets us up for reacting as if these symptoms are personal attacks, right? Whether that be providers, professional providers, prevention specialists, law enforcement, like whatever that looks like. And let's see, here we go. And we know that there's wonderful treatment protocols for opioid use, specifically medication-assisted treatment. And so I'm going to spend 5-10 minutes talking about MAT because I think that we need to. I've experienced a lot, and when I was director of an opioid treatment program, I saw stigma, a lot of stigma from people in our own field, people I worked alongside, when it came to MAT. So what I'll show you is, the first thing I'll say is SAMHSA came out, I don't know, 10, 15 years ago and said, stop doing research on methadone. It's the most researched drug in history, literally. That's not hyperbole. And we know it is absolutely impactful and very powerful for a specific group, right? And we know buprenorphine is the same way. And we know some people respond extremely well to buprenorphine, whereas they don't respond well to methadone, vice versa. So we have this whole cadre of medications to treat severe opioid use disorders. I'm talking about individuals that come into treatment and have overdosed 2-3 times in the past 6 months, been brought back to life. This individual is life or death, right? And that's what this comes down to. That's what this treatment modality comes down to, is really life or death. And so this was the largest cohort, the largest treatment study ever done on MAT. And we have a long history of these studies saying the same stuff. Okay, and so this was done in England, a country about half the size of California. But what's remarkable about England and their public treatment is they keep remarkable records, and records and data that mean things, not just checking the box. So they had 150,000 participants with severe opioid use disorders in this study. That's a big study. And what they found is what many of us that worked in this modality of treatment already knew, and there was other research indicating Very similar statistics, right? If individuals with severe opioid use disorders enter into psychological treatment alone without the support of medication, they're twice as likely to die by overdose. Literally, that's the nutshell. An individual who goes into psychological treatment alone for an opioid use, a severe opioid use disorder, were twice as likely to die by overdose. They found in this study that individuals were less likely to die if they just continued using heroin as opposed to entering into psychological treatment alone. So what does that mean to say? Well, a lot of folks try to go into what would be considered abstinence-based treatment, and I'll say a little bit more about that. They sort of white knuckle it for a couple of weeks. It's not a tenable sort of solution for them, and they go back out and use. They become opioid intolerant, and then they overdose and die. And so we've seen this over and over and over and over again. Is this to say that every individual that has an opioid addiction needs a medication for it? Absolutely not. Every individual should have an option to it, right? And so what if I told you that your family or friend or your young daughter or son was diagnosed with a rare and deadly form of cancer, right? So you went to see a medical provider and you knew about this modality of treatment that could increase their chances of living by twice or more. And the doctor tells you instead to go to a series of meetings with other individuals who are suffering from the same diagnosis until you have a spiritual awakening. And through that process, you will find recovery. And I'm not poo-pooing mutual aid group meetings. They're lifesavers for so many people and a wonderful, wonderful, wonderful resource. It was a big resource for me, but it's one resource and it's not enough, clearly. If it was enough, it would be enough. And it's not. We need so many different approaches to this, right? And so what I see is a lot of misinformation and stigma that still perpetuates around this. So help me to dispel that. And we only have to look back into history to like the 1980s and 90s when NA groups and AA groups were proliferating information around, and these were just people in the groups, right? Just people with positive intent trying to do the right things, telling folks that psychiatric medications for depressive disorders or anxiety, non-narcotic medications were abandoning their recovery. So we have to understand that there's a lot of bad information out there. And as professionals, we are here to combat that information. Now, just one last point on this MAT piece. Treatment for opioid use disorder, medication-assisted treatment is considered the gold standard of care for severe opioid use disorders, right? And we know only about 20% of people with opioid use disorders receive any treatment whatsoever. Well, that's better than the 10% that receive addiction treatment overall for all substances. But it's not as good when you look at only a third of those, of that 20%, which is what, 6.67% or something like that, of those individuals are receiving access to this modality of care proven to extend life for individuals. This is the diagnostic criteria for an opioid use disorder. This is how we tell individuals whether or not they have this addiction, right? And it goes from mild, moderate to severe. And we know that MAT works when all of the diagnostic criteria disappear from that person's life. Yet we still have individuals that would argue that this is not a legitimate pathway to recovery. Now, the last piece on that is abstinence-based treatment. We often hear that as a counterpoint to medication-assisted treatment. Medication-assisted treatment is abstinence-based treatment if that individual is adhering to their treatment protocols. When a person is taking their treatment medication as prescribed, and we go through great lengths to make sure that they're taking it as prescribed, to the point in opiate treatment programs where we're watching that individual take the medication every day by a licensed professional nurse and then checking their mouth to make sure they're not diverting the medication. Like we take it, it's very serious. But we know that when all the diagnostic criteria disappear from that person's life, you need to tell me how I can't tell that person that they're not in recovery. that they're not abstinent from illicit substances when they are a lot abstinent from illicit substances, when they're a mother again to their child, when they go back to work. This is all the stuff we have to do in an OTP before we give a person a medication that they could misuse, ostensibly, purportedly. It's a laundry list. More auditing bodies than NASA. And this is our problem, right? Mark Twain says, to a man with a hammer, everything looks like a nail. Well, all of us across the continuum in a lot of ways have been doing sort of business as usual. Well, everything has changed. And then COVID happened. And then it changed in ways that we could never have fathomed. We were already a broken system of care prior to COVID. Can I get an agreement to that? We were already a broken system of care. And there's so many costs to stigma. We see people dying. This is Joe Thompson, who was told by a treatment facility that using medication-assisted treatment for his opioid use disorder was simply trading one drug for another. Again, people getting kicked out of treatment for exhibiting symptoms of the illness that we have diagnosed them with, and going off to die. I wish I had more time to talk about these stories. 70% of all adults in the United States have experienced trauma, and of those adults, 20% will develop PTSD, right? And so the opioid treatment program that I worked in, Southlight Healthcare in Raleigh, North Carolina, they're a nonprofit that's been open. They just celebrated their 50th year anniversary. They started as a medication-assisted treatment facility 50 years ago. That's pretty remarkable, cutting edge. Out of those 600 plus individuals, every single one of them had had a traumatic experience. That is not hyperbole either. Every single one of them. Were they all diagnosable with PTSD? Not all of them, but most of them. Many of the individuals started using opioids because of the trauma. Many individuals experienced trauma during the opioid use, or they experienced trauma when trying to get help for their opioid addiction. And we know that stuff got really real last year with COVID, right? During late June of last year, we saw 40% of US adults reporting struggling with mental health and substance use. And as a society in America, we're not great at disclosing our issues with what happens in between our ears. And I would venture to say that these numbers are likely much, much higher. Right? And then we have this emerging consequences of this pandemic. 1 million reported deaths in less than a year. Do you think this has disproportionately impacted our population? 100%. Yeah, these are our people, many of them. Our people, our families, our communities that we serve. It's triggered significant emotional, physical, and economic problems around the world. We had largely left folks working on the front lines to continue doing the work, very much isolated from those of us who had the luxury of not being on the front lines. And I'd be remiss to not mention the sort of negligible impact of racism on substance use disorders and the way that we have treated and responded to substance use disorders. And the reason for intergenerational trauma in a lot of our communities throughout our country, right? And so this is a Chinese man, early anti-drug laws, the Harrison Drug Law Acts in San Francisco in the 40s were really targeted towards the Asians and in San Francisco. And he doesn't look like a nice guy. He's not being portrayed as a nice guy. He's got sort of these glowing demonic eyes, these long, weird fingernails, and he's doing something taking advantage of this gentleman, when really these opioid dens, these opium dens were highly, highly popular with the wealthy white elite in San Francisco. And if you look back in history, It's really quite interesting. The British had a stronghold on the poppy trade in India. As many of us know, the British brought colonization to almost to an art form, and they had a stronghold on the poppy trade in India that they had colonized, and they were selling opium. And they wanted China as a market. China is a huge, huge country, right? Very populous. And they weren't selling opium to China. And China said, you know what, we're good on this. Thank you. We've been doing okay without opium. And what they did is they dropped off literally thousands of tons of opium on each of the ports, the large ports of China. They built in an addicted market. And so there's a long history here, right? And then we saw racially sort of charged headlines in the New York Times as recently as the 50s, this time aimed at the African-American, the Black population around cocaine, and positioning them as just very disturbing things, right? And then I'm just bringing you to this point of diseases of despair, because what I think is college students aren't using substances as much because they think it's cool or they think it's the right thing to do. They might like start by experimenting in that way. But I think that it's really treating something that's untreated. And what we have, and so for me, it was mental illness, right? And so I had untreated mental illness, depression, anxiety, things like that. Those things don't go away, they build with time. And then all of a sudden, we're given a new level of freedom in college or whatever that looks like, young adulthood. And then we find these substances that start treating these things that were never treated, okay? And so I think we need to get to the business of working on this stuff, because even the National Academy of Sciences and Engineering has started to put this stuff together. You know what I mean? So here's what they say. Overprescribing is not the sole cause of the problem. It was a vector of the opioid epidemic, of course, but researchers agree that such structural factors, such as lack of economic opportunity, poor working conditions, eroded social capital in depressed communities, accompanied by hopelessness and despair, are the root causes of the misuse of opioid and other substances. I would agree to that. I think that that's a big part of it, right? And so if we're not making these structural factors, if we're not working on these sort of fundamental things, and I love this glossy term, social determinants of health. You know, this beautiful, beautiful term that it's almost like it's a new thing. Well, let me just remind you, we're talking about food, transportation, housing, and employment. This is what people need. They need lives that aren't so stressful that they have to use substances. And we know that we have different people with different brains, different environments, different rows at life that need different approaches to treatment that look and feel more like they want them to look and feel. Because what we have done, I'll speak for the treatment side of the field, what we have done historically in treatment is kick people out of treatment for exhibiting the symptoms of the disease that we've diagnosed them with, because they're hard to work with. And we blame them for their failures of treatment. And we have rarely turned the microscope back onto ourselves and said, what could we do differently? And that's what I started doing when I went into this opioid treatment program. I started asking the clients, how could we change to better service your recovery? And just completely change the dynamic. And so we took what was formerly sort of a pyramid structure, a traditional structure we see in most organizations. You have a director at the top, right? And then you have all the employees, and then you have this population that you're working toward. The director is the top. You know what I mean? And so we turn that upside down. The director's now at the bottom. How can I work for my staff to best support them to do the work for the clients that we're serving? And they're at the top. So everything that we're doing is determined by the health of our clients, the wellness of our clients. And of course, we all have the guidelines we have to sort of work within. We all have that, right? But what we have done in many circumstances as a field is left it to a check the box type thing. And instead of bringing our passion and interlaying that with the things that we do have to check the box with, we focus on checking the box. And those check boxes start to drag us along in our careers, as opposed to us leading our organizations into innovation. And what we know is that our field is typically about 15 years behind in employing the most innovative evidence-based practices. So we as leaders have a responsibility to give support to those that are doing that work, okay? And ACEs, I don't have to talk to y'all about ACEs, right? We know when individuals struggle with these critical experiences in childhood, they're much more likely to experience a broad range of physical and mental challenges. This is Carl Rogers. We give a lot of respect to him in the treatment field. He was, he did this remarkable thing of starting to treat people like human beings, as opposed to like we're just going to download some knowledge onto these people. And what we know is that our clients are actually the experts. And we're really there just to partner with them and sort of help them along in this process. So the only person that is educated is the one who has learned to learn and change. And one thing that I'm going to remember throughout my entire career, until we have really nailed this thing, is that we have not nailed this thing, and that we all need to have a certain level of what I would call clinical humility, or this idea that we're all still learning and we're all still sort of like grappling with this, throwing everything against the wall to see what sticks, because it's literally life or death. And we don't, again, have to look very far back in history where we as professionals had made very poor decisions. This is a doctor promoting Camel cigarettes. This was in the 50s, I think. That wasn't that long ago in the grand scheme of things, right? And just remember, we always think we're so innovative at the time, only to look back at dark spots in our history. What are those dark spots now? Well, the way that we treat individuals with substance use disorders based on not understanding their behaviors and based on not giving them support with the underlying issues prior to the development of the substance use disorder. Cocaine tooth drops at some point seemed like a good idea to enough people to make and market cocaine tooth drops. We used to do this to folks when we didn't know what to do with them, right? Folks with schizophrenia. We would just take a part of your brain out so that you would continue to breathe and eat, but you would not display these uncomfortable symptoms. We know now that that's absolutely, there's no words. There's no words. Okay, so SAMHSA talks about recovery like this. And I really like their definition of recovery because I think it scratches at those underlying issues. The one thing you'll notice in their definition of recovery, it doesn't even talk about substances. We get so obsessed about substances that we forget to treat the person holistically, knowing that that's the best way to work on their substance use disorder. And we can exacerbate their substance use disorder by working on the wrong things in the wrong order. So to a man with a hammer, everything looks like a nail. So I had clinicians, everyone looked like somebody to therapize. And what I had to tell them was, no. You know, the first day that you meet with an individual who was brought back to life from an overdose a couple of days before, the first thing you do with them is not to talk about their feelings for your own clinical curiosities. It's to figure out how they're going to eat tonight. Where are they sleeping? Are they in danger of intimate partner violence? What are some indigenous recovery resources in their own community that I can link them to? So when I have a young Black man who comes to me with a heroin use disorder, I don't have to send him to a completely through a whitewashed experience. I can send him to somewhere where I know that he's going to see people that look like him, that understand what he's been through. That goes for all our populations that we serve. And this is just brilliant to me. This was Dr. John Kelly's research. Remember, I talked about the largest recovery cohort study ever done to date. This was done in 2017. It was called the Multiple Pathways to Recovery study. And it uncovered a lot of stuff. And look at the left-hand side. This is what we found. So that first 5 years that an individual enters into recovery, and we look at the first 5 years because we know after 5 years that individual's, maintains a certain sturdiness or a robustness in their recovery. And it's not to say like on year 5, they wake up in the morning and all of a sudden everything's changed. We just know, statistically speaking, after about 5 years, in long-term recovery, folks enter a sort of recovery that makes it more likely that they stay in long-term recovery for the rest of their lives. Okay, and then look at what we saw. Everything got better. Happiness, quality of life, recovery capital, those things in that individual's life that sort of support their recovery, whether it be a job or whatever that looked like, recovery capital. Self-esteem. The only thing that went down was psychological distress. Great. But then you look at the first 6 months. Look on the right-hand side. It zones into the first 2 years. You look at that first 6 months. It's a bit hard to see. But what they found is that everything got worse in that individual's first 6 months in recovery. So think about it. We take it that individual's biggest and best coping mechanism away from them. Because drugs do that. They help folks cope with these situations while their lives fall apart around them. They're not stupid. They're doing these things for a reason, right? And then they abstain from the substance, trying to do the right thing. And then they enter a treatment center that maybe doesn't understand the fact that this individual is not all puppy dogs and butterflies, because their life has gotten absolutely hellish. Because what happens when you take away that coping mechanism that throws an individual in severe withdrawals that was helping to treat their trauma? Opioids treat psychic pain, not just physical pain. And that individual comes into the treatment milieu and maybe they say a cuss word at the front desk person or something like that. And then they're thrown out of treatment. It's just like, no, this isn't personal stuff. We have to understand what folks are going through in that first 6 months. It's an absolutely critical time. It's like a raw nerve. And then I just want to hit on this point of recovery management, this idea, if we're not in our communities doing this long-term recovery work and in our facilities with providers, having folks come in, talking to licensed clinical addiction specialists into their recovery careers, to do checkups, to make sure, because we plateau in our recoveries and we have to change our methodology up, our treatment plan, our treatment approach, in the same way that we have to do it with medical treatment approaches, right? So sometimes medical, physical illnesses become medication resistant. So what do? We change stuff. We don't tell the individual that they weren't doing a good job. That's not what we do. What do we do with diabetics that come in with elevated sugar levels due to eating things that they know they probably shouldn't eat? We don't shame them. We take care of them. We stabilize their sugar levels. We give them some assistance and support. We need to take that same approach with addiction. We've been saying it for a long time. We've had these mental health parity laws for over 10 years now, and we're still struggling to take insurance providers to task. And we need all folks across the continuum to work on this, right? This advocacy piece of calling insurance providers and politicians to task for making sure that we're providing the same sort of health insurance that's commensurate with physical health services in our country. And that's already bad. We already know our physical health insurance is garbage. We just want a level of mental health care and addiction treatment and prevention, and heavily funded prevention and recovery. We want our entire continuum flush with resources, because this is an epidemic, it's a pandemic, and it's a brutal, brutal problem that is getting worse and worse every single day. So we got to take a different approach, because we're trying to dig ourselves out of a hole. And you can't dig yourself out of a hole. You need a ladder to get yourself out of a hole. So we got to try different tools. We got to talk in different ways. We have to have a different sense of urgency. And the biggest thing that I see is we have to reach across the continuum of care, across buckets of money, to coordinate services based on evidence-based practices that we know work. That's our responsibility, I think. And then the thing that I will leave you on this morning, and then maybe we'll have a couple of minutes for questions, is Rumi was one of my favorite poets, theologian in the 1200s. And this is, to me, what it means to work, to be a social worker. I'm a social worker. So you wander from room to room, hunting for the diamond necklace that's already around your neck. So as providers, as professionals, we do not download knowledge onto individuals, families, communities. We give them platforms. Because I've heard enough white folks talking about issues that I should hear other folks talking about, right? And so what we know is that all of these families, communities, and individuals that we partner with have within them the answers. We just have to help walk alongside them and clear the obstacles and barriers to the best of our ability. And as the sort of experts that know our very complicated and confusing space, maybe that's the best that we can do in many circumstances, is to demystify this for our communities, families, and individuals, right? And to work with each other for the sake of our traumatized populations that have inhabited an inherently inequitable society that many of us had a better sort of chance at. I know I did, right? So I grew up in an atmosphere where we were not wealthy, but I never worried about food or money or housing, anything like that. And so for us to sort of cast opinions or judgment on others without really knowing what they're going through has really gotten us into this mess in the first place on many levels. So I appreciate you letting me talk at you for a few minutes. Natalie, is it kosher to open this up for questions or comments?
Yeah, there's actually a question in the chat from Karen South Jones, and I'll read it out loud for everybody. The question is, what is the one thing each of us could do today that would improve the way we serve our clients?
Yeah, okay. Well, I'll tell you two things. So one thing I would say is, where are you in the continuum? And what are you doing to connect with other pieces of the continuum, right? And so what I ask people a lot of times is, what's the problem in your community? Is it opioids? Is it methamphetamines? Who are your treatment providers who are doing the best work in that regard? And how do you know? Have you visited that treatment facility? Have you talked to them? Right? So reaching across the continuum, looking into indigenous recovery resources. What does that mean? Okay, I'll give you an example. So at Southlight, we were in the quote unquote bad part of town. What does that mean? Impoverished Black and Latinx community. Most of the individuals that were coming into our intensive outpatient were coming from that surrounding community, and they were struggling with crack cocaine and, statistically speaking, and alcohol use disorders. And instead of looking for the meetings and the long-term, the folks who are in long-term recovery that lived in the community outside of our doorstep that we could connect these people with, because what happens is treatment, prevention, these sort of things, these experiences, these small windows of interface that we have with our populations are like a blip on the radar in their lives. So we can only have a very small impact. I mean, to be honest with you. So if we're not connecting the populations that we serve with the indigenous recovery that's in their community already, that's more appropriate for them, then we're doing a disservice. So talk to other folks is the one thing that I would say. The other thing that I would say is advocate politically. Your voice is needed. There are groups like APNC, Addiction Professionals in North Carolina, that are doing great work around advocacy for the field. Get involved with those folks, write letters, go educate your politicians. I spent a lot of time doing that a few years ago. It's a good practice. What else?
Judy, you had your hand raised, but then you sent me a DM. Do you want me to just read your question out, or you want to just ask him?
Yeah, I'd just like to ask it. Let's see. Scott, we hear a lot about legalizing marijuana, and I was just curious about your thoughts on that, since cannabis was one of the drugs that you had on your list.
Yeah, I think it's really complicated. For me, it comes down to people are using these substances either adaptively or maladaptively, right? And so early on in my recovery, and so I'm speaking for a second, I'm going to speak from my recovery standpoint. When I got into recovery, I did not agree with cannabis use at all, because what I thought is if you're using any substance to alter your mind, then that was sort of maladaptive and a no-no. But what I've come to learn is that some individuals can use some substances adaptively that doesn't seem to have a diagnostic impact on their life. So that being said, I see that there's room for certain parts of our population to be able to use substances in ways that I could not. Now, the flip side of that is, will it be handled in a way, and responsibly, in a way that keeps it out of the hands of folks that should not have access to it? No, I don't think so. I don't think that's possible given our current situation. So that being said, I think our best row at this is to take away the need for individuals to get high and to take their minds off of things. So one of those things might be introduction to treatment for mental health challenges, whether that be anxiety. So for me, taking Lexapro was my antidote to having to smoke pot. It was a non-narcotic medication that just made it a little bit easier to do life. And it has no negligible impact on my recovery. In fact, it supports my recovery. And so I see sort of access to services and addressing the root causes. And because, what if folks could just go out and have fun and be comfortable in their own skin? That's sort of a prerequisite. And so if folks are given the option to take a substance that lets them have more fun and forget about those things that they've been struggling with, I think that's the thing.
Judy, you raise your hand again. You want to go ahead?
Yeah, I'll jump in. Scott, I really appreciate your description of not being comfortable in your skin. I have several mental health diagnoses, and I remember before I was treated that was one of the things that was just so awful, was not feeling comfortable in my own skin and just wanting to rip it off. And while I did not get into substance use disorder, my quote disorder was food.
Yeah.
And so that, and spending money, of course, when I was manic. So Yeah, it's good to hear somebody else describe that, not being comfortable in your own skin.
Hey, Judy, first of all, I just want to thank you for disclosing that. And second of all, I'm so glad that you mentioned that, because it made me think about when I was diagnosed, and this might be TMI for some folks, but I mean, this is the field we're in, so it should not be, right? But like my experience when I was talking to my psychiatrist was about my anxiety. He was like, well, what does it feel like? Well, it feels like being in terror. And for me, that was so normal that it felt normal to say. And it took a psychiatrist saying that that is not normal. You should not feel terror at all points. And so and my only point in saying that, Judy, and to the audience here, is we have a lot of folks that are struggling with substance use disorders, and they don't even understand that that's what they're doing, right? That they don't even understand that they're in this constant state of terror or feeling uncomfortable in their own skin, because it's like a fish swimming in a bowl of water. The water's always been there. The glasses have always been, I don't even know they're on my face. You know what I mean?
Yeah. And, you know, I wasn't diagnosed until I was 50. So I just figured that that's the way life is, that it's normal.
Right. That's it. What's wrong with us? Why are other people normal? Yeah, it's a lonely place to be. So you can see why people become addicted.
Yeah.
It becomes life enhancing, and their brain recognizes that, but it's not adaptive. Not in our modern contemporary world. Our lives fall apart around us with this type of use and maladaptation. Yeah. Thank you.
Any other questions? You can unmute yourself and just go ahead and throw your question out, or you can drop it in the chat if you like. Otherwise, we're going to transition into the next presentation. Okay. Thank you so much, Scott. That was a whole lot, like, it exceeded my expectations. I had high expectations for you, but it was still like really a really good presentation. I was over here mind blown. So I really appreciate you for coming and speaking. It was really, really great. And I really, you opened my eyes to a lot, and I know you opened a lot of other folks' eyes to a lot of different perspectives. So thank you so, so much. And Scott, myself, and Leslie Deal, we're going to be working together more in the future to bring more presentations like this to you. And then if you would just unshare your screen, stop sharing your screen, Scott.
You bet.
And then we can switch over and I can do the introductions for our CRM presentation, which will be offered to us by Ms. Judy Klusman and Kelsey Silva-Disla. So I'll do their introductions really quick, and then I already made you both co-hosts, so you can start sharing your screen whenever you're ready. So Judy Klusman was elected to the Rowan County Commission in 2014. She has a passion for people, especially children. Judy serves on the Board of Health, Department of Social Services, Smart Start chairs, the Juvenile Crime Prevention Council, and Saving Grace Farm.
Alyssa, or Natalie, you froze.
I apologize. Judy's love for creating policy comes from her faith background, which taught her to care for the orphans and widows, the most vulnerable in her community, and served 12 years in the Wisconsin State Assembly. She enjoys gardening, focusing on plants for pollinators, butterflies, and birds, horseback riding, and walking her dog, Bella. Oh. Bella means candle in Spanish because he lights up her life. Judy has 2 wonderful sons and 3 beautiful grandchildren. That was so beautiful. Okay. And Kelsey Silva-Disla is a community engagement specialist and CIT training coordinator in 4 counties in the Southern Piedmont region, Southern Piedmont area of North Carolina. She works with Cardinal Innovations Healthcare and is responsible for engaging key community partners in Cabarrus and Rowan County, as well as law enforcement across several counties for the purpose of promoting behavioral health awareness, reducing stigma, and creating change. As a unifier of community partners, Kelsey works collaboratively with them to discuss issues impacting the community, to create training opportunities, and to develop synergistic ideas with cardinal innovations and with each other. Through the Crisis Intervention Team, CIT for short, training program, Kelsey leads collaborative teams of law enforcement, behavioral health professionals, and community advocates as they deliver an innovative model of law enforcement intervention designed to assist first responders who respond to incidents involving people with mental health, intellectual or developmental disabilities, or substance use disorder needs who are in crisis. Kelsey holds a bachelor's degree in psychology and human services from Montreat College. She is currently enrolled in the MSW program at the University of North Carolina at Charlotte. Kelsey believes that education and collaborative work are fundamental components to healthier communities. So Judy and Kelsey, you are up. Thank you so much.
Well, wanted to share and I couldn't because it's not allowing me. So if you can maybe make that possible.
I apologize. I just made you co-host.
There we go. Okay, as Natalie said, yeah, get rid of my echo. Okay. I'm a technology newbie. Well, I call myself illiterately technology challenge. As Natalie said, I'm Judy Klusman, and I am just thrilled to be here. And my friend Kelsey will be joining me, and we're going to talk about CRM, the Community Resiliency Model. I have to check if that's me. This version of the Community Resiliency Model training was created by Elaine Miller Harris, and she's the co-founder of and director of Innovation, Vision, and Creativity of Trauma Resource Institute, TRI. And Kelsey and I recently had the opportunity to train as trainers, and we are looking forward to bringing that to our community. And that's really what this model is about, to work with groups and individuals. If you have a young child, I'll tell you, this is great parenting training too. So Kelsey, if you want to take the next slide.
Awesome. Thank you, Judy. Definitely we want to share this community resilience model with you so that way you have some techniques and tools. We're going to have two portions of the training. We're kind of going to give you the background and share some resource information with you. And then later on today, you'll have, some practice session, just kind of putting those techniques and tools into practice with some other presenters later on in the day. So the community engagement, the community resilience model was basically created because it wanted to create a safer dialogue to increase the polarizing of differences within different cultures. And so we wanted to bring up that the core values embedded in this CRM training, or the community resilience model, is to service social justice, dignity, and respect, and the worth of every person, family, and anyone in the community. So we believe that we need to practice inclusion and diversity within the model as you're learning some of the resiliency skills.
We all have a nervous system. And what am I doing? I always forget which one I'm supposed to mute and which one not. So we all have a nervous system, and learning to regulate that nervous system through CRM wellness skills can be life-changing as people learn to bring their own system back into balance and then share their skills with their families and communities. CRM skills can become a common language. CRM has been used across cultures, religions, and ethnicities when we help children and adults learn how to tell the difference between sensations of distress and well-being. Resilience can expand by learning simple wellness skills. And the result is feeling greater balance in our mind, body, and spirit. And this is true all over the world. The community resiliency model can be shared with individuals who have low literacy rates or with children who have not learned how to read or write. So learning to read the nervous system is a human skill regardless of literacy level. So CRM can be used across the lifespan. And it's really cute. A well-attuned parent can help to regulate the immature nervous system of infants. Absolutely. Children can learn the skills as well as adults. And here's the neat part. The oldest person who learned the skills was 104 years old. That's pretty cool. Next slide.
Yep, so definitely it can help us along our lifespan from 0 to 104 or even further. And so as we get ready to start the training, we want you to look at these questions that are in front of you. And I would like to invite you to think about the answers to one or more of these questions. And so I'm going to give you just a few minutes as I read them to you and kind of start thinking about what or who uplifts you and what or who gives you strength, or what or who helps you get through hard times. It's so important that we think about these questions because we actually can use the response to these questions to build our resiliency. And you'll see that later on as we're teaching you some techniques and tools. Judy and I won't go over them, but again, other presenters will today. And so make sure that you're thinking about those questions as we're going through the whole process of sharing this with you.
So there are many definitions to the word resiliency. And as we start the training, it's helpful to brainstorm about what that word resiliency means to you. And our training team was recently in North Ireland starting a training, and it was brought to our attention that there was a giant billboard in Belfast saying, "Stop calling me resilient, because every time you say, oh, they're resilient, that means you can do something else to me. I am not resilient." And this was Tracy Jackson from Louisiana Justice Institute. In other words, it was the government's way of not helping people in need. Also, we traverse parts of the United States, and there are others who have objected to the word, and their individual definitions that we have often found is not in the spirit of the Trauma Resource Institute's definition of resiliency. So what I'd like to think about now, invite you to think about, is what is your definition of resiliency? What is your definition of community resiliency? And if you want to put that in the chat box, you are so welcome to do that. So since then, it has been important for us to have a wider discussion about the word resiliency and its meaning. I invite you, if you feel comfortable, to write in a chat box your definition of resiliency. And I'll give you just a few minutes to, and you can talk around the table too, if you'd like.
So Judy, I'm seeing that someone wrote the ability to be able to bounce back from adversity. Karen says resiliency is the ability to bounce back after a setback that life throws at you. Sorry. Chris says being able to bounce back from whatever is bringing us down. Desiree says the ability to figure out a way of managing something that is out of your control. Miriam says to be able to handle difficult situations in a healthy way.
Okay, thank you for those. We will go on to the next slide. Kelsey.
Oh. Oops. Sorry about that. So great for, thank you so much for sharing your definitions of resiliency. They definitely are pretty much in alignment with the definition that the resiliency model has. And it includes cultivating our well-being, embracing our individual and collective assets and strengths, being able to be solution focused about our life challenges, being compassionate, optimistic, and acknowledging individual and collective suffering with kindness. So empathy is so important as we're practicing resiliency. And all of this we need to accomplish all of life's demands. And so we definitely want to make sure that we're mindful of that. Another definition from the creators of the community resilience model is that resiliency is an individual's and community's ability to identify and use individual and collective strength in living fully in the present moment and to thrive while managing the activities of our daily lives. And that was from Elaine, who created the resiliency model. According to George Bonanno, resiliency is the most common reaction to those who experience trauma. Community resilience model has been used worldwide, and they have witnessed that this capacity of cultivating individual and community well-being during and after human-made or even natural disasters, and while dealing with challenges in our life experiences is so important. So if you look at the graph in front of you, everything that you are doing on a daily basis, moment to moment, really impacts the ability to have or your resiliency in life.
So resiliency, staying calm when faced with a challenge. Dr. Bethel's definition of resilience is in accordance to CRM's definition. We must help children learn wellness skills that calm their minds and bodies. Adults
can do this too. I know I need it. Dr. Christine Bethel, John Hopkins, investigated associations between ACE scores and factors affecting children's development and lifelong health. Her study is pertinent to CRM as her definition of resilience, staying calm and in control when faced with challenge, is similar to CRM's definition of being the resilient zone. If ACEs lead to a disruption in the nervous system, and for some children, the beginning of a cycle that disrupts health as adults, CRM skills of well-being could be an antidote to help people learn to regulate their nervous system. So this is really, really critical. And what we're going to do next is work on our ACEs scores to see where we're at. So I invite you to find your ACEs score. And if you feel comfortable doing it, you can put it in the chat box. It may very well surprise you, or you can keep that private. So here we go, finding your ACE score. While you were growing up during your first 18 years of life, did a parent or older adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? And the answers are yes or no, and each yes, and you can write down on your paper, just crosshatch or whatever, but if you answer yes, enter a 1. Number 2, did a parent or other adult in the household often or very push, grab, slap, or throw something at you, or ever hit you so hard that it left a mark on you? Number 3, did an adult person at least 5 years older than you ever 5 years older than you were ever touch or fondle you, or have you touch their body in a sexual way, or attempt to actually have oral, anal, or vaginal intercourse with you? Number 4, did you often or very often feel that no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? And number 5, excuse me, did you did you often or very often feel you didn't have enough to eat, to wear, you had to wear dirty clothes and had no one to protect you, or your parents were drunk or high, too high to take care of you or take you to the doctor if you needed to? Kelsey, you want to continue?
Yep. And so we want you to see these questions and kind of go through them for yourselves. And like Scott said, maybe many of you have already gone through or know about ACEs, but we wanted to make sure and not leave it untouched, because it's so important to put things into perspective. And so the questions continue, and we continue to invite you to try to see if you can score yourself. Number 6 says, were your parents ever separated or divorced? And you would answer yes or no to that. 7 says, was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Sometimes, often, or very often kicked, bitten, hit with a fist or with something hard. And I won't read the last one, but you can go ahead and see that. Number 8, did you live with someone who was a problem drinker or alcoholic, or who used street drugs, or like we say, if they had substance use? Number 9, was a household member depressed or mentally ill, or did a household member attempt suicide? And sometimes, even like Judy mentioned, you know, some people we grew up with might have had some sort of disability or mental illness, or, you know, substance use disorder, and they were never diagnosed, and we still had to deal with that situation. I also want to invite you to think about the people that you serve in your communities. If you are professionals serving your community, you know, how many people are you encountering that are possibly experiencing these different types of trauma? The last one says, did a household member go to prison? So basically what you would do is take all of these 10 questions and you would sum them up. And based on your numbers, then that would give you your ACE score. Anything that is over 1 ACE score is already putting you at higher risk. So as the numbers of your ACE scores increase, so does your risk for negative health outcomes. So we're not going to ask you to share your score. This is for your own information, and for you to just be mindful that some of us fall in different areas within the ACE score, and just, you know, it's very relevant for us to know this so that we can apply those resiliency model techniques and tools that are going to help us to be equipped to counteract those traumatic events in our lives and to help us to cope with life. And so here are some possible risk outcomes when those ACE scores are higher than 1. You're looking at behavior, and you're looking at physical and mental health being affected as we are going into our adult life, into our youth. And so again, it just really increases just the risk of us either being physically or mentally ill, our behavior as well. And going back to what Scott was saying, you know, there's so many variables to the things that affect us and how we cope with them and how our brain responds to them. And so Judy's going to talk to us a little bit more about that.
Yes, when we talk about understanding the brain, it's like our previous speaker said, it can go on and on and on. But what we wanted to do today was simply give you a very rudimentary idea of what our brain is. So if everyone would please hold up their hand, and I'm going to point out, and I invite you to point with me. If you're at your wrist, that is your cerebral brain, and it's the fight, flight, freeze area. And if you go up into your hand, that's our emotional brain. It's our limbic system. And then when you bring your thumb in across your palm, this is our amygdala. And this is our smoke alarm of the brain. Now take your fingers and just fold them over. And your fingers are the thinking brain. And that's the largest part of the brain. But it's our online brain. Now, what can happen is you can flip your top, and then we go back to the offline brain. So let's do it once more and just think about our wrist is our survival brain. And what this deals with is sensation, autonomic functions, survival, strategies, fight, flight, freeze, submit, or collapse. If you got an animal, some animals will play dead to protect themselves. Okay, now move up into the emotional brain. This is the part of the brain where we have expression and regulation of feeling, memories, relationships, and attachment. And then fold that thumb over one more time for our amygdala, that smoke alarm of the brain. It assesses for safety and threats. And then the thinking brain, our cortex. That holds our critical thinking, problem solving, beliefs, planning, creativity, impulse control, and language processing. So our brain is really involved right there and can go, if you, it's like my brain, I can be thinking about something and then something else takes my attraction away. And, you know, so yes, I am a little bit ADHD. Okay, but the thinking brain can all of a sudden flip its top and it goes offline. So it's your offline brain and it goes back to survival and is in control and unable to access the thinking brain. So it's like it comes all the way around in a circle, and you can be anywhere within this brain, emotional, survival, and thinking brain at any point in time. And then something dramatic happens and it's like your brain goes offline and you're back to survival. Okay, Kelsey.
Awesome. Thank you, Judy, for sharing that. So our brain function is definitely a huge part of our responses. And so here we have a graph, or not a graph, just I'm going to show you about the resilience zone. So this resilience zone is our state of well-being in our minds, body, and spirit. So in the resilient zone, one is able to handle the stressors of life, and you can handle them appropriately. Within that zone, and within those two lines that you're seeing, things happen, life happens. And as long as we're within that zone, we are within our resiliency zone, and we can cope with life, and we can go ahead and react or respond. And within that zone, you can have any type of feeling. You might be sad, you might be upset, you might be mad, angry, frustrated. And so what we want you to know is that as long as your resiliency zone, you stay within it, you're able to manage the ups and downs of life, and you're still okay. What we want to make sure is that you recognize what your resiliency zone looks like. Some of us have wider, and some of us have a shorter or narrower resiliency zone. And so we're going to talk about that a little bit. So notice that this resiliency zone here, it's like a wave. So as there can be times in your day-to-day that you have more stress, or you have other times during the day when you're calmer, there is an ebb and flow, and you can manage and challenge those challenges that you're faced with during the days When your mind is its best self, when your body is at its best, and your spirit as well. So this is your okay zone. And so if you're going to explain it to a child, you want to say, hey, this is your okay zone, that resiliency zone. And again, it's okay, sad, mad, angry, as long as you're within your zone and you notice the different feelings, you're going to be okay. You're still handling life appropriately.
I just want to just do a quick story that our teachers shared with us about a teacher in a classroom who had kind of like the highway or the resilient zone going along the wall. And each day the children put their little dot or whatever with their name on it up where they thought that they were within the resiliency zone, or if they were bumped out up or down. But as Kelsey said, it's like things happen in life and our thoughts and feelings and reactions move around in our resiliency zone. So this wave is there. It can be times in your day that you have more stress than others during your day. When you are calmer, there is an ebb and flow.
And yeah, that's just
But it's
basically the same thing.
Yeah, but there is an ebb and flow. You can manage the challenges that you face during your day, being your best self in mind, body, and spirit. So especially with children, we have begun to use that okay zone for children as you, let's see. Sorry. We have begun to use okay zone for children as you can be okay mad, okay just right, and okay sad, and still be with it in your zone. So notice the different feelings that can be in the okay zone. Kelsey.
So as we mentioned before, life can result in a person getting bumped out of their resiliency zone. And so when you're bumped into, and if you look at this lightning bolt, it represents the traumatic or stressful events that we can possibly go through, or just anything that comes that throws us out of our zone. So when we're bumped into the high zone, we react. So this is again within our graph, just showing us that the lightning bolt happened and that life threw us off our zone. And this is our being thrown off of the zone into the high zone, which is when we react to different situations. Maybe you're stuck in traffic and you're feeling angry. Some people here go into road rage, so they go into their high zone, and the responses can be irritable, even mania, anxiety, panic, and all of these things can happen. You can have people who have outbursts, as we've seen. They can even experience pain. The other thing that can happen is you can also adversely be kicked into a lower zone, right? Where now we feel disconnected from just life. Maybe we feel exhaustion or numbness or depression. So when there's a trigger that represents a past traumatic stress or a stressful situation, we can get bumped out of our resilient zone and get stuck either on a high zone or the low zone, where we're depressed or sad, isolated, again, exhaustion. Some people can go up or down within the zones and get kicked out. The point is, how can we get back to that center best place within the zone itself? So this graphic just shows us that, we basically, life happens and it can throw us off if you're explaining this to children. You can use different emojis, or you can, just explain by what Judy was saying, using the zone and maybe having them put with a piece of a sticky note or something where they feel that they're at. What we don't want is to get stuck in either the lower or the higher parts of being kicked out of the resiliency zone, because then we're dealing with possible risks of mental illness, or it can throw us into substance use disorders, or just anything else that is going to affect our health. So we definitely want to make sure we come back to our resiliency zone.
Okay. I'm in the wrong place here. There we go. Now, some of us have a very narrow resiliency zone. So small stressors can bump a person into the low or high zone. Let's say you just had a baby and it's very traumatic, and it's really kind of hard to keep it within that low, within the confines of our current resiliency zone. All of a sudden that baby cries and you're like up here. Sometimes people have postpartum depression and you get stuck down low. But the point is that we can work on getting our resiliency zone wider. So we can, the more someone can learn the wellness skills, and the more skills are integrated into one's life, the more the individual can work to widen his or her resiliency zone. Now, in neuroscience, the more awareness that is brought to the sensations, and you may not have noticed, we're not talking about feelings, we're talking about sensations in our body. So when we notice those, we can work to increase that state of well-being, increase resiliency. Now remember that neurons or brain cells that fire together, wire together. It's a very interesting way of remembering that we can increase this resiliency. So can you give an example of how your resiliency zone widened by learning the skills to deal with life stressors? Just take a minute to think about that. And if you want to share something, then I invite you to put that in the chat box.
And thank you guys who did share your ACE scores. Thank you for sharing that with us. Again, just being mindful that everything, our holistic view of everything matters. And so as we're thinking about widening your resiliency zone, if you need to, the tools that are going to be shared later on today are going to help you to just widen that zone. There is hope. The point of us sharing this presentation is to share that with you. And now we're going to go ahead and show you a resource. This here is a picture of an app that is our community resilience Model app. And the app itself is called iChill app. And we're going to invite you now to go ahead, pick up your phones if you can. You're not using them for the presentation. And look up this iChill app. You want to make sure that you have an opportunity to download it into your phone. It goes through some tips and techniques, and it talks more about the community resiliency models, and just really goes into depth of that information. Again, you're going to get some of that later on, some more resources related to the app, so keep that in hand. If you wanted to share with some of your Spanish-speaking community members, it's also in Spanish. It's translated into Spanish, and it does have the author and creator of this model reading the information to you. And so we're going to give you an opportunity to go ahead and download the app. If you have had a chance to download it, please give us a thumbs up, or I have it on the chat. And as we're doing that, we also want to open this time to questions or anything that you wanted to share. And hopefully so far, you've learned a little bit about just being mindful of not only our ACEs scores, but then the hope that there is with learning these tips and tricks and tools with the resiliency model, so that you can widen that and you can use it to counter effect traumas that we've experienced and live a happier, holistically better life. Thank you for having us. Awesome. I see one person downloaded it.
If you don't, if you don't download apps very often, just go to your app store, and on mine it's a big letter A, and find the little search button and just type in iChill, and it will pop right up. Now there might be something that's first that's not iChill, but just look for that bright green or bright teal looking app and download that.
Awesome. And I am seeing some people downloading it. And this is something that it's a resource that you will have available to you, but then you can also share it with your family members, your community members, your coworkers. It's a great resource. So we definitely want to promote for us to kind of spread the word. It's something that people can, just like you would maybe an audiobook, listen to an audiobook and relax. This is something that you can listen to the strategies, try them at home. And again, you'll get a little bit more of that later on. We don't want to do any spoilers right now, but you will need your app probably later on as well. So thank you everyone for having us. This was awesome. I hope it was beneficial to you. And if there is no more questions or anything, we're going to turn it back to you, Natalie. Oh, you're muted. And I'm going to stop sharing.
Sorry. Thank you so much. That was very informative, and I love CRM. I was in the CRM cohort in February 2020, and it has been, I can say from a person who has, I would feel like I have some form of undiagnosed anxiety. I have not been to a therapist, but I have definitely had an anxiety attack. That CRM training really just changed my whole life around. It helped me to be more balanced and just kind of regain control of my emotions. So if you have any type of emotional dysregulation at all, I encourage you to try it out, teach it to your children, just kind of model it for people that you love and care about. And I promise you, mirroring is a thing. When we talk about mirroring in CRM, you'll be able to, people around you will reflect those behaviors that you're demonstrating. And it is such a beneficial skill to take in just expanding who you are and how you show up as a person. So our next part of our agenda is the lunch and learn. So we'll have some folks that are really like huge. I think these people are really huge hitters in the recovery community. I admire all of these people so much. And that'll be starting at 11:30. Our lunch and learn. So if you want to just take a break, use the restroom, grab coffee, go outside, look at the sun, breathe for a few minutes, come back with your lunch, because we are lunch and learning. So eat your lunch, and while we're chatting and just talking about things dealing with recovery, substance use, and all of the like. So I'm going to go on mute, and I'll see y'all back at 11:30. Our panelists for the lunch and learn are Ashley Creek, Tyler Yates, Kristen Klingel-Smith, Stephanie Kursinga, and Delton Russell. These are really awesome people. I'm going to read over their intros really quick so you can just know more about them if you don't know who they are. And give me 1 second to do that. I'm sorry. So Kristen Klingel-Smith has a Bachelor of Science in Sociology and received her Master's of Public Health degree from UNC Charlotte. She's a substance use program manager at Cabarrus Health Alliance and has worked in substance use prevention and harm reduction for over 7 years, not 70. Sorry. Stephanie is a person in recovery, a certified peer support specialist, and really an amazing person. She's so sweet. She is like, I don't want to mess up your title, but are you like the coordinator or the manager at the syringe service program at Cabarrus Health Alliance? She's like the ringleader over there, and amazing person. I work with her all the time volunteering. Ashley Creek, sweetheart. She is our certified peer support specialist, also a person in recovery. She serves as a member of our port team and one of my team members. Love her to death. Delton Russell, I don't think I got an intro for you, but Delton is also a person in recovery. He was one of the, I want to say you coordinated at Will's Place, and I'll let you introduce yourself more because I don't want to butcher your intro. I don't think I received one from you. And then Tyler's he works at the syringe service program. He works as a service syringe program coordinator for the Guilford County solution to the opioid problem. He is a senior in the social work program at the University of North Carolina and a certified alcohol and drug counselor, as well as a peer support specialist and a person in long-term recovery from substance use disorder. So how we're going to do this, I have questions for them, but I'm also going to leave some space for you guys to answer the questions and ask questions of the folks in the crowd. And if you have questions for them, please drop those questions in the chat and I can read them out to them and they'll be able to answer. So we're going to get started, and whoever wants to chime in first, you chime in to answer those questions. So the first question that we have is, what are some of the barriers that you've experienced or you've seen or experienced when attempting to get someone into treatment or recovery? And whoever wants to answer that question first can go ahead and answer that question.
I'll go ahead and go.
Ashley.
Was that Delton?
You want to take that one?
Oh, I'll go, Delton, I'll let you go first. You can introduce yourself and answer, and I can go after you. It's no
Oh,
biggie.
sure. No worries. Hey, y'all. My name is Dalton Russell. I work for Partners Health Management as a member engagement specialist. You may have known me in the community formerly, working for Cardinal Innovations, doing the same thing. In between the two, I worked as the executive director for Will's Place Recovery Resource Center in Albemarle, North Carolina. And there we were just connecting people into treatment day in, day out. That was the primary focus. So I do have a lot of experience both with all three jobs, connecting people. I'm also the board chair for the Cabarrus Recovery Alliance in Cabarrus County. And we connect a lot of folks to treatment through there as well. Yeah, so the largest barrier, when I was younger, I thought the largest barrier was that people didn't have insurance. And then I actually worked with people that had insurance and realized that that presents its own level of barriers as well. Really, in my perspective, the biggest barrier is that services are best kept secret in terms of treatment. Getting people engaged in detox, stuff like that. Like you gotta like know the secret knock and know the right word and know the time of day and all that stuff. And that definitely makes things pretty complicated at times. And then a lot of that has to do with state laws. The Olmstead Act. There can only be a facility with 16 beds. Otherwise it's considered an institute for the mentally diseased, and that's that changes the funding structure of how that facility is funded. So our detoxes usually stay full all the time, and in addition to that, you run into issues where like somebody doesn't have an ID, or somebody's been using cocaine or methamphetamine, and there's no detox for those things. It could just create a lot of complications. But anyways, Stephanie, go ahead. Sorry.
Yeah, I definitely agree with the depending on the substances that they're using, predominantly will dictate if they're able to get into a detox system. So some of the barriers, and I kind of made a little point so I don't get carried away. So with that question, my first one was the difference between a clinical and a non-clinical environment of a detox system is what I have been discussing with like the Daymark Treatment Center. Was the way they explained to me was there's a clinical and non-clinical, and because they're a non-clinical, they have a lot of stipulations they have to go through. If there's like scarring, if there's active abscesses or endocarditis, things like that, like they're not able to take them because it's not a clinical environment. So if there's no ID, they can't take them. A lot of barriers. It's really hard when you've got a homeless population or people with lack of income and they're not able to get in because they can't afford to buy an ID, but you have to have an ID to get into detox. So then you're kind of like bumping your head, but you can't get into treatment unless you have detox. So it's like, well, what do you do? Like, where can they go? You can't take them to the hospital because they have to have their mental health is like the key diagnosis. If they go in saying they're wanting a detox, they won't take them. But if they go in and say I'm suicidal or homicidal, they'll take them, but only for 7 days. If they exceed that, then they can go to another hospital, but you're in a mental facility, not a substance use facility. So they're going to primarily address mental health, not substance use. But they can, it's just backburnered, if that makes any sense. So there was one of the barriers that I have found hugely with my population that I serve with detox and being a difference between a clinical and non-clinical. Let me see. Point to be made, need service for all journeys. Oh, well, we've already addressed that. Limited treatment options with parents. So like, what is a mother or a father? Where are they supposed to go for detox if they have a child? And then what is the age group? I have not found anything yet that will have a detox. Treatments, yes. Detox, no. And then the treatment options, the only thing that they show is for mommies. Well, what about the fathers where the mothers may the deceased are still actively using, or whatever the dynamic may be. That's a rabbit hole that we just won't go down today. But, you know, if a father has the child, where are they supposed to go for detox or treatment? Because we have nothing for them. There's treatment options for mommies, nothing local with Cabarrus and Rowan County, but then there's no detox options that I have found, except for one that may be able to help, where you can have something for your child. So where does a mother go when they have a child and need a detox so they can go to treatment? So that's another barrier that I have seen. Of course, no insurance is really hard. So you're like, you can look up treatment options within 100 miles of Cabarrus County, and I can find a buku's amount, but when you say no insurance, it brings the list down to this, and they're so far away. Like, how do we get them there? What funds are we supposed to use? So that can be an issue. And then I also just wrote down like the Hep C treatments and things. Like, some places I have dug and I have found where they can offer that while they're there in treatment. Like, hey, while you're here for our program, we can offer you Hep C treatment. But that's very, very few and far in between. So, you know, just trying to find them that a broad spectrum of services while we've got them, because they are such a difficult population to work with. Like, while we have you and we've got you in one spot and you're sitting still, let's like work on these, not too overwhelming, but just enough to give them that positive outlook that there's, you know, a future worth fighting for. And so that was one of the barriers. Well, those are some of my barriers that I have messed with in the last year and a half of being here with the syringe service program, is trying to find those immediate services that we can get them in without bumping our heads. Because once they walk out of here, I can't tell you when they'll come back, or if they're even going to be willing to want to go to detox or treatment in that next conversation. So we may start all over in those stages of change. And it's like a hamster on a spinning wheel. So yeah, that's my answer to the question.
One other thing that I think would be important to add too is that, you know, we know that nationally 9 out of 10 people in active addiction started using before the age of 18. And there's next to no resources for adolescents in active addiction. And also, if you get involuntarily committed because you present suicidal, that last 7 days, if they, after the second eval, determine that you are still actively suicidal, that you're truly actively suicidal, if you have your second eval within 24 hours and they don't find you to be suicidal, they'll release you.
Lots of great points. You know, I do want to touch on the adolescent thing. You know, not too long ago, I was working with a 17-year-old kid that's using heroin, only been using for about a year and a half. You know, he was wanting detox, and there was literally nowhere that would take him. And because he had, you know, Medicaid, that was another barrier. You know, the few places that do provide detox for adolescents are starting to move away from doing it for opioid use disorder, because it can be treated in an outpatient setting, such as in, you know, an OTP, methadone and Suboxone clinic. This is something that I'm constantly screaming and ranting and raving about. I think the couple times that Ashley's come up to Guilford County, we've discussed the barriers that folks run into. You know, one of the big ones is, you know, related to opioid treatment providers, specifically the clinics, having to wake up every morning and be at the clinic at 5 a.m. before work, when there's no buses running. And if you don't have an ID, then you can't get in. And now we're going to this non-smoking system where you can't smoke on the property. So while you're waiting outside in the cold, you know, waiting on to get your medication, you're stuck outside. People are driving by, they know what you're doing. You know, that's a huge barrier. Another one that we've recently started running into, I'm not going to name any specific locations, but there's a provider that does not provide opioid detox if the person tests positive for opioids. And we all know how bad the poly substance use is. The rates of poly substance use are going up. So that's another big one. I could really go on and on and on and on about the barriers that we create, for no other reason except for risk aversion. I can't think of any other disorder where we require people to go to groups to get their medication. Such as an opioid treatment provider, one of the ones here in Guilford County, people must go to group every single day to receive their medication. Imagine if we did that for things like diabetes or even depression. People would be in an uproar. So there's just a lot of, barriers that we've created that could easily be done away with.
I have nothing really to add with the barriers. You all have said them all. I think Delton hit the nail on the head with the analogy of you have to know the secret handshake. And I think something that gets us very frustrated is you have to check all the right boxes. And if you don't know what to say, how to say it, or how to make it look, then people aren't getting the services they need. And that makes it really difficult.
And depending on who the admission staff is, sometimes the goalpost changes. Sometimes people will be more lenient about one thing than they are about another, and that makes it really complicated as well. Ashley, I think there you go. You were on mute while you.
Yeah, I didn't realize I was on mute. Thanks, guys. Y'all shared a lot of great stuff already. There's only a few things I would like to add, and one of those is, in my experience, this is my opinion, I have found that there seems to be more treatment programs for men than women. And I'm not sure exactly why that is. I've heard, different reasons why that might be, that we're more dramatic, possibly, that we seem to be harder to deal with than men. And I'm not saying that's true at all. I'm just saying these are some of the things that I've heard. But I know that I have, searched for resources and found a plethora of treatment programs for men and, not as many for women. And so that's been a struggle for me to get people to help people into treatment. I've also, with, just to add, like Stephanie and Delton were talking about the detox and getting somebody into detox and the level of difficulty it can be to do that. But then when they're in detox, trying to find them placement for afterwards. There's a limited bed, there's a wait. And so people are leaving detox and then they're going right back into the environment in which they came from. And that can make it where there's going to be, that round and round and round, here we go, right? Because they have nowhere to go. And, it's just a struggle because we just have limited programs. We have limited treatment programs, especially for people who do not have insurance. And even, like they've suggested, the barriers that they have for insurance and just I wish I could explain or go over all the things that I've heard as to the hurdles that people have to jump through to get into those treatment programs. It can be exhausting. I know from my own experience, trying to receive help for my mental health and substance use disorder, the amount of things that they wanted and required from me, the wait time that I was going to have to wait, left me defeated and hopeless. And I know that can be a barrier for people getting into recovery, that they're trying so hard and then they get doors closed, or they have more hurdles and more hurdles, and they give up. So those are just a few of the things that I wanted to add to what everybody else has shared.
I also want to add real quick, one of the other things that we've been running into here recently, especially with this contaminated drug supply, is detox centers not providing buprenorphine for folks because they're not testing positive for opioids. You have to test specifically for fentanyl for it to show up. So when individuals are going into detox, wanting to make some positive change in their life, they're testing negative for opioids. Therefore, they're not able to be prescribed buprenorphine. So they're left with the decision of either, suffering and being terribly sick for the next, week to 2 weeks, sometimes even more, or leaving and going back to get the one thing that they know can make them feel better.
Yeah, Jason, I agree completely. Since I started in this field back in 2008, I've seen consistently this attitude of if you want it, it's here, come get it, but we're not going to meet you where you are. Kind of the field of dreams, if you build it, they will come sort of deal. But recovery rates are painfully low, extremely low. And it's not because opiates are so amazing. It's because access to recovery has so many unnecessary barriers in front of it. Barriers that serve no purpose other than, as Jason said, risk aversion. That's it. And it's terribly unfortunate. Because realistically speaking, when somebody goes to detox and they get out of detox, if they have a return to use, they're a lot more likely to overdose and die at that point than they were before they went into detox.
Absolutely. The study from UNC Chapel Hill shows that folks that are getting out of prisons, and I imagine that this also would relate to detoxes as well. But folks that are entering back into society from prison that return to use are 40 times more likely to die in the first 14 days after release than if they would have kept using. And I think that's a huge issue. There's evidence-based treatment for opioid use disorders, and treatment providers are refusing to use it. They're refusing to link people with Suboxone and methadone or buprenorphine when they're released. We're not bridging folks, and I think that that's a huge issue.
Thank you. I'm going to move on to the next question. And then again, I see some questions in the chat, but I'm going to say those towards the end and we can address everyone's questions at one time. So the next question that I have on my list, what are some of the struggles of maintaining long-term recovery?
Community.
Could you say that again, please?
Me?
Yeah.
I'm sorry.
No, Delton.
Yeah, no, community. We often miss the value and the importance of community. Like in my area, at least, I can't speak for other people, other areas, but I'll speak for my area. There's very limited communities for you to be engaged in. If you don't identify with a certain recovery fellowship, then there's not really a whole lot for you out there. And there's also a tremendous amount of stigma and a tremendous amount of misunderstanding as to what recovery actually is. We often think that recovery just means that I quit using drugs and alcohol. If I just quit using drugs and alcohol, then everything's great. But the reality is there's a whole lot that goes along with making recovery sustainable, making abstaining from use of drugs and alcohol sustainable. And a lot of that is found in community. And you know, when we're connected with other folks, when we're in a community, we not only learn from other people that are walking that path in front of us, but also it greatly increases our feelings of self-worth and our feelings of value and how we see ourselves. And I think that's really important. That support is imperative. At least it has been in my life.
I think for me, the struggles that I've seen and that I've experienced myself in maintaining long-term recovery is a holistic approach to treatment and recovery. I've seen people want to focus on one thing more than the other, and that left me in a position of lack. Realizing that, we need so much support to, like Delton was saying, and then, addressing a physical, mental, and spiritual aspect of my recovery has been vital in maintaining it. But not everybody has that approach. I feel like people, like I said, people lean more towards one or the other, and they lean towards abstinence-based or this based. It's just this one idea of recovery instead of this, why can't I bring it all together? And so for myself, that's what I've done, is try to bring a little piece of 12-step, a little piece of mental health, a little piece of faith, a little piece of science all together in my recovery to maintain that recovery. And that was a struggle to try to get that. It wasn't all in one place. I had to search for it and look for it, because we have, just a lot of set in stone ideas of what recovery looks like. And maintaining, just to share again what Delta was talking about, that community, there is a lot of stigma and shame if I come out as somebody who is in long-term recovery, but I've chosen to live my life like that. But I know so many people who don't, because of the stigma and shame that can come with that. And so having a lack of support around them, to come around them, to be able to walk them through the different stages of what they might go through, because it's a very tough line to walk, because many of us started very young. And so we have arrested development and mental health conditions that may have never been addressed. And so we're kind of learning something, but also still trying to survive in this world, still trying to live this life that we have. We have responsibilities to take care of. We have things that we need to do just like anybody else. But now we have this added thing of we have to recover and we have to get better so we can maintain these things in our lives.
And to be clear, that stigma isn't only just within our own community, which there is a lot of stigma within our own community, but also that stigma very much is related to our community around us. My employer, my in-laws, my friends' parents, the person that is checking me out at the grocery store that remembers me 2 years ago when I came in there and I was definitely not doing so well at that time. Or you explain to people that, well, yeah, I'm in recovery, and, that can mean a lot of different things to a lot of different people, like there's just, it's very siloed, it's very fragmented. And as we were saying, there just tends to be a lot of stigma out there. And that's honestly, the sad part about it is all that stigma comes from just folks being uninformed. I mean, that's really all it is. They're just uneducated about it, I've had a nickel for every time I've had a colleague, a professional that works specifically with people that live with addiction that couldn't explain what arrested development means. I'd have a lot of nickels. And 9 out of 10 adults in active addiction start using before the age of 18. Like almost all of us have experienced arrested development. And if you don't know what arrested development means, then you can't really explain to somebody that neuroplasticity is the pathway out. And we just need to do a better job at educating not only ourselves, but also our folks in our community about this stuff.
I think that was put amazingly. I definitely think that we need to put more money into education and actual education, not this fear-based, just say no tactics that we've been using since, Reagan and Nixon. Another thing that has really helped me is having that recovery capital. And when I say that, when I went to treatment, I had a family that was able to kind of support me financially a little bit while I got my foundation for recovery. And that played a huge part in it. When I think of sustaining recovery, I think of Maslow's hierarchy of needs. And if my basic needs aren't met, then I'm not going to be able to focus on what Maslow calls self-actualization. So, I think that we need more recovery resources. We need people, we need long-term housing options that are free. We need long-term, employment options, stuff like that, places where people can go to have their basic needs met so that they can spend time focusing on that positive change.
As exemplified by Portugal. Portugal legalized every drug known to man, which sounds wild and crazy to hear those words, like crack is legal, what is that? But instead of spending all their money fighting the war on drugs, they instead invested their money into support services for people that are trying to get sober. And for 10 years in a row now, we've been able to see data that clearly shows that addiction numbers go down every year, recovery numbers go up every year. People are staying in sustained recovery for longer periods of time because they have things like Jason's talking about, that their Maslow hierarchy of needs are being met. They have housing, they have shelter, they've got food, they've got a job, they've got a career, they have something that they can do that adds worth and value to their life. They don't have to check the box and say, yeah, I'm a convicted felon, so I'm going to work for $9 an hour for the rest of my life if I'm lucky.
I think for me, what I wrote down was the pressure that my life is supposed to be put back together after I stopped using substances. And I guess that falls in both, like with conjunction of like the community world and then just outsiders, or sometimes what we say is earthlings because they're not quite like me. Like it's I have to work on me every day. It wasn't just a one-time thing like, oh, I stopped using. I'm better now. I go to meetings a couple times a week, go to church 4 times a month, but I'm good. But like, I have to work on that every day, not just on Sundays, Tuesdays, and Thursdays. Like it's an everyday thing. So like the pressure that I don't want to be treated differently, but I am kind of different, and like you're there, and then like everybody has their own perception. I've been addressed. I had one of my dearest friends. She was like, she called herself a junkie one day, which is a really big no-no. We don't say that, but she called herself a junkie one day, and I was like, you're not a junkie. And then I said something about being a junkie, and she was like, well, you're not a junkie because you didn't use needles. And I'm like, what makes your illness different from mine only because you use needles and I used a straw? Like, we both chased it. We both put it before the welfare of our families, our wives, our husbands, our children. It's like we did that. So like that stigma is just as much alive in the recovery world as it is outside that may not know everything. I do highly support more webinars and trainings to help people understand the substance use disorder world and addiction world if you find yourself, taking that role as I'm an addict. Just because it's not a one size fits all. Faces are different, your financial background is different, your race is different, sexual identity is different. That it doesn't hit just one person, it takes down people. I've had issues with the school being transparent and being open about, my struggles. And because of that, it fell on my son, and the teacher said that she wouldn't help us because she wasn't going to do special treatment for my son because his mommy was a junkie. This is what we get from the community sometimes. So it's really hard to be honest, because then you get backlash. But if you're not honest, then it just makes you sick on the inside. You know what I'm saying? Personal question. That was hard for me to answer that one. Because recovery is hard. This isn't easy. You know, out of 3 people that I can see, only one of us is going to make it. And it needs to come with everyone. It doesn't matter if I come from a 12-step fellowship, a faith-based, a non-12-step fellowship, or just someone who has absolutely no idea what it's like to be someone with a drug problem or has not been directly affected by it. We all just need to come together and just accept that this is a part of our world and that we need to love them. You know, like we need it. No more, no less than the next person. But we do need to, you know, just be careful, maybe how we approach people and how we speak our language. That harm reduction language is critical. You know, like I tell my sister, my little sister, sometimes we'll talk about it. And I'm like, it's funny if I say something about my friend being a tweaker and like wearing a flashlight and like digging in her flower beds at 2 o'clock in the morning, but it's not okay for her to say it. Like that's stigma, you know, like it's not okay for me to pick on my friend, and it's not okay for my sister to do it either. You know, we've done things that we're not happy about. And it takes a whole lot for that to come out. So when we're transparent about it, the facial expressions and the words is not necessary. We're already doing that to ourselves. We don't need that from someone else, especially from people that are just like us. Because I come to you with that mutual understanding that we're alike. So I want to trust you and I want to be a part of your life and you a part of mine, because I need social interaction. It doesn't have to come solely from a 12-step fellowship. That's where I was born at. That's where my foundation started out, was a 12-step fellowship. But over the years, like I still attend meetings and I still work steps, but I know that I'm open to other possibilities that I can grow and prosper in that restoration. Because for me, recovery can look different in the lens of all sorts of ways, rather if it's MAT, marijuana maintenance, whatever works for you. It's just, for me, the restoration is that spiritual growth that you get on the inside. As long as you're moving forward and you're growing, you do what you need to do for yourself. But that was my take on that question. Sorry for taking so long.
Stephanie, I really appreciate your vulnerability. Thank you for sharing.
Thank you so much. Anybody else I didn't want to cut anybody off. Does anybody else on the panel want to speak again on that? If not, I'll go ahead and go address the questions that are in the chat, because we got a few and I want to make sure we have enough time to address them. Okay, so Karen South Jones, she's interested in hearing from you guys what you think our communities could do to support people in recovery. And she's specifically thinking about like any like sober venues or recovery, mental health, employment, social support platforms. And if you address this question, I didn't hear it, but yeah, that's the first one.
Go ahead, Ashley.
No, yeah. So I think that that's a great point that you raised about, communities that support people in recovery, about sober venues and mental health and employment. For people who are in recovery, we do lack some options, especially when we were in active use, where we may have, collected some felonies. We lack the ability to maybe get a really good job that we need to feel good about ourselves and to be able to maintain a happy and healthy life. We also do, I know that there's so many things that surround alcohol in our community, right? And that we do for fun. And so once that I take that alcohol away from my life, which is not good for me, and not good for so many people, but that's our option. Once you take that away from me, like, where do I go? How do I have fun? How do I learn how to have fun? Because all I know for me, for 17 years, and even prior to that, because I grew up with parents who actively used, you know, where do I go? What do I do outside of these things for fun? So a venue where I could go and meet people and, you know, learn more about how to have fun would be great, where there's pool tables and darts, because I really thoroughly enjoy those things, but most of those places are in bars, you know, and I could go in there, but it could be detrimental to me, especially in the beginning. And I want to stay away from that for my own well-being, because I know that that's not something that I can handle. You know, as far as social supports, you know, we do have NA, we have AA, we have those 12-step programs, right? But where are the more, we need more social groups that do things differently, is absolutely. So we can learn, like I said, for me, that holistic approach to recovery has been so vital and important. And once I step away from maybe a certain person's mentality, I lack that support that I need. I have to work really, really hard to create it. So to be able to have more places where I can go create that would be amazing.
Anyone else want to answer that question? If not, I'll move on to the next question that's in the chat.
I just want to just back up what Ashley said. I think it's a great idea, and I love the question and how the community can help. I mean, it's like I said, both of us have our equal stigma in the recovery world and abstinent world, but when we can conjoin it and defeat that and welcome all walks into like a community event where we can like hang out, drink coffee, have cookies, listen to live bands without the pressure of buying alcohol or the transaction of drugs. Like, it's going to be around us. I'm one of those that I was taught early on, like, I can do an environmental change and sometimes it's necessary, but no matter what, I'm taking me with me. So like wherever I go, you know, so I can be vigilant, you know, but I think it would be great for, you know, our communities to coexist with one another and have communal, sociable events, you know, that we can, and kid friendly. It's so hard to be a mommy in recovery, because when I have a kid, they're like, oh, this is just like for adults only. And so like I get stuck at home with my 10-year-old son, and he already has like social issues and ADHD. So like he doesn't do well with large crowds and a lot of activity, like, you know, and so we're working on that, and that's a personal outside issue. But, you know, like more involvement with our children so they can have, you know, kids to play with. I mean, our kids, you know, well, for my kid, also had an impact because of my substance use, you know, so I think it would be great for him to have some type of social outlet and to not feel alone, and have kids with similar common backgrounds, like not necessarily sit around and talk about war stories about their parents, but I mean, like, you know, that my kid has someone to talk to. I think that would be helpful too. Just another community thing we can maybe look at later. Yeah, I'm good. Next question.
No, you're absolutely correct. And to add to Ashley and Stephanie's point, you know, if you know me at all, you know, I eat, sleep, and breathe old cars. That's kind of my thing. And the group of guys that I hang out with, like, you know, alcohol use and drug use really isn't a thing amongst those guys. None of them are in recovery, just none of them actually use. And you know, I didn't become a part of this group with the intention of being around people that weren't using, specifically in relationship to cars. I became a part of this group related to cars specifically. And then I found over the years that the foundation that I was giving in mutual aid fellowships actually was really transferable to this relationship of people that I have. And I've got a wonderful group of people in my life that, if I want to talk about recovery, I can talk about that, but I don't have to talk about it 24/7. Like, we have lots of other things to talk about other than just recovery by itself. And as a byproduct of that, I think it's helped me, you know, later on in my recovery, it helped me be more stable in my recovery, because, you know, what you focus on is what you find. So it's been really helpful for me. So yeah, to Ashley and Stephanie's point, you know, community, having a strong group of people to interface with, to interact with, that are supportive, that genuinely, like, more than anything, just love you and care about you and want to see you do well and succeed in life. That's extremely important. And let's be honest, whether you've lived with addiction or not, is there any person on this that doesn't need that? You know, like that's what we all need as human beings. And again, you know, I think that's kind of some parts that we miss sometimes. You know, when we're talking about recovery, is we think that it's just about not getting high anymore. Really, we need the same things that we all need.
The next question is from Judy Klusman. And the question is, what specifically do we need to change? What specifically do we need to do to change the barriers? And is there a place for counties in this discussion?
Yeah, counties are the head. Body follows the head. If county commissioners, if the powers that be are role modeling and exemplifying recovery language, person first language, you know, if they're showing that they take this seriously, not just one person on the on the board of commissioners, but everyone, you know, is demonstrating that they take this seriously, that it's something that's important. You know, that could be a huge signal to folks in the community. It's like, hey, this is something for you to take serious and you know, see as important as well.
And Dalton, I know you can probably speak a lot better about this than I can, but it seems like so often a lot of barriers that we end up meeting are due to maybe old laws that haven't been revamped in some time, organizational policies. I mean, it's crazy to think that something as little as not having an ID can be the difference between someone receiving treatment and not receiving treatment. And at the end of the day, like, how important is it really? Or can we make getting an ID easier? I think oftentimes it's just time to kind of revisit what already exists, see what's keeping us from being able to do what we need to do, and you know how far we can push the needle to make it easier to access treatment, to advocate for more treatment options, to advocate for recovery communities, whatever the case may be. I think just taking some time to take a deep breath, look at what exists, and see what can be changed or amended.
Yeah, if I had a nickel for every time, here's another nickel story, but if I had a nickel for every time that I've provided education to a group of people in the community, and you know, and shared my lived experience alongside that education, and you know, the feedback that I get is like, well, that's your opinion. I'm like, no, that's actually not my opinion. Like, I understand that your opinion disagrees with what I'm sharing with you, but like, it's not an opinion. You know, this is not only lived experience, but also it's steeped in science. You know, what we talk about, you know, in relationship to education, like we've got decades of science to back this stuff up. And if it could be taken a little more seriously, and if people were a little more open and willing to be educated, I think that would go a long, long way. So my encouragement is be the change that you want to see.
I want to echo everything that was said. You know, I think that one of the things that is unfortunate that we oftentimes don't realize is that money talks, and we may realize it. You know, so the folks that have the power with the money, the county commissioners, the folks in government, you know, they need to be pushing treatment providers to make change and to you know, edit these laws and these policies that they have, because essentially, you know, the more money that we put into treatment and prevention and harm reduction, the more money we save as a society. So, you know, I think looking at that, because we live in a, let's be real, we live in a society where money is a huge motivator. You know, it's sad that we live in a society where that's more of a motivator than human life. But that's just how it is right now. And I think that we need to use that, use the awareness of knowing that to influence policy.
And to Jason's point, you know, every year as a nation, we increase budgets in relationship to incarceration, and we often decrease budgets in relationship to treatment. unless it's medication assisted treatment, and you know, we have increased those budgets a little bit here and there, but you know, and MAT certainly has its place. It's very valuable. It's a very valuable tool, but it is a tool. It's not the silver bullet. We have to invest in our communities.
If there are no more responses, I'll move on to the next question. Judy asked another question. Are any churches hearing your pleas for help, and are they taking action?
So I just recently found a church that I'm comfortable with, because boy, oh boy, I really thought that I would like smoke and fall in flames when I walked on their doorstep, but I haven't. I'm feeling good. So the church that I'm affiliated with has a group for men. They use the recovery language to insinuate, not saying like, hey, addicts here, but like, if you know, you know. And they do have a faith-based intimate group for men. Unfortunately, they do not have one for women, and it's not co-ed. I wanted to say something, but then I got really embarrassed, because once again, I feel like I'm doing it to myself. The church has never made me feel uncomfortable. They make you feel very welcomed, tattoos and all. The preacher himself and his wife have tattoos. They're amazing. But I've thought about asking, hey, could someone start one? I don't know enough about the Bible and all that to even do the group, so that's not my calling. I'll be one to sit and read with you and challenge you with lots of questions so that I can understand. But yeah, but my church so far, yes, they do have a group. Addicts. Yeah.
I don't go to church, but I will say that here in Guilford County, GC Stop actually operates our syringe exchange out of the basement of a church. They've been super supportive of us. They've written grants and got us money so we can continue to provide services. They're a huge leader in our community for justice, for, you know, just increasing equity among like equitable health outcomes, and just advocacy in general. They're really great.
I think that, you know, I've seen so many churches, you know, there's a lot of programs that I found, you know, for treatment that are faith-based, you know, that they're fueled by the Christian community. There are churches here in Rowan County that, you know, are partnered with treatment programs and halfway houses. And we're really grateful for that, you know. So many churches have heard the plea. I think the only thing that I've seen with that is, again, you know, not having the, you know, that holistic approach to recovery and understanding what it is and how they can help, because they really want to help. They truly want to help, but just learning more how to help, right? So they're taking action, but how can we take action more effectively?
Yeah, to kind of build on Ashley's point there, I remember a couple years ago, there was the Hope Over Heroin event that was in Kannapolis, and you know, a lot of resources were pulled into that, a lot of money, a lot of time, a lot of effort, and I certainly appreciate that. I really do. But I do remember approaching the gentleman that was kind of heading it up and asking him if him and his people that are putting it together would be interested in some education on childhood trauma and its relationship to addiction, and, you know, just trying to help them be more person-centered, trauma-informed. And they were like, no, thank you, we got it. We appreciate you. And, you know, I'm not saying that, you know, they didn't do anything, or, you know, they weren't successful in their efforts or what have you. That I don't know, but I do know that that was a lot of effort and a lot of time, a lot of money put into a situation that with a little bit of education could have potentially been more impactful. So yes, I definitely see a lot of faith-based organizations helping. I see some faith-based organizations that are very holistic, as Ashley put it. that are really helpful. And then there's some that, they have their own view and agenda of how this works. They're not really interested in hearing, the science behind it, so to speak.
Thank you. And then one last question to wrap us up. Are there any programs that will use Medicaid or managed Medicaid to pay for MAT in this region, if you know?
I can't speak specifically for Rowan County, but I know that there is several in Guilford County, ADS and Bethany Medical Center, Triad Behavioral Resources. There's actually a good number of them here in Guilford County.
While I do work for Partners MCO and formerly did work for Cardinal, I'm no longer in Rowan County specifically, so I can't answer that about Rowan County specifically, but I can tell you in neighboring counties, there are resources for those folks.
I believe that Nazareth Family Services, if I'm not mistaken, takes Medicaid for MAT. I'm almost positive. I see Stephanie shaking her head, so they do. And then, but I do know that there's a lot more resources outside the county that take Medicaid for Medicaid or for MAT for sure. But I know that's one for sure in this area in Rowan County.
Center of Emotional Health in Rowan County also provides MAT. I believe that the methadone clinic there off of Jake Alexander also does more than one method than methadone there. You may be able to follow up with them. There's a few other places. Who asked that question? Was it Chris Watts that asked that question?
Yeah.
I will, I had a URL thing that I had saved on the computer. I was hoping that I could find it more quicker, but yeah, I'm all thumbs at this moment. But I want to say that I had some type of website that you can go to and kind of put your location and what you're looking for, and it'll give you a list of detailed information about MAT providers in, I think, like the state, but then you can break it down to county and then your mile radius and so forth. If you want to keep talking, Natalie, or how long is this platform going to stay open?
The platform will be open for the until like 3:30. So you're fine. Whenever you want to drop it in the chat, you can.
Yeah, I'll do that, or I can just email it to you. And if you want to disperse it to everyone that was involved, everyone, if you want to use it, you can. If not, it's
I can do that.
It's a resource.
Stephanie, is that Aunt Bertha by chance?
I don't believe so. I actually accidentally kind of stumbled across it doing some digging for a participant that was looking for some things. And I'm like, oh, well, isn't this nice? It's like an MAT Bible. Let me just save that on the desktop. And so I did. And it was interesting. I was able to find that and like different treatment options. And I even have that resource. It's quite long, but it's one of those things that Sherry and I had worked on. I think I borrowed some information from Ashley Creek's resource and just made a big like living, breathing treatment option. And it's broken down to like outpatient, inpatient detoxes, anything you want to know about those places, we can, it answers it there for you. I still would suggest a call because now with pandemic, I don't know what that looks like. They're in through their lens at this point, but then it offers like treatment options as far as like halfway houses, well, not the Oxford House, that's a whole nother page, but I've got transitional treatment centers, co-ed, men's, women's with children, long-term, short-term. It's pretty diverse in the treatment world. I created that a few months ago and just kind of let it sit there and collect dust. So I have that too, if that's any of support.
Right on. Yeah, and just so you guys know, if you're ever looking for resources anywhere in the state of North Carolina, and you don't know, you don't have anybody that you can reach out to or whatever, you're in unfamiliar territory, what have you, you can go to Aunt Bertha just Google search Aunt Bertha, and you can type in what resource you're looking for and what your zip code is, and it'll pull up all the resources related to that in that area around you.
Is the NC Care 360 similar to Aunt Bertha? I'm just learning about the NC Care 360.
I don't know.
We've started doing it here at CHA, and I feel like some people were still using Aunt Bertha, and then some of us transitioned from Aunt Bertha to NC Care 360, but I'm still learning how to use it. But from what I can tell, it's really cool. It's just a couple of clicks. You log in, you specify what you're looking for, and then it pulls up a map with the radius ring, and it shows you where the locations are, what they offer. And then it gives you an easy printout button, or you can text it to the person, or you can email those resources that you looked up, and you can provide them the resources via text, email, or a printout. Super neat.
Yeah, Kelsey said that it's the same.
Oh, okay. Thank you. Yeah. Oh, yeah. So that's what we use here with Aunt Bertha. I've heard they're equally amazing. I guess it's just choice preference or whatever, but yeah.
Well, so NC 360 is actually from the state. So DHS kind of put that in place so that everyone in the state has access to providers. And Aunt Bertha is more like locally, you know, I know Atrium kind of and Cardinal had paid for the platform so that we can have those local resources available for the communities. And so it, you know, they call it something different depending on who the organization is, but it's just a search tool. Both of them are really great. NC 360 is kind of being a little bit more mandated or required. So it's going to probably transition into that eventually. A lot of providers are still getting trained and kind of, you know, getting all the ins and outs about it. So yeah, it's in progress. So, but both of them are really great search engine tools.
Thank y'all so much for speaking. I really appreciate y'all for sharing your personal stories and just kind of speaking from your perspective. I know that takes a lot of strength, and I view all of y'all as heroes that just don't wear capes. So I appreciate you so much. There are also some resources, local churches and agencies that were dropped in the chat. So if you want to know more about those or see those, please refer to the chat to see them. Right now, we're gonna take a break. Please come back. Just a quick 7-minute break. So if you need to use the restroom, throw something away, you know, whatever you need to do during that time, please come back at 12:40 so that we can reconvene into discussing prevention, harm reduction, and treatment and recovery options. And then during that time, I'll give you some more instructions before we move forward into that. So see you guys back at 12:40. And on certain aspects of the continuum of care, prevention, harm reduction, treatment, and recovery. And before we do that, let me just tell you, so CEU credits are available for this event. And to receive those, you need to fill out the survey. I will send those out to you via email after the event has concluded, so that you can submit those to me. If you do not need CEUs, please do the survey anyway, and I will send you a certificate of completion. And if you have any specifics, I know I received an email earlier, but I haven't responded to it yet. I just saw the name pop up about it. Just reach out to me by email and we can talk about it. If you need both or something like that, just let me know. From here, moving forward, we will, in order to discuss each of these three things, these three different aspects of the continuum of care simultaneously, we will be in breakout rooms. I have 3 breakout rooms, and what you will do once I publish them, you will see the prevention and harm reduction, you'll see treatment, and you will see you'll see prevention, you'll see harm reduction, and you'll see the treatment and recovery tracks. Just join whichever track that you are interested in hearing about, And if you want to hear the other tracks, it's absolutely okay. Again, each one of these each one of these presentations will be recorded, published on our port webpage, and also available on YouTube. So it's okay if you want to hear from prevention, but you also want to hear about harm reduction. Just choose one for the day, and then we'll get back to you with the information for the recording when that is available and published. Okay, so I'm about to go ahead and open the rooms up now so that you can join them and give the presenters a chance to join. So all of my presenters, you should know. I'm just going to give a rundown just in case there's no confusion at the start of this. Dennis Rivers, you're in prevention. Jessica and Lindsay aren't here yet, but they're also going to be in prevention with you. I am going to be doing the harm reduction presentation. Elizabeth Brewington, you'll be with me. Okay, I see you. And then Ashley's going to be in our treatment and recovery tract, and along with Melissa Larson, who isn't on here just yet, but I'll catch her when she comes in. Okay, so join the one that you're most interested in. I just made those live. If you are, what are your thoughts on this? Harm reduction programs are a hub for a variety of health and social services, including sterile supplies for IV drug use, blood pathogen testing, vaccinations, treatment, and recovery services.
Fact.
Absolutely. Absolutely.
Got lots of people in the chat saying fact as well. So
yeah, I'm looking at it and I'm just smiling because I'm like, yay, okay. It makes me feel good. Okay, so then the next one, harm reduction programs increase IV drug use.
Myth.
My heart is warm. I'm seeing a lot of myths. That's good. That means we don't have to do a lot of backtracking in this conversation. Okay, and then the last one, harm reduction programs reduce the risk of bacterial infections and the spread of bloodborne pathogens. Look at God. I got a lot of forward-thinking people in here that are aware of harm reduction programs, so I don't really have to dive too much into dispelling these facts, but I'm going to go over some really quick, if I can get mine. So harm reduction programs, people who access harm reduction programs and utilize these services on a regular basis are more likely to reduce their IV drug use, and over time stop injecting. And then another one, people that use IV drugs on a regular basis and access syringe service programs are 5 times more likely to enter treatment for drug use. And that's really because they get those continuous touch points. They have someone they know for a fact, without a doubt, that there's someone out there that is going to be able to provide them with some unconditional support, resources to get the help that they need for when they are ready. And that's really a big thing about it. It's not about pushing people to be ready, it's just being there for when they are. And on top of that, folks that are using syringe service programs, they are getting those supplies, and those supplies, again, reduce the risk of getting infections, bloodborne viral infections, and the like. And people who are healthy during active use have more hope that things can be better once they decide to walk into recovery. When you have someone that, and I've heard this volunteering at the syringe service program, the folks that that are diagnosed with Hep C and other viruses, they just sound, and they are very truthful about this. They just seem a lot less hopeful about things, the circumstances in their life being able to change, because they don't have the hope of once this is over, I can walk away from this journey and really rebuild a new life. They are left with that health condition that is a consistent reminder of how the decisions that they've made. So harm reduction programs are an amazing resource for people that use substances. And addiction is a ritualized compulsive seeking behavior, a compulsive comfort seeking behavior used to cope with negative traumatic experiences for which they were not given healthy alternatives to cope with during childhood as they have grown older. And we talked about this during Scott's presentation, during the panel. It is a result of trauma. And a lot of folks, unfortunately, like Scott was saying, based on our genetic makeup, based on our chemistry within our brain, everyone doesn't end up being addicted after experiencing trauma, but there are some folks who experience a extreme amount of trauma, and without the environment, the supportive environment to teach resiliency skills and coping mechanisms, and a lot of this times it's learned behavior, and the only behavior they've learned from childhood is substance use, then that is their coping skill. So CRM is just an added bonus to that, to just improve the circumstances for that. So I'm going to talk about resiliency as being a protective barrier against the effects of trauma, and bring attention to everybody experiences trauma. I guarantee you there's not one person. It might not be what you think of on that ACEs list, which is kind of, it was triggering for me to read that ACEs list, but you know, everyone doesn't have those things on that list, but you've been through a breakup, you might have been in a car accident, a lot of other situations that could be deemed traumatic, but just not on other people's radar but I'm not big on putting people's pain on a hierarchy. Pain is pain, whether or not you had a family member that was in jail or died from an overdose, or you had a parent who had to be hospitalized suddenly. I've had all of these things happen to me, so I can understand. So we need to, with having trauma just being a given in life and having these negative experiences being a given in life, we need some type of cushion, and resiliency skills are that cushion. And here are just a list of characteristics for resilient children. So when we start with them early and we teach these folks that are in active addiction or in recovery, and they have children, and we teach them resiliency skills, they can pass those resiliency skills along to their family and their children, who can become more secure within themselves, more in control of their reactions to their external environment, more competent about their environment, how to respond to it, how to just behave in certain given situations, more confident within themselves, great contributors to the community, just a strong sense of who they are, and just being overall more connected to the community that they live in. So I use this picture flower that bloomed from the concrete because it's really just a testament to what a resilient person is at the core. It doesn't mean that you don't have any type of hardship. It just means that you can push through it and come out on the other side. And I can imagine being that flower in the concrete, how hard it was to come out, but they made it out. So here are some of the reasons why or how CRM can empower people that use drugs. So it empowers people by helping them to regain control of their bodies during and after a traumatic experience. One of the things that we learned during our CRM training was understanding sensations versus emotions. Sensations being a stimuli that our organs being stimulated from something internal or external, and having that power of noticing the sensations within the body, we can very easily be able to sense, this person, this place, this whatever, the smell is making me feel dis-ease instead of at ease. And because I can identify those internal sensations sooner, I can learn how to redirect and shift my energy into a more positive space. For me, for example, speaking is not like one of my favorite things to do. I've never been the type of person to jump forward to do public speaking, but because I know that I can redirect my energy into finding other skills that can help me concentrate and actually push through to do things that actually scare the heck out of me. I'm trying not to curse, but yeah. So And one of the skills we talk about is CRM is help now skills. So those type of skills can be very helpful for people that are in situations that can be very traumatizing or re-traumatizing for them, so that they can shift their energy into something that is more calming and brings them back into their resiliency zone. CRM gives individuals the ability to appropriately respond to potential triggers. And see, that's another that just kind of goes into what I was saying about having, we all have some level of trauma or some type of memory that wasn't the most pleasant to us, but being able to manage that is something that CRM teaches us and imparts in us, as far as understanding what the triggers are, and then understanding what our physiological responses are to those triggers. And being just that knowledge alone can help people navigate their experiences in the environment, whether that be avoiding the triggers altogether, which that is very hard to do sometimes. I get triggered all the time. So it's more so giving you the power of understanding, I know what my triggers are, and now I can cope, and I know what my physiological responses are to them. Now I can do some internal coaching, some reparenting, some just kind of internal counseling to coach myself through how in future situations when I am encountered with that trigger, how to respond appropriately so that I don't lose my job, so I don't get arrested, so that I don't get a fine, or so that I'm not put out of a place that I actually love to go to on a regular basis. These are things that happen, especially with people that have experienced extreme amounts of trauma and they're triggered into their flight or fight modes on a regular basis because of the different types of trauma they've experienced. So CRM also provides people with teachable skills that can be passed along to their family and friends. And so I spoke about this a little bit. So CRM is the great thing about it. It can be used among people in all age groups, all races, all demographics, all professions. And the skills are they're extremely teachable. And you don't even, especially for somebody during our CRM training, one of the things we saw was an example of a 2-year-old learning CRM, just because some of these help now skills and these behaviors are very more physical than they are communicative. So you can really, once you learn and master the skills for yourself and you learn to model those skills when you are triggered or when you're in a place of discomfort, you can reflect those out to the people that you care about, so that then you turn your whole household, your whole community into a space where everyone is more resilient, it's more calm, less chaotic. And overall, CRM helps to widen an individual's resiliency zone. I learned these CRM skills February 2020, and I have always never diagnosed it, just because one of the things in the Black community that is not talked about is just it's talked about, but just not as much as it should be, is the mistrust of medical professionals. Even when I was in college, I did not take advantage of the free counseling services there, because it was just this level of distrust and this kind of underlying feeling as a Black student in a PWI that I would not be understood. So why even express myself? I had a tremendous amount of anxiety that had not been addressed. And ever since I have been doing these CRM skills, I feel so much more at peace about just life. And I'm so much better able to respond to things that are happening to me in my space. And it's almost like now that I've practiced them intentionally, it's second nature to do a lot of these things. So that's what we mean by widening the resiliency zone. Initially, it's a struggle to push through, especially if you're on that end of the spectrum where you're kind of like, and once you start practicing and pushing through and learning the skills and holding yourself accountable to practicing the skills on a daily basis, you really do it without even thinking about it after some point. So I put this together to just throw the principles of CRM and the principles of harm reduction side by side so that you can see them. The principles of harm reduction, there are actually 8 of them, and I did insert the link at the end of this presentation so that you can refer to that and read all of them. But I just pulled out the ones that I thought were the most relevant to this presentation, and the ones that are most relatable to CRM, more so to speak. And so I highlighted some of them. The main part of the principles of harm reduction is a non-coercive, non-judgmental provision of services and resources to people who use drugs. And that's a big part of CRM in general. It's just about being non-judgmental, is about identifying people's strengths and identifying that they need skills and they need compassion so that they can be able to learn those skills over time and grow as resilient individuals. Another thing that I highlighted, people who use drugs themselves are the primary agents for reducing harms within their drug use. We as a society tend to push folks into just stop it, just stop it, just stop it. But in reality, people do not stop until they're ready, until they feel comfortable enough to where they have the skills, the support, the resources to transition into abstinence or whatever based recovery they'd like to be in, because there are so many different forms of recovery than just abstinence. And that's a big part of CRM and what CRM does, and it's focusing on just being a help to people and giving people tools so that they can make their own transitions into healing, mind, body, and spirit. It's a more holistic approach. And I inserted this slide from the Trauma Resource Institute, the CRM presentation, to kind of explain. So trauma informed is where a lot of people are right now, understanding what trauma is, what the ACEs are. People are suffering. People need an effective intervention. Many people care but lack understanding and skills. We need to learn how trauma impacts a child and adult's development, and it focuses on the question, what happened to you? So when I think about these questions, I think a lot about what harm reduction is. It understands that people come from socioeconomic backgrounds that aren't advantageous to their success. It doesn't give them the skills, whether that be financial literacy, mental health. There are a lot of different things that put people at a disadvantage that harm reduction focuses on so that they can meet those needs and help people get to where they want to be. With CRM takes it a step further and pushes people into thinking about resiliency and not just what happened to you. It focuses on people's strengths. What's right with you? What are your strengths are the questions that CRM asks, because it helps people to shift focus. And one of the things that we learned in CRM is what you focus on grows. So it's more about, okay, we know all these things happen to you, and I'm so sorry all these things happen to you. But now let's think about some solutions and the positive aspects about who you are as a person and how we can support those so that you can show up how you want to show up, so that you can engage in new environments and social groups, so that you can have your dream job and you can keep your dream job. So that is what CRM empowers folks to do. And it just kind of takes harm reduction and just kind of pushes it a step further so that people are actually having skills that they can take on and just conquer the world with. So at the conclusion of my presentation, and I want to just make these points that using CRM in these situations makes harm reduction programs more than just a service hub in a space for unconditional support. And what I mean by that is when we teach, what happens when we educate all of these folks that are leading these harm reduction programs about CRM, and they learn the skills. And then so when they're in situations, and me volunteering at the Syringe Service Program and Cabarrus Health Alliance, I know just from talking to Stephanie and being around Stephanie and just seeing her interaction, there are situations where she's also triggered. So what happens when we teach her and other people that are in the same positions as her, those CRM skills, they can model, they can practice them, they can stay regulated, they can interact with people in a more effective way, and it doesn't throw them off and shift them from their focus of recovery too, because these people are also still in recovery, growing and learning as people as well, as Stephanie spoke to that. Not only that, it not only does it strengthen them as people, but they can take these skills and teach them to the participants that come in. And everyone that comes in, they get services, they get supplies, resources outside, and they also can take little skills that they can practice outside in the real world. And over time, CRM strengthens and builds resiliency that could over time empower people who use drugs with more coping skills to effectively reduce their need for use of substances and as a coping strategy. Because again, we said with addiction, it is a compulsive, I might be wording this wrong, but it is a coping mechanism. And so if we give people more skills that they learn and they can regulate themselves, they don't need to cope, because they've learned how to naturally, from a holistic approach, navigate the hardships of life and stay within their resiliency zone or bounce back into it more easily. And so the last point, CRM values the perspective that anyone can learn self-regulation skills, which can improve mental health and life outcomes. Because once you're more resilient, again, you can maintain social settings longer, even after being triggered. You can interact with people, places, situations, things, and really kind of push through life, even though it's hard and tough. That is my presentation. And if anyone has any questions, if not, I am going to open the platform, open the door up for Elizabeth to go ahead and do her presentation.
Could you make me a co-host so I can screen share? Sorry, I accidentally logged out of the Zoom meeting earlier when I was trying to leave a breakout room.
Oh, okay. I made you co-host earlier, but now I can't even. Hold on now. It's not letting me make you a co-host again right now. I don't understand. Lord,
messed it up. I'm sorry.
No, you're fine. You're fine. I don't understand why it's not letting me, the host, make you do. Okay, let me answer this question before I stress myself out with that. Do we still have a mobile exchange in Rowan, and what other harm reduction is in Rowan besides PORT? Well, PORT isn't a harm reduction program. In essence, we are opioid response, so it's more so the Band-Aid method, I like to call it. But Angela might be able to speak more to this. So we just had, why is it ending? I don't understand why the break room, no.
Well, quick answer before it cuts us off. Yes, the mobile exchange is still running in Rowan County. It's really starting to grow. And Matthew Boardman is our new county coordinator for that. So if anybody wants to get in touch with him, feel free to reach out to me and I will share his contact information.
Thank you. And we're probably about to get kicked out of here soon. I assume that what happened is somebody accidentally hit in all break rooms. So we'll figure that out, but we're going to come back into here. So I'll just I see everybody's names. I'm just going to reassign you to this space. And I'm so sorry, but I have no control.
Yeah. Oh.
She's handling it much better than I am. I would be, though. I can tell you that, because I would be losing my mind. And
well, it's probably not helping that I'm her boss. You know?
No, it's not helping at all, Angela. I think you should jump off. And like
I know, really. I know. I feel a little bad about it, even though it's, I totally get where she's coming from.
That would be the worst.
Y'all,
like,
believe it or not, we practiced this several times.
Oh, I'm sure we did. No, Zoom does what it wants to do when it wants to do it, and that's just how it is.
It really does.
No, we've been, I mean, I've been in Zoom meetings like all day today, and like everyone is having tech issues. Actually, I think it started yesterday.
It's totally, yeah. I attended a conference like 2 months ago where I couldn't even log into the panels, and I was like presenting on one. So this is a dream compared to that. Y'all are doing great. We're still missing a few people, so I can get started, but I also don't want to leave anybody out.
Wow, I just noticed when I was typing my message to Christopher, it's Matt Boardman, not Matt Ford. Sorry. And his email address is boardman@preventionservices.org. So forgive my sloppy typing, but you're going to love Matt.
Thank you so much for sharing that with me. I get a lot of folks here at the hospital that can definitely benefit from the mobile exchange.
Oh, yeah, we'd love. I'm sorry, go ahead.
Well, before I was given a number for folks to text, and that text number was 704-662-5667.
I don't know. All of our numbers that we use burner phones for our syringe access program coordinators, because we don't want people having their cell phone numbers. So I don't know if that number is correct off the top of my head, but if you go to our website, which is qchr.org, you'll be able to find correct and updated phone numbers there. I'll type that in too.
And is that through the Queen City Needle Exchange?
Yeah, except that we've rebranded to Queen City Harm Reduction, because we wanted to get away from the idea that this is a needle exchange. It's not an exchange. You don't have to bring a needle to get a needle. We would like for you to bring back reused needles, but we don't require it.
So I had to jump into the other room to help Amy Smith out for a second. So I missed Elizabeth. Did you already start your presentation?
No, I was wondering if I should start or wait for everybody who's missing to join.
I think the only person that we're missing is Natalie. There she is.
There she is. Okay. I can totally start. There we go. Well, I'm Elizabeth Brewington. I work for the Partners in Health and Wholeness program, which is a part of the North Carolina Council of Churches. So the North Carolina Council of Churches has been around since 1935 and represents 18 different denominations across the state of North Carolina, and works on a range of issues, whether that's creation care, pay equity, health, etc. The Partners in Health and Wholeness program has been around for about 10 years, and we work with faith communities and their health ministries. And we have programs that focus on mental health and providing congregations with the tools to become trauma informed. We have a healthy aging program, but we also work with congregations about healthy eating and active living. We also give churches mini grants of up to $1,000. So if a church really wants to get off the ground, we can kind of help them out financially. So Natalie and I had almost the exact same mind when we were talking about harm reduction. I chose very similar photos to kind of start off going off harm reduction 101. And so since she covered that, I'm just going to skip over these really fast. And also, since Natalie explained harm reduction so well, I'm going to skip over this as well. I just wanted to focus on what I really connect with in harm reduction is that it's centered on dignity, compassion, and hope. And particularly as a person of faith, that's really key for me when talking about harm reduction and faith communities. I also really love this picture. It's of Michelle Mathis at Olive Branch Ministry. It says neighborhood hope dealer. I just think it's so good. And then again, we've already gone over the definition of harm reduction. We all passed the myth or fact section, but I just wanted to focus on this picture about respect, dignity, and compassion. So with Partners in Health and Wholeness, our work around educating faith communities about harm reduction started 3 or 4 years ago. And we initially surveyed congregations and asked, has your congregation been affected? What do you view your role as when it comes to substance use? What are the spiritual needs of your community? But also, what resources do you know are available in your community? And we found that most congregations said that they had been affected, and that pastors, faith leaders viewed their role in the community as a connector to resources, spiritual advisor, educator, mentor. But when asked what resources were available, they really didn't know. Maybe they would mention an NA or an AA program, but outside of that, they did not know what resources were available in their community. So in 2019, we launched our Clergy Breakfast Initiative, where we would go to local communities and we would host a breakfast for all the faith leaders, and we would partner with a local harm reductionist and do a harm reduction 101 training. We would try to connect clergy with their local resources and then give them some handouts and tools such as stigma reducing language, how prayers, different liturgies, so they could start incorporating some of the ideals of harm reduction into their worship services. And then we've been doing some resource collection, and I will point y'all to some of the resources at the end of this presentation. I'm also part of the National Faith and Harm Reduction leadership team, which does this work nationally, trying to connect people who use drugs with spiritual resources, but also faith communities who want to engage in harm reduction with resources as well. So, how harm reduction connects to faith. There's a few ways that I tend to do this, but I also heavily encourage using your own spiritual journey and your own kind of language when talking to faith communities about this. But where I tend to start is with the golden rule, because almost all religions have some concept of the golden rule. And do unto others as you would have done to them. I mean, this rule commands us to see the humanity in our fellow citizens, our fellow people, and to ground everything we do in dignity and respect. And so that is harm reduction. I also connected into the Gospels. Jesus went out and he healed people. He met people where they are when he healed them. He didn't make them come to them. He also didn't require them to have a theological conversation before he helped them. When Natalie was talking about going to the dentist and the dentist not serving you because you ate candy, the dentist doesn't also preach to you before they help you. So if harm reductionists or faith communities are going to engage in harm reduction, they shouldn't require a theological conversation to do that. And then finally, I like to use the story of Lazarus. So for those who don't know, Lazarus was one of Jesus's friends, and bless you, Lazarus' sisters had wrote to Jesus and said, hey, Lazarus is sick, he's dying. And so Jesus waits, and he waits for 4 days after Lazarus has died. And according to Jewish tradition at the time, after 3 days, that's when your spirit leaves your body. So you are really dead. So Jesus waited until Lazarus was really dead. And then he came and he found Lazarus's sisters and he grieved with them. He was with them. He was present. He cried with them. And then they went to the tomb. And of course, because it's Jesus at the time, there was quite a ruckus and people were very intrigued about what Jesus would do next. So a crowd gathers. And Jesus stands in front of the tomb and he says, "Lazarus, come out." And that's when Lazarus comes forth. And then the next part of the story, I think, is really key. Jesus calls to everybody in the crowd and says, "Go unbind him." He commands the crowd to get rid of the barriers that Lazarus had. And we heard all about the barriers people are facing right now at the Lunch and Learn. And so I think this is a real call to action for faith communities to work on removing barriers. And there's a spot for everybody in this story, which I think is also powerful for faith communities to hear. There's a spot for somebody to be present and to help people grieve. There's a spot for people to watch and spread the good news of harm reduction. And there's also a spot for people to actively work to remove barriers. So when I'm talking to faith communities, I often try to frame harm reduction as a ministry. And I share this quote that I really love by St. Augustine that says, "What does love look like? It has the hands to help others. It has the feet to hasten to the poor and needy. It has the eyes to see misery and want. It has the ears to hear the sighs and sorrows of men. That is what love looks like." And so when thinking about harm reduction ministry, how can you show love? And so the first thing we do to show love is to use stigma reducing language and to center the person. So we really encourage and try to get all faith communities to start incorporating person first language in everything they do. I have a colleague who does trainings around person first language when it comes to suicide or to mental health. And so we're really trying to make sure that faith communities are fighting stigma, because for so long, I feel like faith communities can be real sources of stigma. We also encourage faith communities to think about ways they could get involved. So maybe a medication take back, where they could have bulletin inserts and a newsletter and a day where everybody can turn in their unused expired medication. Transportation ministry. Some churches have vans or buses that they don't use outside of Sunday when they're picking up people to go to church. So maybe that they could use that church van to provide transportation to MAT or to visitation with a child or just to get around town. We know that transportation is a huge barrier to people. And so if a church could possibly alleviate that barrier, it could be huge. A church could hold a naloxone training or a naloxone kit making. Basically, they could put together bags so an SSP wouldn't have to do that. Also, during that process, churches could learn how to reverse an overdose. I also really encourage people to think outside the box. These bags are from the Catawba crafters. They crochet these washcloths. And then at the top, it's really hard to see in these pictures, there's reflective yarn. And so Olive Branch Ministry has been using these bags for Narcan. So people get to come in, pick out what bag they want. And then because of the reflective yarn, you can find it with a flashlight, any source of light, and you know where your Narcan is. I think this is a really wonderful way for people to show love and do something they really care about. And it's not necessarily running a syringe exchange, or some people aren't comfortable with that. And so finding another way to show love and help people. Churches are really good at supply drives. So thinking about how a church could do a supply drive to support harm reduction. Could they do a supply drive around wound care kits or Band-Aids or whatever? Maybe they could help supply things for their local syringe exchange. If they can't do a supply drive, could they pack SSP kits or could they pack Narcan? Churches tend to have a lot of volunteers and can come together and do things. So how can they support harm reduction in those gatherings? As we talked about earlier at the Lunch and Learn, everybody needs support. So how can churches do that? How can they provide support groups? Maybe it's families who are directly impacted. Maybe it's a grief support group. Maybe it's a harm reduction works or a celebrate recovery. There are so many different ways that support groups could be held to really support people throughout the recovery process and throughout their journeys. Maybe a church has some space and they want to support a syringe exchange by opening their doors. Twin City Syringe Exchange in Winston-Salem and Guilford Park Baptist and Guilford County. Twin City Needle Exchange is out of Green Street UMC, and Guilford Park Baptist partners with GC Stop. Then there's also First Pres in Hickory that has a holistic harm reduction center with a olive branch ministry, where they have a syringe exchange site, but they also will hold paint classes and drumming classes. So people at the church can come and engage in those things with the people who participate at the exchange. Or maybe a church just has a parking lot or a closet that a syringe exchange could store stuff in. So now kind of transitioning to resources. If you know of a faith community that's not sure how to engage in harm reduction or hasn't really started thinking about harm reduction, these resources are really great for that. The Faith and Harm Reduction Spirit of Harm Reduction Toolkit is a great resource. It makes the case for why faith communities need harm reduction, and it educates around drug policy and substance use. There's a bunch of different spiritual resources that are sermons, poems, short stories, and that gives faith communities concrete action steps of how they can support harm reduction policies and practices in their community. And then we at the North Carolina Council of Churches has come up with a 6-week Sunday school guide that helps walk churches through what is harm reduction, how they can get involved, and it includes prayers and different worship readings. We're hoping that it could be helpful for small groups to really dive into this. I know it went really fast. My coffee just hit and I started talking and haven't been able to slow down. I'm so sorry. But I'd love to kind of open it up and hear your experience working with faith communities. Are there any challenges that you're facing, any roadblocks, or have you seen really creative solutions that faith communities have engaged in? I'd love to just talk.
I didn't realize that I've been off mute this whole time. That's terrible. Anyways, because you never know what could be going on over here in my office. So one thing that I've learned, and I think I talked to you about this when you and I chatted, was that like the people in faith-based organizations who are already doing this work are busy people. Like they're super busy. Well, those are the people that I've been in touch with, but like, even if, when I'm looking at engaging with a church or what have you, a lot of times the like person, and I'm not good with this language because I'm not that, I don't do the religion thing. But I say that knowing that like people who are religious and do the religion things need to be with us in this work. So like a lot of times, like the preacher or the pastor or whoever the leader of the church is, they may not be the one that's going to help you do your thing, but they're like always the face, so it's kind of like not losing steam just because you reach out to that one person who doesn't have time for you or doesn't respond or whatever. And I say that not meaning no shade, like I don't think it's intentional. I think these people are very, very, very busy already. And so then part of me feels kind of like bad for even asking them to like join me because I know how busy they are. So yeah, that was just, thinking about things that I've learned. It's that, the person whose face is on the website might not be the person that you actually need to talk to.
Yeah. And a lot of times churches will have like a health ministry or a health team, and I find like they will be the people to talk to. I like to give the example at my own church. There was a day a couple years ago where there was, it was a rather dramatic day. So just going to say that this was not a normal day for our pastor, but There had been an explosion in Durham. So she was trying to check on all the parishioners that lived near where the explosion was. And then the church cat got killed. And so then later that night, she was shifting to do a funeral for the church cat. And that was just like one day of like nothing that she had planned went according to plan. And she was just very, very busy. And that doesn't mean she doesn't care. It just, you're constantly shifting. And so finding that one person who can be that kind of bug in that person's ear of like, you said you were going to help with this. You said we were going to do a supply drive. Remember to say it at announcements is really key, but also can be tricky. So no, the number of times I've had to annoy pastors to show up to events, you would not believe. They're just incredibly busy people. Yeah.
And definitely, so I do the religion thing.
It's a great way of phrasing it.
I happen to be married to one of those people. So, you know, it's so important that we understand they have a whole congregation, and depending on what size of the church they have, each and every one of those constituents or people in their pews are, you know, the people that they have to care for. So we just have to be mindful of that. And yeah, they have to assign people to programming, just like the organizations that we work with, right? Mm-hmm. You know, our CEOs are not doing everything. They have people that do stuff for them. So just being mindful of that, and maybe even encouraging and being there and supporting. You know, is there somebody who's passionate about this in your congregation? Because sometimes people don't know that that's actually their calling, and that they could actually support in that, because nobody's really even mentioned it. But guess what? They have lived experience. They have all of this information, maybe from their own experiences. And it's not until somebody says, hey, you know, this is how we can support and implement something like this, and who would be the best person to do that, who would lead that at your congregation, if any exists, right? And so it's kind of probing and making sure we give information and education around what that looks like, because a lot of times in general, I think it happens to a lot of us. Maybe we have the $1 million idea, we just don't know how to implement it, you know, or we know that there's a need, but again, it might be too big of a reach for us because we're not even there yet. I know with outreach in my church, it's like, I'm always, you know, talking about, hey, pastor, we need to do this, we need to do that, and whatever. And he's like 100% there, but he's like, I'm kind of even working my congregation to get there, because guess what? I'm like 1% Latino in my church. What's up with that? It's not a negative thing necessarily. They're not, you know, saying no to any other Latinos. It's just, again, cultures, behaviors, perceptions, just the way things are handled in different regions. All of that is going to make a difference on how much of this we get, you know, programming and support we get out there in the communities. And we just have to keep advocating, you know, from different sides, keep advocating and doing what we do already, and, you know, with the respect that we already have and the professionalism that we already have. And you know, maybe I can say, hey, I know you don't have this, but this is still good information. I think repetition is a huge part of this, moving this big ship. You know, because a lot of people, I know with the CIT program, for instance, we've had it for such a long time and nobody knows. How many of us don't hear the same thing? It's like, what do you mean you don't know that this exists? But it's true, and it's been around forever, you know, and it's like, okay. So it happens with all the different programming that we have. We just have to keep advocating in a positive way. Sometimes you have change in leadership also within congregations, and that makes a big difference. Just like when we have changes with chiefs and sheriffs in town, you know, one might be totally anti harm reduction, another one and mental health, you know, or whatever, and another one will come in and be like, yeah, hoorah, let's do it all.
Yeah.
So yeah.
And I also think coming in and saying like, hey, I can teach a Sunday school class, or I can do a program, like this doesn't have to be on you. You don't have to be the expert on everything, can also sometimes help with that busyness of like, I can do this. I got this. But yeah, for sure that persistence is key.
And I'm sorry, I might have missed this, but I want to just kind of come back in and chime in on some of the conversation. Like, can you give an example of, and this is one thing that just speaking to other people that are in the recovery community, and everyone has all these different viewpoints and religious views, or some people might be more spiritual, some people don't have any beliefs at all. How are you connecting? How does the church, the faith-based community, or how do you advise the faith-based community to connect with people that may not have a strong Christian belief, but they also, you still want to connect with them and just kind of let them know they're supported? Do you have instances of that happening, and how do you provide support to those people?
So the best organization that I know that does that is Olive Branch Ministry. They're a faith-based harm reduction organization. So the reason they're faith-based is their faith is the why they do what they do, why they go out and do harm reduction. And if somebody wants to have a conversation about spirituality or theology or whatever, they'll have that, but that's not what they do first. It's always provide services, provide love, provide care, etc. I think Faith and Harm Reduction, the organization nationally, does a really good job for people who they have a craving for spiritual practices, but don't necessarily want a specific lens. They'll do grief rituals, ritual roundtables. We have a naming ceremony for kind of recognizing people who have been lost to the war on drugs, but also overdose. And so those services will happen around Overdose Awareness Day, but also just kind of whenever people can get together. And they offer a lot of good prayers and spiritual resources. That's what I got off the top of my head right now. I can keep thinking. Yeah. I do know Harm Reduction Works is a 12-step like harm reduction support group, mutual support group, that has Zoom calls and stuff, and that has a spiritual component as well, for anybody kind of on the recovery continuum or actively using but believes in harm reduction. That would be my other, off the top of my head.
Okay. Anybody else have any questions? No. So, Elizabeth, have you been introduced to CRM before? So we can kind of bring it and connect it all in together.
I'd heard a little bit about it. My colleague Jessica does a lot with trauma-informed care and was kind of transitioning to talking about community resilience, and kind of a lot of her work in the past has focused around the East and how hurricanes are really a source of community trauma, and trying to get faith communities to understand that. But I had never made the connections that your presentation had made, which was really wonderful.
Thank you. So, what are some, I guess this is a good question for us to know, because initially last year before COVID hit, we were working with a network of pastors in Rowan County. We had coordinated the first meeting with them, and we were moving forward. And I had actually connected with you to do the presentation for that, but COVID hit, and we were talking about building a faith and harm reduction network out here. So what are when building that network of folks, what are some of the things that need to be considered And what are some of the activities that we can take those faith-based communities through so that they're comfortable transitioning into doing harm reduction? Because I know especially when relaying this information to congregations, it's like, I don't know about all that. I don't know if I want to get my hands dirty. I don't know if I want to be a part of this. Like, what are some of those conversations? What are the things that we need to consider and look out for when planning these collaborative efforts?
I think the first thing to kind of keep in mind is to meet congregations where they are as much as we meet other people where they are, because a lot of congregations don't understand harm reduction or don't realize, to your point, that they've already been doing it. And so first showing that, hey, you throw away expired medication. You went virtual when COVID hit and you were reducing risk of people gathering. You kind of highlighting the harm reduction they already do. And then also saying, what if the first step is, do you give out food? Could we add handouts for our local resources when you hand out food? Or would you be okay doing a medication take back? It'd be a one-time thing. This is all the reasons why it's great. We'll make sure to have somebody trained to dispose of the medication, or just kind of have a menu of options so maybe you're not fully ready to do a Narcan training, but would you do a supply drive for empty laundry detergent bottles instead of having people throw them away? Maybe Overdose Awareness Day is next August 31st. Would you want to do a worship service with us as part of our Overdose Awareness Day celebration? We would love for you to lead us in a prayer as we light candles, or just kind of things that will slowly bring them more into the work, but also highlight the gifts that a faith community can bring to the work as well, if that makes sense. I can send you my PowerPoint for when this goes out to everybody. But just kind of thinking through, what does the church have and what does the church already do, and how can that fit in with harm reduction as much as harm reduction can fit in with what the church is doing. I can't hear you. I think you might be muted.
Sorry, I was. You actually just gave me an idea about and never thought about it, about partnering with a church to do a medicine take back. And one of the things, even now, I grew up in church. My mom was a minister, but as I got into public health and got onto these different avenues and understanding, we talk about the separation of church and state and how that can play a critical role. And I understand that making these partnerships can be a very delicate balance, so to speak. So what are some, for folks that are coordinating and leading these collaborative efforts, what are some suggestions that you have for us to maintain, to build these partnerships, but still respect that separation of church and state, and respect, keep those guidelines there? Does that make sense how I answered it? Okay.
Yeah. So I think first and foremost is kind of right, this is just me as Elizabeth Brewington, not me as the North Carolina Council of Churches. The church, when it's at its best, is the best at what it does. And when it's at its worst, it is awful. It can be full of shame and stigma, and just can be the coldest place and very isolating and cliquey. So it's trying to talk to the faith community and make sure, like, do you know your role? Do you know that you can bring a lot of love and support to people, but also you can cause a lot of harm? And so I think starting the conversation about stigma and kind of, these are our brothers and sisters. These are our fellow community members, but they're also the people sitting next to you in the pews. And so we need to do this because we're all interconnected. And so kind of having, at least making sure that the person leading the conversation in the faith community are on the same page when it comes to that foundation. That I think goes a long ways, because you don't want to invite a participant you don't want to have an event where the church is going to end up harming a participant or shaming them or setting them back on their recovery journey. So just making sure that the church understands that, like, we're doing this because we love other people and we're not going to change them, or we're not adding new church members by doing this. We're not trying to save souls. We're just trying to do what the church was meant to do. So does that make sense?
No, it makes perfect sense. And so that was one of the things I struggled with. Like I said, my mom is a minister, an evangelist, so to speak. I grew up in the more apostolic form of ministry. So like holiness type of church, very strict, couldn't wear pants, like all the full nine. So I experienced that myself. And so when the conversation came up, when I started in this position about partnering with churches, I was just like, really? Are we going to do that? But
church trauma is such a real thing.
It is very much a real thing. I've gotten over it a little bit, but it's still, I'm just learning how to navigate it, because I do understand that people are people and they might have the best of intentions, but coming from a place of hurt or having their own places of trauma. Even when we had that meeting with the churches to build that network last year before COVID hit, it came out that, like, one of the men, when we started talking about harm reduction, and we brought in some guests, Mr. Robert and David from they help set up Grace Place in Stanley County, and they also have a syringe service program, some other services in Davidson County. Brought them in and just kind of explained and talk about harm reduction like a blanketed statement. And one of them kind of introduced syringe service programs. And one of the pastors was absolutely livid. I mean, turned red, stood up, denounced all of us. Like, I can't believe you were bringing me in here. And I kind of had to like reel him. I don't know how I did it. I think somebody took over my body and helped me get this man to calm back down and sit back down, because when I say he was done with us, he was absolutely done with us. But I changed the conversation around and we were able to have that conversation. But what came out was he had some trauma as far as friends and family members that had battled with substance use disorder, and it had hurt him in a space where he didn't even want to be associated with the conversation. So it's very interesting. You said what, Kelsey?
No, I'm saying that's so important, right? There's stigma that goes both ways, I think, towards the church as well. I mean, when we're so apprehensive as well, right? Because there is trauma associated with that. And it looks different. You know, I grew up in New York, so it's very diverse and inclusive in New York. Whereas in the South, that's a whole different story. I'd be like, oh yeah, you all have a lot of trauma down here, because it just looks different. And so I'm not saying that wouldn't happen in New York. I'm just saying that it just looks different in different places. And it's understanding those cultures that we're walking into, because half of the time in the community, anywhere I go, I'm like, are we really having this conversation? Because you should have known this like 20 years ago, but okay. I have to tell you to translate this into Spanish, you know, talking about just normal things in general, anywhere I go. Like everybody in the whole world knows that you should at least have 2 languages down, English and Spanish, and then everything else. So again, I mean, it goes with anything we talk about. A lot of education has to happen. We do have to meet people where they are at and really get to know them, because once you found out about the trauma associated with their experience, right? Then of course there's going to be apprehension. And I think that's a fear that most people in the church or pastors or leaders in the church have. They want to protect their congregation, and they've had the experience of people coming in there pretending to be spiritual, pretending to be whatever, and they really harm the flock, if you will. And so it's being mindful that it happens both ways. Just like I don't want somebody to come and talk about harm reduction or syringe exchange or recovery and not use appropriate language, you know, because it's just not, it's not good. It's not helpful. It's just going to add to the trauma. So yeah, it needs to strategic. We have to do kind of our work around really gathering data around how to approach different congregations. They have different beliefs, different ways of worship, different ways of seeing things. And so all of those are variables to how inviting or apprehensive they're going to be to the information. And that's why you need someone who's kind of versed in that information to kind of build the bridge. And I know I have to do a lot of that just in the norm. But yeah, so it's just being mindful that you know, just like when I train first responders or law enforcement, there's stigma associated to them, right? So it's the same thing when I'm teaching them about recovery, harm reduction, substance use being more intricate than just somebody, you know, a junkie or whatever language they want to use that's inappropriate, and just kind of debunking all of that. So there's a lot of work to be done.
There is. 3 things. You all reminded me of 3 things. One, I have totally had those conversations where people get red-faced and had just spewing everything because they're just on their attack defensive. And what I have found helpful is saying, you know, I believe that Jesus met me where I am. So I think I am called to meet people where they are. So turning it into like using my own like spiritual language and my own journey. If Jesus is not your thing, that's totally fine. Just frame it in terms of your own spirituality and what you believe. And that tends to take people off the attack. And I also say, not everybody is called to open a syringe exchange. We don't want everybody opening a syringe exchange. That is not, we need a complete, total, holistic safety net like we've been talking about. And so if somebody is like blistering mad about that, then you can kind of be like, you know, that is not your journey. That's totally fine. Would you want to help with transportation? Would you want to help with housing? Would you help with making sure people get enough food, or just introducing that idea of not everybody is called to do the same thing. Not everybody's journey is the same. So where are you in this continuum of care? And if that is knitting little prayer bags with reflective naloxone, that is reflective thread to put naloxone in, that is great. That is what you should do. If that's all you ever do, that's great. If doing a medication take back once a year is all you're going to do, but you're not going to stigmatize people when you do it, that is great. So just figuring out how we can, any positive change with the faith community, like, and then the last thing that what y'all said made me think of is certain denominations now have different like statuses. I know like the UCC has one called WISE, which means they're a welcoming and inclusive something, but it means that they've had to go through a year-long process of talking about mental health and stigma and all these other things. And so some of those churches might be an easier one to bring on board, and they might have pastor friends to then bring those people on board. And then once you have kind of like your one person in the church. If you have your one pastor who is adept at harm reduction and can kind of translate into church speak for all the other pastor, that really helps. Is comma churches considered a status? I don't know comma churches. I can look that up.
We're recording now. But yeah, a really valuable component of a prevention method is being able to get into spaces that are still attractive to people who are probably going to try to dodge some alcohol and other drug prevention work. You know, and as far as that goes, also really understanding, you know, who are we trying to talk to, and meeting them where they're at. So again, we can look at those themes and recovery stories, and we can look at some of the big picture stuff that generally happens for some of our kind of scattershot attempts at providing some prevention. I'll get into that a little bit more in the next slide, actually. But as much as possible and as often as possible, it is nice to be able to have conversations directly with the individuals, right? And try to come to understand exactly what they're going through, meeting them on, you know, their home turf, right? Coming to them where they're comfortable, giving them space to really tell you what their experience is, being able to build that trust and rapport, right? You know, one of the things I always do whenever I'm sitting down with a group of people is like, I'll start a conversation that has nothing to do with alcohol or other drugs. It has nothing to do, you know, with, especially not their use, you know, like I'll have a conversation about, you know, whatever TV show's big right now, or whatever movie's big, or if it's obviously during certain athletic seasons, like, hey, you know, did you catch the Falcons last night? Whatever it is, right? Whatever conversation we can have on the front end to build a rapport and to build some trust and to have some fun and bond before getting into talking about some of the other stuff. And that's something that Dennis mentioned that, you know, really is important and valuable. The other thing that I just have to note this here, you know, when Dennis was talking about having his kids send the songs, you know, literally one of the people in one of the groups that I facilitate sent a song about how she was feeling in our little, you know, group message. And so those are really excellent ways to allow people to tell us, you know, where they're at and how they're feeling. You know, and then the other thing is, like, as professionals, depending on the space that we're in, we get the opportunity to model these things, right? To show what it's like to be open about our thoughts and our feelings and things like that. And so depending on you know, what your circumstances are, there's a variety of ways that we can work to build those relationships. You know, and then this is also the kind of opportunity to talk about how to do this in a kind of diverse and equitable way. And that comes down to really understanding people's realities and people's experiences. I had a guy a couple of days ago who was talking to me, and he comes from a culture where alcohol use in particular is very normalized. You know, his parents are particularly permissive of his alcohol use because in their culture, it's completely normal for alcohol, you know, use initiation to happen very young. So he's been drinking since he was very young, but he is starting to develop some issues. You know, he is acknowledging that there's some problems that are coming up. He's got some concerns about how it's impacting him, and he's really conflicted about, you know, how can it be bad? It's something that, like, my parents have encouraged me to do. But it's also having these negative impacts. My friends aren't experiencing the same things, so maybe it is a problem. And so having that conversation with him and letting him, like, express, you know, honestly letting him express that, you know, my parents let me do it, so how can it be bad? But my friends, like, don't experience this, so maybe it is bad. And you know, giving him that space to work through those things and to just talk about, like, you know, okay, this is what we know, like, in terms of an indication of a potential problem. You know, like, if it's impacting your ability to show up to class, like, is showing up to class important? Yes. Okay, then if that's important, and alcohol is preventing you from doing that, then perhaps, you know, there's some conversation to have. Like, let's get you in for an assessment. Let's, you know, do these next step things. These are the resources that are available to you based on that. You know, and so just having that opportunity for somebody to do that and to not be criticized and to not feel judged or anything like that. This next slide, this is a model that we've worked on in terms of trying to develop prevention programming. It's really just, this is a resource for anybody who works in prevention to try to like work towards that and organize their efforts in a way. This is really just kind of what we do. It roughly doesn't translate to every audience, right? For our purposes, though, we look at like, what is our goal? And then, you know, what is our kind of scope? And I'll explain that a little more thoroughly. Generally, when we're talking about the goal, right, are we trying to prevent substance use? Are we trying to intervene on current substance use? Or is our goal just really to give some kind of like a functional skill, right? So prevention, intervention, or instructional. At the end, you'll see our emails. You can always reach out. I'm more than willing to share this stuff. But looking at that goal, what are we trying to do? What does this particular audience need? What is even feasible, right? So if we're talking about trying to train people in brief intervention, right? If it's a 500 person audience, there's literally no way that I'm going to train 500 people in brief interventions in an hour, right? So considering the audience size, considering their needs, considering what resources are available, right? So in a lot of ways, this is a lot like the crown. Like, what are my resources to be able to do this? You know, who do we have in this space? What space do we have? What money do we have? Those are all things that come up in determining what our goal for any kind of programming or presentation would be. I see something in the chat. Sorry, I just saw this. Okay. Yeah. The next thing is, oh, I don't know why that's popping in weird. Sorry. The other component of that being our scope, right? So are we trying to keep it broad? Like, we don't really know necessarily who's going to be in the audience, so we need to keep it broad. Or, hey, we actually do know, we have a pretty good idea that this specific group has these kind of specific needs or specific concerns, right? So we can be more focused. And so again, you know, what are those needs? All of that. There's a wide variety of factors to consider in just kind of identifying what is my goal and what is my scope. And then from there, like, we come to understand like what exactly we need to do. So if we're broadly aiming for prevention, right? So we're not necessarily sure who's going to be in the audience, but we know we're aiming to prevent substance use, right? We want to challenge the norms that people have about substance use. You know, we want to offer alternatives to substance use, you know, so understanding why people typically initiate that use, and therefore giving them some other solutions to avoid that initiation. You know, go over some of the kind of resources and the factors that contribute, right? Talk about all that kind of stuff. Again, this is something that can be available to anybody who's interested, but really being able to break down and look at, you'll see like the challenge norms component that shows up across really in most of the spaces, you know, really talking honestly about, you know, why do people initiate alcohol and other drug use? You know, what are they typically looking for? And then what do they typically find, right? So if I'm consuming cannabis in order to go to sleep, well, honestly, that might help until it doesn't, right? And so let's talk through why it might not be the most sustainable solution. Let's talk through what would be some sustainable solutions, things like that. I think we're running up on time, so I'm not going to be too long-winded here because I do want to give everybody the opportunity to ask any questions that they may have.
Jessica, I think you actually have until 2:25. So if you want to go back to the slide and be more detailed, that's fine.
Okay. Well, I will actually go ahead and leave it up. I still want to offer that opportunity for questions, but I'll leave it up so that people have a point of reference for questions if they have any. you know, I know this particular session is a little bit more focused in on that prevention side of these factors. And so I can certainly talk more about all of it though.
Jessica and Lindsay, I had a question. With you working with college age students, are there any times where you are actually able to bring in the family, or your main focus is just the college student themselves?
I will gladly take that question because I am meeting with a bunch of family members this weekend. So on occasion, we do get the opportunity to speak with family. What we're primarily dealing with is an adult population, right? And so we have rules like FERPA that we have to follow, which, you know, we have federally protected information. We can't really like reach out and like, hey, we're worried about your student or anything like that, because there's laws that tell us we can't. But we do engage very heavily with both our parent and family program department, because we do have a very robust parent and family program area here at KSU. And so we do a lot with them. And then orientation, right? Like any way we can sneak into orientation and be able to provide anything to be able to kind of like sneakily put stuff in the hands of parents so that when they're having these conversations with their students and things like that, they're like, oh, and by the way, here's something that's happening, or here's a resource, or here's this thing that's going on. And so we don't get a lot of opportunity, but we seize any opportunity that we possibly can. But like I said, our university has a parent and family weekend, and that's actually going to be happening this upcoming weekend. It always comes ahead of homecoming, which I think is brilliant. But we bring in parents, and they are able to come in, have a great time. They get to participate in pep rallies, and like they're really brought in as part of the community here at KSU. And so fortunately we have great rapport with other departments on campus, and they'll like essentially pull us in on that. And so that we can provide some messaging, some education, and literally just be a resource at times too. And parents are always an interesting one. So like our department is the Center for Young Adult Addiction and Recovery, right? And so I don't know that Jessica really like went over the whole scope of what we do here at the center, but we have our collegiate recovery community, which is a community of students who are all in long-term sustained recovery from substance use disorders, eating disorders, as well as process addictions. And we offer all sorts of academic and social support for those students. But we also do a huge amount of research through our department. We have undergraduate and graduate research assistantships in recovery science research. And then we also do the majority of the alcohol and other drug education here on campus. And then my position, like I said, is an interesting position that doesn't exist in a lot of spaces, because I serve the entire KSU population, like I said. And we work with a lot of other departments, like our health promotion and wellness does a lot of our alcohol and other drug education here on campus too. But I coordinate all the department AOD education. And so it's an interesting space, right? But so when we're out there and just resource tabling or anything like that, we'll see an interesting thing with parents where just because of the name that's on our tablecloth, right? We'll either have people come up that are like, tell me everything about what you do here. Or we refer to it as the ARC, because you will see people who are walking through all the different resource tables, and you'll see the parents, and then they'll shoo their child and like do like a 10-foot arc around the table being like, you don't need that. Don't ever need that. And so that's a really terrifying place for us to be in, right? Because we're like, oh my gosh, the messaging you just gave your student was if you need help, like we're not going to be receptive to hearing that you need help. And so we do, again, Trojan horse our way into a lot of spaces when it comes to family members, being able to talk about like, here are all the services we offer, and here's all the prevention work we do, and here's why it's really important that your student actually engage with our department and all the different resources we have to offer. Because yeah, it's a terrifying topic, right? So I told y'all, like, my oldest started at a different college than the one I work at, by the way, much to my chagrin this year. And like, I talk to students about alcohol and other drug use for a living. This is what I do day in, day out. You know, they tell me it's 40 hours a week and they pay me for 40 hours a week, but it's certainly more than that. And it was a terrifying conversation for me to have with my own, right? Like, okay, you're going to college and like, and it's a scary topic, but like really sitting in that discomfort and having those conversations with these family members and being able to be like, we know it's uncomfortable and we know it's a scary place to be, but it's such an important conversation, and being open and being willing to listen and understanding that like stuff's going to come up and stuff's going to seem appealing, right? Here's how we're going to support you as your family. That was a really long tirade, but I also know that we have time to spare. And I think that's like a really important message, right? Because it's such a terrifying thing when I see the parents do the ARC and I'm like, oh no, come back. Let's talk about why that's not helpful or effective. Well, and I will say that reminds me of another really important point. So we also collaborate with organizations kind of across the state, really, and help support their efforts. And one of the things that we do and we try to establish is that like the point of prevention work isn't what you can do last second, right, before they start. It's about the framework you can set up on the front end, and the more proactive we are, the better our prevention is, right? And so that's why the example of like family game night, right? Having that space for young kids before substance use is even really on the table, having that space where it becomes normalized to talk as a family, right, and to bond as a family, so that 5 years from now that's an established kind of standard, right? And that's a comfortable and a familiar space is really important. But then also recognizing that like family game night's not an option for every kid, right? Like not every kid has that availability. And so what can we do, the people who exist in different systems, especially like in positions of authority and all of that, what can we do to try to establish that for the people we serve, right? Teachers, right? Various like community organizations, right? What can the local, Boys and Girls Club do to help establish this? What can the local clergy do, right? With youth groups and things like that. What can we do to make sure that the kids who don't have those kind of relationships can have them somewhere else, and really have that space to come in and be honest and be open, and that just be the standard on the easy stuff, so that when it gets to the hard stuff, they can go there. It's really hard to go from I don't talk about my feelings to like I talk about full-blown trauma, right? Like that's a big jump, right? I need you to be able to talk about how you like that lollipop. And then we can talk about like how you really enjoy this TV show. And then we can get to the point where you can, start talking about the difficult stuff. And so really the more we can do that on the front end, the more responsive we can be when we have those kind of traumas, when we're getting pushed out of that resilient zone, right? We have a much more quicker route back into a stable spot.
Dennis, one of the questions, because Jessica and Lindsay sort of are at the college level and you're more, and also out of state, but also you're more at a local level, but you're also working with younger youth. What is your rapport with the parents that you're working with? Is that lacking? Do you depend a lot on our school intervention specialist, or how as community partners can we help you or can the school help you more? Well, Lindsay, I will chime in as a parent of a child who just graduated from college and one who started college. It is a hard thing if you don't use substances to find your place as well. So I think we need to make sure when we're working with our youth and our college students that, you know, we're aware of that too, because, you know, trying to find, my daughter just trying to find her place and trying to still do well in school because she's trying to get into nursing school, which, you know, has to, you know, her nose to the grindstone, but it's kind of hard. And, you know, you definitely don't want to push them into an environment that could be harmful to them if they chose to dab a little bit here and there. But, you know, you also want them to get out and enjoy the college environment. But it's been a long time since I've been on a college campus, so things have definitely changed and stuff. So knowing when to push and when to say, you know, I understand where you're at, but I think it's awesome that y'all have programs like that on your campus.
Well, and we, like I said, we work collaboratively with so many departments across campus. We have partnerships with our student conduct office. We have partnerships with our health promotion and wellness office. And so we do as much collaborative programming as we possibly can to bring as many different viewpoints and angles. And so like with our student conduct office, for example, our center, and it's actually me, we do a workshop for students who violate our alcohol and other drug policy. If they get caught in violation of the policy, then they have to sit through a 3-hour workshop with me. But it's that partnership has actually resulted in very, very low incidences of alcohol or other drug policy violation cases, but our recidivism rate is actually incredibly low as well. And so like being able to provide an educational alternative as opposed to like a more punitive way of approaching things has actually been incredibly successful here at KSU. We have a pretty low incidence of policy violations anyway, considering we have just shy of 43,000 students, and I think we only had 200 cases like the last. We're not counting COVID because like that 2020 year got a little weird in there. 2020, 2021 school year. But if we look at our 2019, 2020 numbers, before COVID hit and all the weirdness really popped off, we had, I think, 253 cases. And we have a recidivism rate with our AOD policy violations of only 3.5%. And so it's low. And so what we know is that the education works. We know that just having open and honest communication works. We know it's effective, and like giving space for students to be able to share their experience without any kind of fear of punishment or, you know, ramifications or anything like that has been huge. And we also have to recognize, like, when we're approaching these things, I know Jessica touched on this, but, you know, there have been populations that when it comes to alcohol and other drug prevention and education and all these things that we talk about, you know, we have to recognize that this country has had some really sketchy stuff happen when it comes to alcohol and other drug education programming and enforcement specifically. And so recognizing that there have been populations who have been targeted in laws and policies when it comes to alcohol and other drug use, and recognizing that the war on drugs had some really serious ramifications nationwide, and that it impacted family structures, and that impacted a lot. You know, the Controlled Substance Act had a really, really intense cultural impact for a lot of people and populations. And so coming from the understanding that has happened and that exists is really, really important, right? Because we tend to kind of discredit anything in the AOD world. We tend to discredit anything that's not like drugs are bad, right? And so, you know, so critical for specifically inclusive and diverse and equitable programming to really understand that experience that is coming from people and giving people the space to be able to talk about that and how it's impacted them, their family, their friends, their loved ones, to be able to actually approach them from a way that they're not going to push back on. That was a lot.
Thank you, though. Dennis, do you want to try again? I'm not sure whether or not you figured out your problem.
Can you hear me now?
Yes. And we have about, if you want like 7 minutes and about 20 after, we will take a break, give y'all a 10-minute break. So.
No, I was just going to say, like previously coming with the police department, I was working in higher education. And one thing I learned with helping me, I was, one of my programs was a mentoring program for males. And cultural enrichment for me was like one of the biggest things that we did was working with them, because a lot of the males who either did use a lot of substance use or alcohol, drugs or pills, different things like that, found out that a lot of them didn't even know the different dynamics that North Carolina, because we've been in North Carolina, whereas most of them, either the Black males always went to the beach, but none of them never went to the mountains. So it was like trying to get the idea of going to the mountains, going skiing, going horseback riding. But it was like literally like that cultural experiences, engaging them in things that they never thought they could do, but at the same time change their mindset of knowing that, wow, I can do certain things, or, you know, just because I did have the substance abuse, I can, you know, still stop or, you know, or control it before I can even stop it or something like that. But it was, for me, it was just seeing how their mind was just so different from, I guess, me growing up. I was went skiing, went jet skiing, went horseback riding, went camping, and also did some crazy things like jumping off of cars or, you know, run up in North Philadelphia. So like I did both worlds, but at the same time, I forget the balance that I had as well, where understanding that a lot of them never had that balance, or never had that opportunity of a friend whose parents might take them to different places and stuff like that. And I think a lot of that plays a big factor in them. When they feel that they can't do anything, they resort to substance use, because that's the only thing that's in their being a part of their environment.
Okay, so my name is Ashley Creek, and I am the Certified Peer Support Specialist with the Rowan County Post-Overdose Response Team with the Health Department. I am a person in long-term recovery. So what that means is that I used to use substances to try to maintain wellness in my life. And of course, those prevented me from living a full and happy life. And so I found recovery and have been in recovery working towards wellness since 2016. And by the way, excuse me for my voice. I woke up and my voice was gone today. I was like, of all the days to have your voice leave you, it must be this day. Thank you. So thank you for joining us. So today we're going to be talking about CRM, a little bit about in reference to substance use and more so today about the body and how that can play a part in our recovery. So we're going to talk a little bit about the resiliency zone today, about biological responses and substance use, biological responses and return to use, and just give a little bit of encouragement of hope of how we can overcome. So I know that, you know, through our presentation earlier, we learned a little bit about the resiliency zone, and And so I'm going to touch briefly on what that is again and just give a little bit of my description. So here we have this resiliency zone, as you can see on this screen now. And what I describe that zone as is the lazy river. And in the lazy river, you can make positive choices based on lowered emotional state, where you are in an emotional place where you are just firing on everything that you can fire on, you know, and you are making those good choices for yourself, those healthy choices for yourself, or where you can actively and calmly make a decision in your life. And so what happens in life is stress and trauma. And, you know, for me, that was no different. So many different things in my childhood happened. I was raised by people who also used substances. And as a result of that, there was a lot of chaos and so much trauma in my life. And so it caused this place where I was stuck in a high zone, right? Or at times I was even stuck in that low zone. And I kind of describe it, that lazy river is that safe, happy place. We all kind of know what it is to be on that inner tube in a lazy river or on the river, just floating in the water, how relaxing that can be. But people get stuck in that high zone of edgy irritability, mania, anxiety. You know, we get stuck in that low zone of depression and sadness. And so what you find here for people who have limited coping skills, like myself, you know, I had very limited coping skills as I was raised by people themselves who had limited coping skills to offer me. I began to use substances as a way to get into the resiliency zone, right? I use those to help myself feel and take away from that edgy, irritable place or that depression or sadness. And that is how I found security and comfort and the ability to try to go forward in my life. And what I find is so many people also who struggle with substance use do this to maintain that state of well-being in their life, and it's what they've learned, and they start very young. So I want to talk about, you know, in this next slide, we want to talk about biology versus mental weakness. You know, already I kind of we've described that resiliency zone. We've described being trauma informed, resiliency informed. And so, you know, in life, I think what I have seen is that so many people, you know, want to talk about the choices that we make and how we're making bad choices or good choices, or, you know, how we have more power sometimes in these heightened states of emotion than we actually do. You know, like if I had a head cold, you know, I couldn't tell my body, hey, body, do not have a cold, you know, and just like I can't tell my body to not have a cold, I cannot tell my body to not have anxiety or to not be depressed or to not be irritable. And there's places that we get into when we're getting into a state of, you know, biological responses where we're no longer in control, and we'll get in more detail about that later. And so what I lacked in my life, and what I see a lot of people lack in their lives with substance use disorder, is the ability to, because even though we cannot tell our bodies to not have anxiety, there are skills that we can use to help bring that anxiety to a minimum, or bring that anxiety down, and be back into that happy place, that resilient place, the place where we can make, you know, choices that have positive results in our lives instead of negatives. And really, that's all substance use, in my opinion, disorder is an inability. You know, we are coping the best way that we know how. I was coping the best way I know how, but my coping skill tended to have more negative results than other people's. For instance, people who struggled with maybe watching a little bit too much TV, or maybe, you know, eating a little bit too much sugar, or, eating a little bit too much McDonald's, or watching Facebook too much. Mine just had more of that stigma and shame surrounding it, and more of those negative results that caused me harm. So, and again, talking about the rhythm, talking about nature, and like I said, that inability to be able to tell my body that I can't have an anxiety. I can't do that. And so, but what I've learned in my recovery is that I don't have to stay trapped by that. I don't have to stay in that situation any longer. And I can and if I learn the proper coping skills, which I have felt like I've done so much of, I'm able to make more choices that are healthier for myself. And so, talking about how we're trapped and how we don't have to be trapped, that sympathetic nervous system, or the autonomic nervous system, excuse me, and how the sympathetic is that accelerator and the parasympathetic is that brake. And so what we find and so many participants here in the PORT program, so many people that I work with in substance use, is we tend to be trapped by the rhythms of our bodies. And we are just using that substance over and over again to try to alleviate some of that pain and discomfort, and how there's really not a lot that can be done about it. Once your body begins to take over, you can be stuck in that place, and there's not a lot that can be done if you don't know the proper tools. Talking about, in my life, I've had struggles with not only substance use, but anger issues as a result of PTSD. So I have PTSD. And so what that looks like in a lot of people's lives, is anger, irritability, frustration. And also we have, our cerebellum is larger than other people's, right? And so we can get to this place where we're flipping our lid quicker than other people, because we see a threat more visibly, or we can see threats sometimes in intensity. And, what you see a lot of times in substance use is people who are homeless and they're engaging traumatic situations, right? So you're in this position where you're out in the elements, you are out in the unknowing place, right? Where you don't know where you're going to get food, where you don't know where you're going to get shelter, where you don't know where you're going to be able to bathe, or where you're disconnected with your community. And so you are in a place where threats are all around you, right? And so your body kind of just flips its lid, like Judy and Kelsey were talking about earlier, about how that amygdala sends that signal, and we're not in our prefrontal cortex anymore. We're not calm and rational and thinking clearly. I wasn't thinking clearly when I was in substance use. I'm not always thinking clearly when I see a visible threat, like my past has done as a survivor of so much trauma. I am heightenedly aware. My lid has flipped, and now I am angry. I am fearful. I have anxiety. I have sadness, and I'm unable to make good decisions or calm down anymore. Quite frankly, my body has taken over, and that's it. And so for me, in my life, so many people were always like, just stop it. Just don't do it anymore. Don't get angry anymore. Don't use drugs anymore. Don't use alcohol anymore. But I was stuck in this place without the ability to come down, without the ability to calm down, that I wasn't really capable of making those choices that people were asking me to make. I just, quite frankly, wasn't educated enough at that time. And it's so crucial for people in recovery to be able to be educated on these things and what's happening inside of our bodies. And so many people don't understand what's happening inside of our bodies. And so I feel like in recovery, understanding more of these things and what's going on can help us have a more stable recovery, achieve more wellness in our life. I know for me, in the beginning, I learned a lot about faith, and even though that did wonders for me, learning more about these things where I was kind of trapped, where my jaw was always clenched and I wasn't breathing very deeply and was still making some poor decisions, has helped change me. CRM really, honestly, essentially changed my life. And we already kind of discussed that amygdala and what it is. It's that threat system. And, when you have PTSD or when you're in those elements, like I said, that's constantly being engaged. There's threats all around you. Talking a little bit more about those survival responses and how, when you're in those situations of substance use, how you just continue to be stuck in that fight, flight, or freeze position. And I think I didn't, nor, I know I didn't for a long time realize that was what was happening in my life. And it really created barriers between me and recovery, because I just couldn't think those clear, concise thoughts. And so, moving a little along to why somebody might return to use after long sustained recovery. Now we see kind of some of the barriers that would make it hard for somebody to achieve recovery, because we know that they may not be in rational thought. They're stuck in this fight, flight, or freeze position, with that inability to receive, receive that rational cognitive thought from our frontal cortex, right? And so we think about somebody who's like myself. I've been in recovery for a while. And if you know anything about memories, we've got explicit memories here, which, we start developing early in life, and we can access them by our intention. Like, we can actively remember them, and I know so many of us can just imagine right now, like grandmother cooking cookies for Christmas, and that smell, or our moms cooking cookies for Christmas, or the smell of a Christmas tree, can bring us back to Christmas, and we can put a smile on our face. And I say Christmas because I love Christmas so much. And, and even now I'm thinking about that time and I'm starting to smile. My body is starting to have a reaction based on consciously activating that memory, right? And what's happening for me right now in this moment is that my body is beginning to release a little bit of dopamine. And what that is, our body's mood regulator. So right now my mood is being boosted, just by thinking about Christmas time. And it can take me back there. And so just like a memory can take me back and make me begin to smile and make me think about Christmas time, if I perhaps come across somebody, I'm in recovery, and I come across somebody who I used with, right? I just randomly run into them. And I have all these memories associated with this person that I used with. And so as soon as I get in front of them, all of a sudden my body releases dopamine, because now I've been triggered into this moment, into this time where I actively use drugs. And so my body was conditioned to understand that that was happening. And so it releases just a little bit of dopamine. Anybody will tell you who's ever used drugs are that even when you thought you were about to go get it, your body all of a sudden, your stomach might grumble, or you might get a little lightheaded, or you might even start feeling better if you were sick. And because you thought about it. And think about how many times we've just seen some food or we've seen, we thought about something that we really wanted to eat, even if we weren't hungry, all of a sudden our tummy started rumbling, and that can happen with somebody in recovery, where they see that person, a memory is triggered, and now they're back at that time. And so it's somebody who might not know what's going on in their body, who isn't as educated to know that, hey, this is just a biological response that's happening to me right now. I'm recognizing that and now I've got this craving to use. Somebody who doesn't know that might take that craving and they could start feeling shame for that craving. Oh, I'm really not changed. I'm really not different, and potentially use behind it. They could use behind it just because they got that feeling and maybe not having the adequate coping skills to deal with that in that time could cause a return to use. And so, understanding more about our bodies can help us and aid us in saying, hey, right now, I am triggered by this person. I am recognizing that I used to use with them. It is causing a reaction in my body, and my body wants more dopamine, or it wants to do this based on just a memory. And now because I'm aware, I can pick up the phone and I can call somebody and let them know and shed light in on that situation. Or I can go and use one of my healthy coping skills instead of making going towards something that's going to be detrimental to me. So we also have implicit memories, and implicit memories are more like a body memory. And so, and these can sound off at any given time. I might not be consciously aware. And this is why emotional healing and recovery is so important, right? There are so many memories that I had, so many traumatic events that took place in my life that created a response, a behavioral response, right? And until I was able to connect that implicit memory, because I've blocked it out, I suppressed it, pushed it down for years with lots of drug use, and until I was able to understand what happened and to go into that with therapy and with other people, I had behavioral responses. I engaged in things that weren't healthy for me. For instance, I have lost 85 pounds because, now because of diet and exercise. And so I was an overeater. And this was after I began to stop using drugs. There, I ended up engaging with somebody in trauma therapy. And when I did that, I went back into several childhood memories, like they were just teeny snippets. I did not remember them all, like maybe just a teeny snip. And this was through a lot of digging. Did I come into those? And through a lot of those memories where I was traumatized in different ways that lowered my self-esteem, it created a behavioral response to overeat. It through sexual abuse, it created a behavioral response to overeat. So that way I would be bigger and people would not pay as close attention to me. And so, but I had suppressed those things so far down and was just doing that automatically. And this is what so many people experience when they're using substances. It's an automatic behavioral response, right? And so until I went back and connected that implicit memory, that body memory, because my body still remembered it and reacted. But until I connected it with the implicit, with the explicit, I couldn't do anything about it. And now that I have, I'm like, well, of course I need to make better choices. Of course I can. Now I have the coping skills. So now I can replace that bad coping skill, that causes negative things, with a positive one. And now I have positive results, right? And I feel that so many people with substance use experience this, and it causes that back and forth, or maybe that failure to even be able to engage in recovery in the first place. And so we already kind of discussed the external, internal memory capsule type situations where sound, smells, different things can engage that and create that biological response. Uh-oh, my slide stopped working. Oh no, oh dear. Oh, here we go. Again, and it, like I said, it can have a good result or a bad result, like I was talking about with grandmother's cookies, mom's cookies, Christmas trees. See, I'm smiling again. Just thinking about Christmas. So imagine what happens in my body when I'm unhealed from trauma and all I can think about and all I'm faced with is a lot of negative events from my life. I'm going to want to escape. I'm going to want to run. And if I don't have the adequate coping skills that it takes to run in a positive manner via, I think about, well, we're moving on. If I don't have those, adequate coping skills, I can't do that. I can't do that. But the good news is for people like myself, there is hope. There is change that can take place in our minds and our bodies, and that's through neuroplasticity. And I'm sure, I think they talked a little bit about it earlier, and if you don't know, it's our brain's abilities to create new pathways. So for me, for so long, when I got stressed or upset in recovery, because my body was conditioned to use substances to fight that feeling, that's exactly what I went to if I was stressed out or upset. Now that I am somebody who exercises and eats healthy, I have formed new pathways in my brain. So when I get really, really anxious now, I start thinking about running. I want to run, and I want to run now, and I want to run fast, and I want to run until I can't run anymore, because my body now knows that releases endorphins and it releases dopamine, and it will calm me down, right? It will turn my brain off to where I'm not actively in that traumatic experience anymore, but now in the present moment. And when I get into the present moment, I can make healthier choices for my life. And somebody who is in substance use, isn't always in the present moment. They're literally just combating anything that could possibly go wrong or they're trapped in that depressive place, which is probably about the past. So it's really great news. When I found out about neuroplasticity, it changed my life. When I found out that I had the true power to take control of my life and change, man, I changed. And am I perfect? No. Do I fall back into old patterns? Of course. That pathway is there. I don't use it. It's grown over some, but it is there. And it could be reactivated if I chose to do that, and sometimes circumstances cause that in people's lives. We return to use. But the good thing is now I have the choices that I can make, and I don't have to stay there. And so that's why it's so important for somebody in recovery, to have those new pathways. I think about this story, and I know that we have to end. So, but I'll tell y'all one more story kind of about neuroplasticity, about recovery, how it works. And it's my coffee story. So in early recovery, I got put on a sugar fast in this one recovery. I couldn't have sugar for like 2 weeks. It's a long story, but I always put tons of sugar and cream in my coffee, right? And I had it like that way for years and years and years and years and years. And so I couldn't have sugar. So then I began to only put cream in my coffee. Turns out I liked it. Who knew? I didn't, because I was used to doing it one way. So for 2 weeks, I just had cream in my coffee, right? And so then, of course, I was able to come off this sugar fast. And what do you think I did? I put sugar in my coffee immediately, right? Immediately. And I was like, man, I really don't like this. I don't like this at all. And so I began to try to drink it with cream. But every now and then my brain would be like, you want sugar in your coffee, right? Because it was so used to that. And probably now that I'm thinking about it, I might have been having a stressful day that day. And that's why I was craving sugar. So it was like, you want sugar in your coffee. And so I would put sugar in my coffee and I would realize again and again, man, I don't like that. And then finally one day, and I can't even remember how long it took, how many times I put sugar in my coffee. One day I was like, I had that thought, you like sugar in your coffee. And I was like, no, you don't want sugar in your coffee, right? You don't want it. And so I don't put sugar in my coffee anymore. But it took me a long time to get out of that old behavior and to start being able to recognize that I really didn't need that sugar anymore and that I didn't like it. And that's the same that it goes for people who are trying to recover. You put us in jail, we go back to what we know. You put us in a treatment center, we can go back to what we know. Sometimes it takes those returns to use to be able to recognize and realize, I don't want this anymore. I don't like this anymore. This isn't for me anymore. And, and sometimes that happens because of biological responses, especially if we're put back into the same environment or with the same people or around the same things, and I feel like all this is vital information for people who are trying to help people in recovery, as well as for people in recovery. So we can see ourselves coming before we even come and maybe make a different choice using coping skills. And so, that's kind of what I wanted to leave you with. It's just that our wellness is so important for ourselves and for people in recovery. What are we doing to widen our resiliency zone? How are we using skills, coping skills? And these CRM skills I know helped me, and they can help so many people. And just the information about being resiliency informed helped me, this information about the brain. So thank you guys for coming. And I know we're running late. I think that our next person was already supposed to start about 15 minutes ago, but I know that we were kind of messed up in how we were getting into our breakout rooms. So did anybody have, before I sign off and let Melissa Larson here go ahead and start, did anybody have any questions?
No, just a comment. I'm addicted to chocolate.
Yeah, me too sometimes. I used to be. Okay, well, I just want to thank everybody again. And Melissa, I'm going to go ahead and turn it over to you and stop sharing my screen here.
Great. Okay, so this message, you guys see it? It says breakout rooms close and
oh no.
Countdown.
Oh no.
What do we do?
I guess we're going to leave and come back.
Okay.
I'm not sure. I apologize. We went through this so many times to try to alleviate technical difficulties. So I'm so sorry.
I feel like we'll just wait it out before I start and see if we come back.
Hopefully we'll come back. And thank you for being here. I can't wait to hear what you have to share with us today.
Yeah, I'm glad to be there because I really enjoyed your presentation too.
Thank you. Thank you. I appreciate that. Here we go. 5.
And it says screen sharing is not enabled anymore. Ashley, can you hear me?
I can hear you.
Okay, good.
Ma'am.
I can hear.
Great. Just gonna wait for like another 30 seconds, make sure our group is back. I'm really feeling for Natalie today. I feel her pain. My morning started with our router deciding to completely not work at all. So of course I had to make sure I paid the bill. So yeah, I had paid the bill, so it wasn't that. And then we found an old router in the house, hooked that up. And I had to try like 2 different rooms to get good internet connection to be here with you today. So I feel her stress. I need some resiliency myself right now.
Should we take a resiliency pause?
Yes, yes, absolutely.
Everybody breathe.
Yes, I do have yoga later, so that'll be a saving grace. Okay, so I know everyone, we are short on time, so I'm going to go ahead and get started. My name is Melissa Larson. I'm the Law Enforcement Programs Manager for North Carolina Harm Reduction Coalition. And if you're not familiar with NCHRC, we're a grassroots advocacy, resource development, coalition building organization. We work throughout the entire state of North Carolina, or at least we try to, depending on our capacity. So we provide harm reduction services to individuals who are impacted by their drug use, sex work, overdoses, sexually transmitted illnesses, and chronic health conditions. And so my role primarily is to work with law enforcement and communities that are interested in developing response strategies to really work in a different capacity with people who are actively using drugs. And so much of what Ashley talked about really resonated with me because I do a lot of law enforcement training, and they just do not have the benefit of understanding a lot about what people are going through and their trauma and their childhood experiences. And I just really appreciate everything that Ashley, that you had shared with us. And I think it has such value. And so what I'm going to talk about today is some current strategies and partnerships that we're working with in communities. But what I'm going to do is I'm going to present it in the framework of the sequential intercept model. And so if you're not familiar with it, it can look a little intimidating, but I'm going to break it down because I think it's a really good framework in which, when you're having conversations with your partners, your colleagues, and your communities, it's a good kind of way to look about who are we meeting in our criminal justice system per se, that are experiencing substance use disorder and chronic health conditions that we can work with in a different way. And so I'm also going to talk about North Carolina's menu of local actions, which has a lot of cool strategies in it. And then, of course, just those strategies within the intercept points. And so as we're working to connect people to vital services, this ongoing labor of love and compassion can really take a toll on both participants and the colleagues and professionals that are working with them. So as we all know, stigma continues to be a really strong barrier to services, and helping people get connected to community-based harm reduction services, as well as connecting them to service providers who can really understand the philosophy of harm reduction, can be very advantageous. And so during the COVID-19 epidemic, obviously we've seen so many participants not only struggle with these pre-existing barriers, but also the compounding effects of the hardships that the epidemic itself created, including the loss of treatment services, challenging accessing them through transportation, perhaps through financial challenges, even just changing the office hours at the treatment providers. That's been a struggle for a lot of individuals. And of course, the social and mental health conditions that come created by the isolation that was experienced. And so many organizations have worked tirelessly over this past decade to implement response strategies to improve the quality of life for those with a substance use disorder. I really do fear at times that COVID's put us back many years in our progress, but now more than ever, really learning and sharing these resiliency skills with individuals are so important. And whether it's our participants or whether it's the providers that are working with them. And I think it's really important that we understand that compassion fatigue is real. I see a lot of this when I'm working with law enforcement officers. They do tend to get frustrated, whether it's the first responders, the treatment providers. It's not uncommon for law enforcement officers to express this frustration when they see the same person experiencing an overdose or re-engaging in crime. And so what many first responders don't receive is this education and training, especially what Ashley was talking about, and how adverse childhood experiences and this lack of resiliency skills can really impact one's life. So as I go through this presentation, I'm really hoping that you can pick up at least 1 or 2 harm reduction strategies that you can share with your colleagues and your partners. So I'm sure you all are familiar with what harm reduction is. I like to think of it as a philosophy and also a set of strategies that we can share with others. So it's referring to this range of public health policies. People who use drugs understand that there are harmful consequences associated with it and with other high-risk activities, but we are really here to help support them on whatever their journey looks like. And it's also a way of preventing disease and promoting health and meeting people where they are, and then not making judgments about where they should be in terms of their personal health and lifestyle. So what I mentioned earlier, this menu of local actions, I don't know if anyone has seen this before, but it's got to be probably one of my favorite documents that the state of North Carolina has created. And you can actually find this within North Carolina's opioid action plan. It's their statewide recommendations for priority strategies to address the opioid crisis. And what this document does, it provides a brief overview of a variety of strategies that take this harm reduction approach, anything from accessing naloxone to implementing jail-based treatment programs. So I think this is a great tool to share with your colleagues and your partners when you're brainstorming ideas about what might meet the unique needs of your community. We understand that not every strategy is going to work in every community. A lot of it's going to depend on the current mindset, the current capacity, and the willingness. And so I urge you to check this document out. And the easiest way I think to find it is simply just to Google North Carolina menu of local actions. But I'm actually going to talk about quite a few of them in this presentation. So here's this sequential intercept model. Like I said, it looks a little complicated. It is in essence, our criminal justice system broke down into what we call 5 intercept points. And so what we're trying to do here is really navigate people from the criminal justice system and into the behavioral health system. And so within each of these intercept points, you can develop certain strategies that are effective for that area. And what I really like about it is that you can meet people that have unique needs depending on where they are in the system. And so this is a great time to explore. So anyone with an underlying substance use disorder that comes into contact with law enforcement, they can be immediately connected to behavioral health services and then diverted from the criminal justice system. Now, that's obviously not the reality of the world that we live in all the time. So we have to really be brainstorming about innovation and strategies that we can implement. So this sequential intercept model was actually created in the 2000s for mental health. And so if your county or neighboring county is what we call a stepping up site, your county commissioners and managers and behavioral health professionals have already probably sat down and gone through this process of looking at this diagram, this framework to say, how can we divert individuals with a mental health illness into behavioral health and out of the criminal justice system? So I really like to use this as a framework for individuals with substance use disorder, because I think the same theory is there. It's traumatizing to be in the criminal justice system. It's not therapeutic and it's not effective. So this framework in itself is really about identifying those intercept points. So the first intercept you see there is pre-arrest. It's what happens before we enter the criminal justice system. Intercept 2 is once we enter it, it's then considered post-arrest. And then you have intercept 3, which is court and jail. Intercept 4, which is reentry. And then you have intercept 5, which is probation parole. So what I'm going to talk about first is intercept 0, which actually wasn't on that framework. And so you probably are already familiar with some of these harm reduction strategies. So on the previous slide, it didn't mention intercept 1 or 0. It started with intercept 1. But on some diagrams that we see, there is recognition that intercept 0 is the ultimate diversion from the criminal justice system, in which we put behavioral health strategies first. We frequently see this through crisis intervention training. I'm not sure if you guys have that in Rowan County, but getting your law enforcement officers CIT trained can be very advantageous in helping them learn how to communicate more effectively and connect people with substance use disorder to services. And so, as I said, these harm reduction strategies really happen outside the criminal justice system. But the first one here is the Good Samaritan law and naloxone access. We have found continually in communities that people have forgotten about the Good Samaritan law. And so if you have any opportunity in which to educate your participants, your clients, your neighbors, your friends, people that you go to church with, any young people, please remind them that this law is meant to encourage them to call for help. And then, of course, syringe exchange programs, which we'll briefly talk about, and then EMS take-home kits. But the Good Sam law was passed in 2013, and it really is about encouraging people to call 911 to report an overdose. So it does provide that immunity from being charged. And then there's also a really cool website for the state of North Carolina, naloxonesaves.org. I encourage you to share that with as many people as you can, because you can actually go by county and find out which participating pharmacies have access to naloxone. And then, of course, if you ever have anyone who is at high risk for overdose, you can certainly call our organization or even Queen City, and they can help someone access naloxone too at no cost. So syringe access services, I'm sure you're all familiar with this, passed in 2016 in the state of North Carolina. So there's a lot of benefits that come with syringe exchange. Do you have it in Rowan? If anybody wants to give a thumbs up. Yeah. Okay, great. Yep. And so I will just say here, if you have any opportunity to continue educating law enforcement, they do seem to at times in some communities have a gap in understanding what this law is and how it protects people. And they know less about the benefits of syringe exchange. So, you know, syringe exchange is a phenomenal gateway to services and really does a great job connecting individuals who are facing a lot of barriers accessing services within the community. This third one for Intercept Zero is EMS take-home kits. I think this is a really innovative program where you've got this gap that individuals do not want to be transported to the hospital. And we have to be realistic about why people wouldn't want to be transported. You know, there are times when there's negative experiences with medical professionals. Maybe they went to the hospital last time and they were treated really poorly and they felt judged and they didn't feel that compassion that is so necessary. So that's really going to thwart someone from wanting to be transported again. So we have a lot of EMS communities who have really tried to fill this gap by leaving a take-home kit on the scene of an overdose. And so maybe there's a friend or a family member that they can teach them how to use the naloxone kit. And then, of course, provide a resource material guide in that kit should the person want to explore treatment options in the community. So I just think that's a great idea if you've got some EMS support there. Mm-hmm. The next Intercept is that first one that you saw there in the framework, and that's Intercept 1, which is pre-arrest. So I just want to mention a little bit about post-overdose response and then pre-arrest diversion and the framework of the LEAD program. Now, post-overdose response is a great opportunity to really connect individuals who are already at risk for overdose. And what we're finding is that this data sharing piece is really lacking. And so if you have outreach specialists, or you have peer support in your community, really encourage them to connect with law enforcement and try to get that information from them, that public record information about where and when overdoses have occurred. Because conducting that follow-up really gives them that opportunity to develop that personal relationship that we so commonly see through syringe service programs and trying to make that connection. Now, these follow-ups are typically done within about 24 to 72 hours. And what I have found when I'm working with law enforcement is that they don't know that no one else is checking in. I don't think it's a conversation that's really been had. So when an overdose occurs and EMS is called and law enforcement is called, no one else is getting that information. And so what that does is it leaves a really big gap in which we've lost an opportunity to share information to connect someone to services. And so this is one thing that we find with the compassion fatigue is when first responders are telling us, well, we continue to respond to the same person. Well, the question is, what have we done differently? Have we shared the information with peer support or outreach specialists so that they can connect with these individuals? The second program within that pre-arrest Intercept 1 is LEAD, and this is pre-arrest diversion, really utilizing officer discretion to divert low-level drug offenders and sex workers from the traditional criminal justice system and link them into treatment. This, of course, operates within a harm reduction framework. And what that means is that we're connecting them to case management, peer support services. We're not leaving them with this expectation that, hey, call somebody next Monday, see if you can get in, see if you can fill the paperwork out, et cetera. It's really just navigating throughout the entire complex system of treatment and really giving them options about what they may be interested in. It's really understanding that no one size fits all. Some individuals maybe have already tried inpatient. They felt stigmatized by it. It wasn't the right fit for them. They may not know about other options. And so we really want to make sure that we're sharing all the information about local resources or even regional resources for them. And so what's neat about the LEAD program is that really is different depending on the community in which it's residing. And we have 7 of them here in the state, and it is a national model. Depending on which community it was developed for a different reason. We have Seattle, Washington, for example, originally designed their program to address racial disparities in drug arrest. Santa Fe, New Mexico was interested in reducing property crime. Atlanta, Georgia was interested in working with their businesses that were experiencing high call volume in certain areas. And a lot of the sites here in North Carolina are really interested in it as an opioid response strategy. And so what's really neat about it is the officers making that direct connection to a case manager. They're not simply telling the participant, call them on Monday, here's a business card. It's literally, let me take you and connect you to the case manager, and let's see if we can get this personal relationship established. So it's really helping communities overall. We're seeing an increased number of individuals participating in harm reduction services and treatment, and we're also seeing reduced criminal justice activity. And so I mentioned that within the LEAD program, we have case management and peer support. Here's just some examples of the work that they do. Of course, case management is going to do that immediate individual intake and clinical assessment, help with the referral to services. And then outreach peer support really promotes those harm reduction strategies, utilizes motivational interviewing, and provides access to naloxone, safer sex supplies, syringe supplies, and really helping identify those barriers and untreated health conditions. And so the majority will have lived experience. So it's really about making that connection and helping them navigate through the process. Now, Intercept 4, I think this one is really neat because there's a lot of new initiatives that are coming down the pike, and we're starting to see a lot more jails come on board with some really innovative strategies. So the first one is jail-based overdose prevention education. We have those in quite a few jails here in North Carolina. And then also the naloxone upon exit, making sure that as they're exiting the facility and they're at risk for overdose, they have naloxone already with them, and also providing a linkage to care either before they get out of the facility or immediately thereafter. And so what's really important about this jail-based prevention education and naloxone upon exit is that a North Carolina study of jails said that individuals, inmates, were 40 times more likely to experience death from an overdose than the average citizen. And this was within the first 2 weeks of their release. So this is a really significant number, and it really told us that we need to try to work within these facilities to make these connections to care. And so what we do with the jail-based education program is providing a harm reduction, whether it's talking about where to get naloxone, how to use it, how to recognize an overdose, the different types of naloxone available, where syringe service programs may be in the community, how they're beneficial, where to get HIV, Hep C testing in your community, and really just talking about some wellness topics too, and really trying to figure out how can I support the group that's in front of me. What's interesting about these programs is many participants will continue to come back because they want to continue the conversation. Maybe they want to talk about some of these wellness topics, which could be resiliency skill building, or maybe they had some questions about stimulus use and risk of overdose, so they weren't really, sure what the responses were for that. And so if you have some relationships with your local jail, I encourage you to see if there's an opportunity to provide this education. We actually have a standardized curriculum that we've developed that we're more than happy to share with any community that is interested in it. And so when the individuals come and they take the class, we just jot down their name to make sure that they get a naloxone kit in their personal effects, so that when they leave the facility, not only will they have the naloxone kit, but they'll also have a packet on community resources. And in some of our programs, we have the ability to provide linkage to care. And that's really about making that first step and supporting them. We know so many people exit the jail and there's no one waiting for them. There's no job opportunity. There's, limited or non-existent transportation. Some of their personal relationships with their friends and families may already be a challenge for them. And so really helping support them as they navigate this reentry process can be really helpful. And so much of what you guys have learned through today on the resiliency skill building, I think would play a really good part for it. And so really just understanding overall the complexity of what first responders specifically, and also treatment providers, are working with, and how we can help select and identify and then implement strategies within the unique communities. And so obviously complex drug addiction and mental health issues are there, chronic homelessness, alcoholism, associated social issues with that, and then severe mental illness. So what I'm trying to say is that the criminal justice system is really handling a lot at this point. And a lot of these are behavioral health conditions that really should not be served within the framework of the criminal justice system. And so it's really up to all of us to try to navigate this and develop relationships in which we can access individuals who are unfortunately in this criminal justice system, because it's like I said earlier, it's not therapeutic. It's going to be very difficult for them to experience any positive change. But at the same time, the criminal justice system obviously is overwhelmed. And so they're not going to be able to do the most effective job that they could do, or that a service provider out there in the community is going to be able to do. And so just let me give you some ideas for public safety and public health partnerships, really thinking about what data can we share. Like I said earlier, the post-overdose response, there's a lot of information there that has the potential to be shared. Really just sharing your substance use information with other professionals, to include first responders. A lot of them don't know where this information is. If you have a youth behavioral survey, that's always really important to share also. But really thinking about who are those partners who are already at the table, and how can we share more information with them to develop strategies that would work specific to our community. And really talking about skill sets and working within wheelhouses. A lot of times we're siloed and we're not sharing information, and we're not developing partnerships together. But everyone has their own skill set, and it's okay to say, I don't know the answer to this, but I know a great case manager or peer support person who really could help with this individual or help design this program. And then remembering that first responders, they're out there 24/7. So they know this population and have the ability to make referrals for care. But if they don't know what those referrals look like, how to do it, what the services are, we're not really going to get anywhere. And then that compassion fatigue is going to kind of rear its ugly head. And then I always encourage communities to use that sequential intercept model just as a framework. It really helps to encourage partnerships, bring everybody to the table, kind of figure out what do we already have going on, maybe using that menu of local actions, and then having a discussion to say, hey, the state recognizes this is a best practice. Is this something that's feasible for our community? And then always teaching. So much of what Ashley said earlier, I would love to just put in an envelope and share it with every law enforcement officer I get in front of, because so much of it is what they need to hear. We can't assume that they know what we think that they know. And so always having an opportunity to share that information, because they are working with this population. And that could be what community-based services are available, or just learning how to talk with people, maybe even understanding more about how resiliency is a key factor and why people use drugs. And so one thing that's really seemed to work in a lot of communities is having a lunch and learn. I mean, food brings everybody together, right? And so if you had a community organization that you wanted your partners to know more about, I would encourage you to have a lunch and learn, and maybe do that training session on stigma reduction or resiliency skill building. And of course, I'm always a fan of teaching, the judicial officials. They're the ones who are making decisions, and they do not get a lot of education opportunities to really learn about substance use disorder and how it affects people's lives, and how difficult it can be to overcome. And that recovery looks different for everybody. And then of course, there are detention officers too. If you have any programs within your jail, or you're thinking about implementing them, a lot of the detention officers also don't have the benefit of this type of education, and they can serve as a really good referral source for you. But you really have to find those champions within these agencies and then provide the training. Okay, so I feel like I probably did some serious speed talking through all of that, but I know that time was kind of limited. And so I want to open it up for questions. And then here is my contact information for you. And then the North Carolina Harm Reduction Coalition website has a lot of good information. It's been kind of under development more recently, but there's still a lot of information that you can learn about different harm reduction strategies.
Melissa, thank you for the great information. I also would like to, and they already are involved to a degree, the North Carolina Department of Public Safety, the probation officers.
Oh, yes.
If they get this information, we get a lot of referrals from the probation office here in Rowan County already and statewide as well. But for them to get this information, they would see the importance of educating the offenders that are on probation to take that time and use it to the best benefit, getting educated themselves. And I always talk to Ashley about pre-overdose education, and she definitely gave us some great information today. And I know that everybody is super busy and overwhelmed, but I really believe that the probation office, their officers would be willing to be informed to help their clients.
I think that is such a great idea. And prior to COVID, we actually had some solid conversations with Department of Public Safety, and they did want to do some harm reduction training with some of their, I forgot their titles now, but let's just say their district managers, for example. And then what their plan was is to trickle it down to the probation officers. And I think that that's something that definitely, needs to come back to the table. And I would be happy to come, and if you could orchestrate a meeting, be happy to come and do any of that harm reduction education training with them, because they really are working with the justice involved population that can be high risk for overdose, probably have childhood experiences and trauma that is, unidentified or untreated at this point. And I think that they're a great group of professionals that need this education. So not only for themselves and their decision making, but also to teach their offenders about, like you said, the risk of overdose and how to protect themselves. And I'm really hoping in the future we're going to see some changes with probation where these technical violations for substance use are not going to be so prevalently used, because that really is creating quite a vicious cycle. And when we're talking about mass incarceration and we're talking about what happens inside jails and prisons, it is not always good, right? And people come back out into the community and they're suffering even more than when they came in. So yes, thank you for mentioning that.
And I think that would have to be at the state level, not local, because it's a state program. So I don't have a contact for a state person, but I know that one of the supervisors here would be very interested. He's very pro treatment.
That's great. That's great. Yeah. And I do still have that contact from before that had asked me to do training, but then COVID came. So yeah, I could certainly connect back with her, and you could connect with yours and just say, hey, if you have any contacts up above, we can certainly make this happen.
Great. Thank you, Melissa.
You're welcome. Somebody have their hand raised. I can't see any names. Yes, go ahead.
I just wanted to say, Melissa, thank you so much for sharing the information that you did. And if you ever need any help, I would love to connect with you more, just be a partnership if we could. And if you ever needed any assistance when you're educating, or just life experience, or just to sit down and talk more, I would love to do so. So I'm going to take your email and I'm going to send you an email.
Yes, Ashley, I would love that, because like I said, when you were speaking, I was like, oh, I just want to put everything into a glass jar and take it into that training environment and really get them to understand that this is not easy, right? This is complex. And one of the challenges is when someone's engaging with law enforcement out there in the community, law enforcement probably has about 20 minutes max, right? And they're problem solvers. But when they start asking questions, which can be stigmatizing or traumatizing to somebody like, oh, why are you using drugs? Don't you know that's unhealthy? That is not going to be productive, right? And so it's about trying to teach them, how do we have these conversations? But even before we get there, it's about helping them understand why people use substances, why people are using it to cope, why they have chronic health conditions, and this helps them, or underlying mental health issues, and this helps them make them feel more normal or balanced. So it's a hard journey to try to get all this packed in to training when we're training with them. But I think the personal stories are where it's at, because it's real. And it's something that they don't get an opportunity to hear very often, which I think is not good.
Yeah, no, I agree with you. I think it's so important for them to hear. I've gotten to do a little bit of CIT training where I was able to share more of my story and kind of what was going on behind the scenes, because I wasn't a bad person. Was I doing things outside of what I feel like my natural character was? Absolutely. But because I was in that fight, flight, or freeze response, and I understand that the police, they have big hearts, they're doing the best that they can, but simply do not have the information, that they need to be able to help in the capacity that I believe they want to help in. And so, like you said, they're being quick, they're doing what they know. And I've experienced on my own end and seeing participants encounters with the police, where the just stop it mentality's in there. And it's simply, like you said, there's so many things that are going on behind the scenes that they're just not aware of.
Yes. And they don't know, they don't understand either, that whether it's drugs, drinking coffee, having too much sex, driving too fast, whatever it is, it's all the same, right? You just can't stop. It's like, if you told me today that was my last day of coffee, I'd be like, what? I really need my coffee. And they're just not equating it there. And I think sometimes they're thinking about legal versus illegal, and that's kind of what sticks in their head. And I don't mean to criticize, please don't think I ever criticize law enforcement, as I've 16 years working with a law enforcement agency. I just understand where they're coming from. And I also try my best to understand where harm reduction is coming from, and how we can meet in the middle.
So closing is actually supposed to be 2:15. So we've got time. And Melissa, we killed it. We did it quick. You killed it. You went so fast. I took up all my time. But
oh no, yeah. Miss, let's see. I don't know if it's Grant, has said yes. She's a stepping up coordinator. Fantastic. Yeah. See, and the whole Stepping Up initiative, if your community has not been able to utilize that experience to do that sequential intercept mapping, I really feel like you can do the same process for substance use disorder and really figure out where those gaps are. And Pitt County is doing, I forgot the name of it. They have some education, I think, that's occurring inside the facility with the local community college. And then they also have, I think, peer support specialists that are within the facility, which is great for reentry.
So I have an idea of what we could do with the rest of our time. So clearly we are all in here because we care about what's, the treatment track and things of that nature. Would anybody like to trade information or set up a point of contact for each other where we can work together? Or does everybody pretty much know each other around here?
Ashley, can you hear me?
I can hear you.
This is Kay. How are you?
Good. How are you?
Okay. I had to call in. So my thing was, and what I was trying to say, I didn't know y'all couldn't hear me the whole time. I apologize. I worked with all entities, as I've worked with on a federal level as a contractor at McLeod's Overentry program. I've also been an officer on the state level. And now I'm here in this particular atmosphere at the detention center working with the same group of individuals. And I do feel like it does need to be a local as well as a statewide thing, because a lot of people, like you said, lack of knowledge. If you know this information, it can improve who we're working with and who we're trying to target and who we're trying to assist. On a state level, it starts in the prison. You can't, I mean, well, actually it starts local, then it goes that way. But those officers aren't trained to that capacity. Yes, we get CIT training. They have refreshers, but the refreshers aren't deep enough in depth with the information that would help improve prior to the person coming out. Then if you do rearrange how you're violating your offenders on your probation caseload, that will also, because I feel like it's too petty. They're easily overwhelmed with the large caseloads and can't really take the time they need to see what could they do different to better assist. Now, you do have some dedicated officers that's out there that know and have recognized the same kind of behaviors and the same kind of information, all this stuff, but it's not enough of them. So the information that Ashley shared, I hear Ashley, I talked to Ashley, we work on the same organization with each other. We do need people that can be that voice, can be that example, because it's only going to strengthen and make it better for these individuals coming out. We don't have enough programs in the prison systems. They used to, but I believe COVID has caused them to have to slow down how they offer the classes and the programs in there. And so it's not helping. And then the communication prior to them releasing and coming out on probation is no better. And then even leaving on a local level as well. But I know our program and how they've structured it, it's been here for almost over 3 years now. It has definitely improved as we've built so many relationships with entities involved, not only just the courts, not only probation, not only on stepping up, but or a state level as far as prisons, but the surrounding communities, the other programs that are available out there. I've even touched base with people that's out of this state, but there's too much out here, but not enough people getting this information to help. The officers, you're correct, because I was in school to be an officer. And that information, it has to be reconstructed, because if they had this or had someone such as Ashley, I'm gonna use you and I'm gonna pick on you because you're awesome. If they had someone prior to the end of that training, because they have added more hours to CIT, but if they had like maybe an opportunity for someone who could come and present prior to them ending and switching over to the next subject, that would be beneficial, even on a county level, because they do these kind of trainings. They have to have these things. We do too. Everybody has to, but on a different level and capacity. I really do think, though, it's just people have to come together, and Cabarrus County and Rowan County should have been working with each other a long time ago. Cabarrus County and Rowan County should have helped each other with the Stepping Up program. It should have never just been one county, because we're sisters and brothers, however you want to look at it. We're right here neighboring each other. And we get a lot of Rowan County people here, and it's not enough. It's just not. I know they are working on a Stepping Up program in that area, and hopefully that will thrive soon, because it would be beneficial. But then we still have to get the providers involved as well to make it a successful transition for you all.
Who's running the Stepping Up program in Rowan?
I don't know if Baymark is part of this project. I'm not sure. But I know Captain Hannell, who's actually running for sheriff. He's actually a DOET instructor. He had already had students that were at like Livingstone coming in and trying to identify these individuals to offer some help and services. And I don't know if he was behind pushing this, but that is recent talk. And I do know that that is going to come about sometime soon, because it's necessary and it's needed. It's past due, like a book.
Okay, thanks.
Do you
You're
think
welcome.
Sorry, Kate, do you think as they're undergoing that process and using Stepping Up for the traditional mental health disorder, do you think that they'll kind of have the same perspective while they're going through this and talk about substance use disorder also?
I hope so. I've noticed the difference that it brings about in our area and our facility, because we identify them spot on. We use the questions that they answer in booking. And by those questions being answered, I mean, even if someone's not being truthful at that present time, there's always that open communication with the officers and us to identify, say, hey, you know what, we do know this person, they're a frequent flyer. Yeah, they may not have answered correctly or said things that would have triggered you all to say, hey, they may need some assistance, but they do. Or we may get the reference from the family or someone in the community that may know them. So that open door is always there. So, I mean, at the end of, like I said, it just takes us sticking together and being able to listen and identify, because I always stress this out. What may work for one person may not work for another, but there's something out there to help regardless. Thanks.
Good stuff. One of the things that some of the jails are moving towards because of COVID, I think we'll see greater use of tablets inside the facilities. So if we can't get humans in there to provide the education, what's the next step, right? And so really kind of hoping in the next year, we're going to see a lot more use of that. And also the kiosk, it's about finding out what capacities your jail have. Do they have TV somewhere that you can put, a PowerPoint slide on there that at least puts the risk of overdose or how to get in the lock zone upon exit? Anything that they have in the jail. So it's always just about trying to learn what the jail capacity is. If you can't get a person in there, do they have technology in there? Do they have old school TVs in there? Like, what can we do? Can we have a packet at exit? So yeah, a lot of brainstorming can be had.
We do that here in Cabarrus, and I do actually, Miss Klingelsmith, she actually helped assist, and I have what they need to leave, like a Narcan or something upon exiting. They identify, we do provide them with that. But we do more than that too, because we don't only work with them in here, we work with them upon release too. So it's a continuing relationship.
That is excellent.
Well, I see the note here from Karen Jones South here from Rowan that we have not adopted the Stepping Up initiative. See, as a commissioner, I don't ever remember hearing about Stepping Up, and that's why I'm kind of scratching my head. But what I do know is that we are starting a reentry program, and I'm very thrilled about that. But we've just had our second meeting, so we've got a long way to go.
Well, thank you everybody for all the conversation there. That's really helpful to hear about what other counties are doing.
So I'm going to go ahead and give our two ladies for our last presentation their introductions. Courtney Meese, who is the coordinator. If I'm saying your title wrong, I apologize. I believe you're coordinator or program manager for Healthy Rowan. Okay, and then Amy, who is the wellness coordinator, health education specialist, and also my supervisor for the PORT program, and they're going to go ahead and start their presentations now.
All right. Ashley Creek is going to share her screen, the presentation for me. So just give her just 1 second.
And while we're waiting on that transition, come on. I just wanted to say thank you so much for coming and hanging in there. I know some people were floating in and out throughout the day. That's why I put so many gaps and spaces in between the presentations so that people could float in and out throughout the day. So I really appreciate you for coming, listening, and having these conversations with us. And I hope that we can continue this dialogue and really create something that's impactful in our communities. All right, I'm off mute. I'm on.
All right. So as Natalie said, my name is Courtney Meese. I'm the program manager for Healthy Rowan. So I am outside of my resilient zone right now, but we're going to work through this. So Judy and Kelsey touched a little bit on CRM earlier, and so Amy and I are going to finish this out. So we're going to start by going over some common reactions that people might experience whenever they're in highly stressful situations, or if they're being triggered. So highly stressful and traumatic experiences can have a major effect on our central nervous system and our autonomic nervous system. And as you can see in this slide, these are some common reactions. With CRM, we learned that there are 6 different areas of reactions, and those are thinking, emotional, physical, spiritual, behavioral, and relationships. So if you want to, and if you feel comfortable, you can comment in the chat box if you see a common reaction that you might experience, or someone that you know that they experience whenever they are having a stressful or a traumatic situation. If you see anything missing from any of these lists, if you could just drop those in the chat box. Natalie said isolation. Isolation is definitely a good one. I'm such an extrovert that one actually, isolation is a trigger for me. I get really stressed out if I'm isolated. So I think that's a great example of one reaction for one person might be completely different for someone else. Alyssa said eyes watering, crying. Ashley said upset stomach. Judy said sleep. Those are all awesome examples. Avoidance. Awesome. Thank you, guys. So now that we've talked a little bit about the different reactions people might experience, we can go into the 6 skills of the community resiliency model. Ashley, can you switch slides? Okay, that's fine. I can just talk about them. Oh, there they are. Okay, so there are 6 skills with the community resiliency model. And these are all skills that can help you get back into your resilience zone, like Kelsey and Judy talked about earlier. And so I'm going to cover tracking, resourcing, and help now skills. And then in a little bit, Amy is going to go over grounding, gesturing, and shift and stay. So we'll start with tracking, and tracking is reading sensations. So tracking is the foundation for helping stabilize the nervous system, is noticing or paying attention to what is happening inside your body at the present moment. So some of the language that we use in CRM, we don't want to say we are feeling something, we want to say that we are experiencing sensations. So determining if the sensation is pleasant, unpleasant, or neutral, and sitting and staying with those sensations that are pleasant or neutral. So if you're comfortable in the chat box, if you could just say, are you experiencing positive or pleasant sensations, unpleasant sensations, neutral sensations? I personally am in an unpleasant sensation because I'm nervous about this presentation. Karen said she's neutral. Amy's neutral. Miriam's pleasant. Terry's pleasant. Judy's neutral. Natalie is neutral now. All right. So next slide, please, Ashley. So when we learn to pay attention to the sensations that are going on in our body, we can connect those with distress, or we can connect those with stress. We can also learn to pay attention to the sensations that are not distressing. When we can focus on those sensations, we can widen our resiliency zone. So next, we're going to talk about resourcing. And resourcing is the best way to learn about tracking. It's able to identify things that bring you joy, happiness, make you feel comfortable. So oh, go back 1 second. All right, so resources can be any person, place, thing, memory, or a part of yourself that makes you feel calm, pleasant, peaceful, strong, or resilient. Resources can be real or imagined. Imagined such as a superhero, book characters, movies, or TV shows. A resource can be internal or external. Internal resources could be values, beliefs, your religion. And external could be people, places, skills, hobbies, or pets. So here's some examples. Next slide, please. On expanding resources. So you can see that resources can be smells that take you back to certain places or bring up happy memories. It can be sight, touch, taste, sound, places, people, traditions. So personally, for me, my resources are going to be my 2 dogs, Boone and Ranger, and my husband, Clint. And then, so those would be external resources. And then one of the, I guess it's still an external resource, but whenever I think about it, it brings me comfort. I think about driving on the Blue Ridge Parkway, and that is a resource for me. If I can sit and think about it for a while, I can get back into my resilience zone. If you want to comment in the chat box, what are some of your resources? That would be awesome. What are some examples of smell resources? So Amy Smith and I had this conversation the other day. The smell of coffee to her takes her back to her childhood with her grandparents. They drank coffee a lot. So that's an example of a smell resource for her. However, sometimes coffee for me can trigger me to think about cigarettes. My grandparents always used to have coffee on the pot all the time, but it takes me back to whenever I would visit them and they would smoke in the house. So the taste of burnt coffee for me makes me think of the smell of cigarettes. So I love coffee as long as it's not burnt, because then I'm constantly thinking about cigarettes. So Karen South Jones said the best dog in the world, Jessie, is her resource. Lauren said looking at trees, hiking, and Natalie's poodle, Cody. Carol said toes in the sand at the beach, and Judy said coffee, her dog. Grandchildren, Faith. Ashley Creek just said Christmas. I feel that one deep in my soul. Someone said their cat. Leslie said her dog and her partner. Those are all great examples of resources. So great job, everyone. All right. Next, we have some help now skills. These are some skills that can help you get back into your resiliency zone. If you're in a pinch and you need to do something right now. So we'll go over those, and there are 10 of those. So like I said, the help now skills, whenever you're out or you're in your high zone or your low zone, help now skills can get you back into your resiliency zone. So the first one is going to be taking a drink, a glass of water, tea, juice, anything like that. So if you have a drink around you, I encourage you, I have a bottle of water. I encourage you to take a drink of whatever that is. I'll do it with you. And so when you take that drink, think about the sensations that you're experiencing. What does the drink taste like? Is it coffee? Is it burnt? Did you put creamer? Is it sweet? Is it hot? Is it cold? What sensations are you experiencing whenever you swallow it? Is it pleasant, unpleasant, neutral? So that skill can be, Miriam said coolness. So that skill can help you get back into your resiliency zone. The next one is going to be touching a surface and really trying to explore what those sensations feel like whenever you're touching that surface. So if you're at a desk, you can put your hands on your desk. Is the desk hard? or if you're on the couch, is the couch soft? What does it feel like? Is it squishy? Is the desk cold? Is it pleasant to touch? So really feeling the surfaces that are around you and what those sensations are like. Taking a look around the room or the space and paying attention to anything that catches your eyes. So right now I'm seeing a picture of an acorn on the wall, and the acorn is green and it's very pleasant to look at. So finding something that catches your eye. The next one will be name 6 colors that you see right in that moment. So take a look around the room. There's a red shirt, a brown desk, a black chair, a blue bin. Ashley's dress is like a peach color. I lost count, and there is a tan door. So really paying attention to things that are around you that might be able to bring you back to your resiliency zone. Counting, I'm sure all of us have heard about counting backwards from 20 to get back in your resiliency zone. That was a CRM skill that I bet you didn't even know was a CRM skill. And you've been doing that forever. What is the temperature in the room or the space you're in? Is it cold? Is it warm, hot, cool? Is it pleasant, unpleasant? So again, paying attention to your surroundings and external stimuli. This one could, depending on your situation, could be helpful. Noticing the sounds within the room that's around you. Be careful with this one, because if you are in a space that is stressing you out and there's loud noises or slamming doors, this might not be the skill for you in that moment. So really, these skills are really going to depend on where you're at, who you're with, what's going on around you. Taking a walk around the room and noticing what your feet are sensing whenever you're making contact with the ground. And I encourage you to do that anyways, because it's something that you probably have never even thought about. And then pushing your hands back against the wall. So taking your frustration out and pushing up against the wall and pushing all of your weight into the wall. And what does that feel like? Okay, so Ashley Creek is here with me, and she just told me that this might not be a skill that's best for someone that has experienced incarceration or possibly some physical trauma. So again, some skills work for some people, some skills work for others. All right, now Amy Smith is going to take it away with grounding.
All right. Just to re-emphasize that, as Courtney just said, CRM is definitely a tool about being able to place ourselves back into a positive or a neutral place whenever we get bumped out of our resilient zone. So these skills that we're discussing with you right now, some may work for you, some may not work for you. And the more you get to know about it and allow yourself to get to know about yourself, you'll find ones that will definitely work for you. And sometimes they may not work, but hopefully by discussing these and sharing with you the 6 wellness skills, you will pick one or pick a lot of them that will work with you. But grounding is the 4th skill that we will talk about. And what grounding is, it's the direct contact of your body or a part of your body with something that provides support in the present moment. When we're grounded, we have a sense of self and relationship to present time and space. So anything that we're worried about from the past, or like an upcoming event or a test or anything like that, it allows us to stop thinking about that and just live in the moment, the present moment. So as you can see from this slide, you can ground in many positions. As Courtney shared with you, I guess a lot of us have not thought about when we're walking. It just comes so natural to us. But sometimes grounding can be just walking and realizing that your feet are touching the ground and paying attention to your steps. I know yesterday, as we were preparing for this presentation, Ashley had shared with us that she loves to run, and she uses running as a form of grounding because she allows herself to realize where her feet are hitting the pavement, and it helps her, get back into her resilient zone. Also, laying down on the surface or floating in the water, standing against a wall, sitting on a chair or a sofa or the ground, and also through a part of your body like your hands or your feet. The only thing with this one particular CRM skill, you should proceed a little bit with caution until you get to know the group that you're working with a little bit better. With this one skill, some children and adults who have experienced physical and emotional trauma may have difficulty with the skill such as grounding. For some children and adults, grounding can increase sensations connected to trauma memory. If they've had to sit in a closet, or if something more traumatic has happened as they're laying down, or if something has been forced on them, this may not be the best skill to use with that group, but just as a precaution. The fifth wellness skill that I'll talk about a little bit is gesturing and spontaneous movement. And gesturing is a movement usually that we are not even aware of that we do with parts of our bodies or limbs. As the slide shares with us, it sort of expresses or emphasizes an idea, a sentiment, or an attitude. It's sometimes, if you think about a gesture of joy, strength, or confidence, what it may look like. And we use those here again when we're not even thinking about it. If someone brings us joy or comfort, or if we're in a neutral or pleasant place. And from this slide, you can see different forms of gestures. And when we went through the CRM training, what is so funny is our CRM trainers shared with us that no matter where they go around the world, no matter who they present to, although we don't speak the same language, a lot of times our gestures do speak the same language. And that they see that whether they can understand the actual language of that country or not. So from the top, you can see the little girl, just the feeling of release, just exhaling maybe. Sometimes when people get too close, we talk about our personal space, you can get a little protective. So sometimes people will actually let you know through that gesture that, hey, you need to push back, or you're getting a little too close, or something like that. We can also see from the girl who's jumping with the scarf, joy. There are other forms of joy as well. And then you also have self-calming. One of the universal spiritual gestures is prayer. And a lot of times people will use their hands folded together or together, as you see in front of you, just as a form of prayer, no matter what their religious background is. And then also just powerful, like the high five that the girl is giving to another girl. I know, I remember the dab that Cam Newton did with the Panthers. That was a form of gesturing that showed like, yeah, we're rolling right here on the field, or we just made a touchdown. So you see it in different and numerous ways. Sometimes when you are using the gesturing, you yourself will actually notice that someone is entering that resilient zone, that they feel pleasant or it's neutral. Like the picture shows in front, they are maybe turning their wedding ring, something that brings them comfort, something that they can associate with the resourcing out, maybe feeling comfort with that person through that ring, whether their spouse or significant other is there or not. It's a soothing gesture that can be called to mind by intention to help get back to a resilient zone if bumped out. And one of the things that I always find myself doing, whether a baby's crying or not, is my first child had colic for 3 months. And so it was a rough 3 months. As Judy was talking about, any of us who've had children, we've experienced that somehow. And by sort of doing a soothing bop on his bottom, it helped. And so I find myself, every time I hold a baby, I automatically do that now. And it brings me comfort, whether it brings the baby comfort or not. So something that, and I'm not even aware I'm doing it until after I've been doing it for a while. So I've caught myself doing gesturing myself. And also encouraging the person's curiosity about self-comforting gestures in another way. It also reinforces that person's ability to inherit resilience. And the last skill and the final skill is shift and stay. And shift and stay actually means that you find a skill that you're comfortable with. It may be one, it may be a couple of them, and you're able to shift your sensations onto that, not your emotions, but you're able to figure out what you're what's going on inside, and you are able to stay in that area so that you can avoid unpleasant reactions, maybe that you're experiencing because of an experience or something that brings you back to a traumatic time. And with that, you can shift by using one of the 6 CRM skills that we introduced you to today. Shift and stay integrates all 5 wellness skills that we've discussed. And so you can see tracking your sensations and being able to notice them is a huge part of this particular skill. And as you will find out, tracking is the center of shift and stay. So we wanted to sort of share with you, well, hold on, let me go back for a second. Learning the 6 wellness skills helps people realize that many of the reactions to stress and trauma cannot be talked away. We've all experienced trauma one way or another, but we can sense them away and we can overcome our trauma. People realize that their symptoms are all about biology and not mental weaknesses. A lot of times, I think our communities and us as individuals, we're not willing to talk about mental health because there's such a stigma associated with mental health and being weak, and it's not. Our bodies do control us a lot, but then we also, especially through going through CRM training, we realize that we do have control over those emotions. And then this concept can result in a sense of relief and greater feeling of well-being. So just an easy way for y'all to think about the 6 skills that we have talked about since the very beginning of the forum is you have tracking, which is the center of your palm. And it's all about sensation. It's not what you're feeling, it's all about sensation. And then you have resourcing, grounding, help now skills, the gesturing, and then the shift and stay. So it's a little easy way of figuring out all the wellness skills, and they're right there in the palm of your hand. And it may help because a lot of times people do find comfort in, in their hands. So maybe it's something that you can count on and identify and be able to bring one of those skills into your life when needed. So before we have closing remarks, we'd like you to find a position and or place that you're comfortable with. And before you do anything else, if everyone could unmute themselves, we'll see how this works with Zoom, because I feel like if we ask you to chat, you're going to lose yourself. And here again, we ask you to find a position or a place that you're comfortable with. As a reminder, this may look different for everyone. So some of you may choose to walk around. We've been sitting a lot, but as you walk around, try to see what the sensation is as your feet are hitting the ground. Some may want to sit in a comfortable chair. Some may be at home still doing Zoom meetings and they can actually lay down on a piece of furniture or on the floor. And we'll give you a moment to sort of get yourself comfortable. And while you're doing that, we'll give you a beautiful picture of the North Carolina Blue Ridge Parkway going into Boone, which is a special place for Courtney and myself, but we all have special places as well. So as you're sinking into that chair, or you're leaning against that wall, or you're laying on the floor, notice how your back is making contact with the chair, your sofa, the floor, the bed, or just the earth in general. If sitting, bring attention to your seat. What does it feel like? Is it hard? Is it soft? Do your legs hit the floor? Do your feet hit the ground? What does that make you feel like? Notice the sensations that are more pleasant to you or neutral with your body. If you experience something that's not neutral or positive or pleasant, feel free to find a new place or shift your weight. Is your breathing becoming calmer? Is your heart rate going down? Would anyone like to share with us what you're feeling right now?
I'll share.
Okay, thank you, Natalie.
So I am standing up in this conference room, and I decided to take my shoes off to do this grounding exercise, which made me feel at peace, because me with my shoes off on carpet makes me think about my apartment, which is a safe space for me. I'm introverted and I like being at home. So it just made me feel really calm. I got sensations of chills on my arms and shoulders. I started to notice that my breathing got deeper and just more. I just felt more overall at peace, and that's pretty much how I felt. And then I'm just still noticing the feeling of my toes on the carpet as I'm wiggling them, and I like the roughness on my toes, and it's kind of warm. It's warmer than the slides that I had on, so this is comforting. But those are just the only things I noticed.
Thank you. Courtney said she's sleepy, and Miriam said peaceful. Jenna said relaxing. Anybody else would like to share anything? Judy said calm. I think I feel the same way, but then I also know that we're finished with the forum, so that brings me some peace as well. But I think as we're coming to the end of our forum, those of us who've gone through CRM, as Courtney shared with you and as others have shared with you today, I think a lot of us have done CRM before. As Courtney said, counting from 20 backwards. I did that with my two children. I was very blessed. They were not bad children, but some days they push your buttons. And so I was actually doing a CRM I would count to 10 instead of counting from 20 backwards, but actually doing CRM wellness skill, and I wasn't even aware that I was doing it. And so we wanted to make you aware of more information and resources about CRM. There's different ways to get in touch with the Institute. They're on Facebook, on Twitter, but also if you'd like more information on CRM, about a presentation or how to be trained in CRM, please feel free to contact Courtney. She is our Healthy Rowan program manager, and her healthyrowan.org is Alyssa also put down if you want to contact either one of them. And we would definitely be able to put you in touch with people throughout Rowan County, because we have had 2 CRM trainings. So we have numerous people in our counties and throughout different agencies that have been trained. I think at this point, we'll turn it over to Alyssa, who will be doing our closing remarks for today.
Absolutely. Well, first and foremost, thank you, Courtney and Amy, for leading us through that activity. I think that was wonderful and a great way for us to close out today. For the many conversations we've had about resiliency, about trauma, about what we can do as a community. And hopefully you understand and can take from this some of those skills and think about how we can apply those skills in everyday situations to help really democratize mental health and support those individuals and all of us really in the community who might be experiencing addiction or experiencing substance use disorder. So again, thank you all so much for joining us. It's been a long day, but I feel like it's been a very busy and great packed with lots and lots of information. If you don't mind, as I close us out, if you'll add one thing in the chat that you learned today or something that you're going to take and use as you go off into the world and back out into your community and back out into our community. As a reminder, and I guess I introduced myself a little bit in the beginning. My name is Alyssa Harris, and I am the Rowan County Health Director here. So substance use is one of our priority areas according to our community health needs assessment. And we know substance use, mental health, healthy lifestyle behaviors are all going to be things that we'll be focused on, and we have been, but we'll be focused on moving forward in the upcoming years as we see more of what happens as a result of COVID and the pandemic and how that impacts our community. So again, if you're here with us right now, if you're, during this closeout, if you'll just add something in the chat that you enjoyed, that you learned, or that you're going to use moving forward, we will be sending out an evaluation for this process. So we really, really ask that you take that seriously and provide that feedback for us, because next year will be our 5th annual Substance Use Forum. And so we're excited to make it even better than this one, although I think this was fantastic and really, really glad we had it. So over the last, 4 or 5 years that we've been having substance use forums, we started from a very high level. It started from that perspective of a leadership forum that brought together county commissioners, it brought together the county manager and our local municipal leaders, our mayor, to have the discussion as what was going on with opioids in our community. The following year, still calling it the Opioid Forum, is when we brought on Sam Quinones, I think is how you say his name, to have that discussion about how opioid addiction affects communities. We also had a panel to have folks kind of discuss their impact or the impact of opioid use on their lives. 2 years ago, we were able to have that discussion on pregnancy and substance use and the impacts to families and children. So we transitioned the idea of a substance use forum instead of an opioid forum. So really broadening that perspective, understanding it's not just opioid use, it's a much broader discussion that needs to be had. And then bringing it today to this discussion of resiliency and how resiliency impacts treatment, it impacts prevention, and it impacts recovery. And what we can do within our agencies, within our spheres of influence for making that impact larger and transforming the culture of a community and fighting stigma as we work to really support our own mental health in this process. So thank you again so much for your time, for tuning in. I love that we were able to come in and out as needed. We all have very, very busy schedules, but I appreciate you setting aside time to think through this process, to think about the things that were brought up today. You know, and I do really appreciate the CRM skills. I think we'll be seeing that integrated more into our school system, into our different agencies as we move forward, because that is so, so important to help our kids and help everybody get their resilience, grow their resilience zones truly. So I just also want to take a moment to say how proud I am of Natalie, of Ashley, and of Amy Smith for putting this forward and really all the work that went into this. Thank you all so much. Those are the leads in our port team, and we appreciate their passion for addressing substance use in our community. So I won't keep us here any longer, but we were looking forward to being able to share out with you all as a group, as a collaborative. And if you have any questions, concerns, thoughts, that energy and momentum that you want to share back with us, please reach out. This conversation doesn't stop here. It continues, and we put those actions behind words as we move forward into the community. So thank you all, and I hope you have a great rest of your afternoon.